Session is on basics of pediatric trauma. This session will be conducted by Dr. Premal Naik and Dr. Taposh Talukdar. In this session, we will deliver two topics. One is on how fracture in children are different, and then X-ray workhorse of pediatric trauma. May I request Dr. Premal Naik sir and Dr. Taposh Talukdar sir to come forward and conduct the session.
Thank you very much for having us again for pediatric trauma meeting. On a lighter note, I would like to say to Sarwar that IFICS has never faced a competition like this before in the history of 11 years. Because here we have three, Sandeep, me and Taran, and there is a Shah Rukh Khan just across the hall. So people who are not very much interested could go on the other side. But we'll try to see that you all remain here and we can have a wonderful meeting. So I think without wasting any time, I'll ask Dr. Tapan Talukdar to start with this talk, please.
Thank you, sir. Welcome to IFICS 2023. Respected teachers, delegates and dignitaries. Today I like to start our first session, today's session, sharp at 8, and without saying anything more, I like to go to the session first. Thank you so much. To invite Professor Sarwar Ibn Salam sir to say something about how fracture in children are different. Professor Sarwar Salam sir. Thank you.
Good morning. And I forgot one rule. There are 3 hand mics. If anyone wants to talk, please go there. Please go there. And stands, fixed mics. So, little story about the IFICS. IFICS started in India by these young turkeys, my friends for 15 years. They have been my friends, philosophers and guides. Their first IFICS was participated by only, I think, below 40, Sandeep. And the next one was 400. I attended the 400 plus Pune thing was. And now it is one of the most comprehensive trauma course in the whole world. So let's start with my talk. So we all know children are not small adults. How it is different? We are going to learn how the pediatric bones are different, how pediatric fractures are different, the etiology, epidemiology and risk factors, different pattern of fractures and differences in healing. In comparison to adult bone, the changes are, these are less dense, more porous, more vascular, lower modulus of elasticity, lower bending strength, so fractures easily, lower mineral content. And this increased porosity decreases the incidence of comminuted fracture, which is more common in adult bone. Pediatric periosteum is extremely strong and thick, and which helps in reduction. Sometimes it is even not needed doing any reduction. Maintains fracture alignment and helps in healing. The etiology, sports injury is one of the common motor vehicle accident and falls. Like countries of this Southeast Asia and more in summer, they used to go and pick fruits from the trees. So we get so many falls and fracture. Child abuse, less common in this part of the world. Stress fracture for older children and younger adults. There are stress fractures, and we find so many pathological fractures. Congenital pseudoarthrosis of tibia, aneurysmal bone cyst, simple bone cyst, fibrous dysplasia, infection, osteopenia, and so on. And there are some genetic conditions causing fracture like osteogenesis imperfecta. This was a study in a Chinese center on 10,500 children over on about 14,000 fracture. They found distal humeral fractures are commonest with around 27.5%. The epidemiology is a little different in other parts of the world, but it was a big study for epidemiology, so I have given it here. And distal ulna, I mean the distal forearm, ulna and radius combines around 23-4%. So distal forearm and distal humerus constitutes more than 50% of pediatric fractures, and this is common in most of the studies where it has been done. And the risk factors are low socioeconomic condition like ours, obesity like in the West, and all of families of this continent, summer season. It's true for the Western countries because they can go out in the summer, they can't go out in the winter, and it is true for our country because they go to pick fruits, mangoes and all those. There are some daredevil children who are used to take risk. They have these fractures, osteopenia like poor nutrition disorders, sports related fractures, recreational play devices, less in our areas of the world like scooters and roller skates, and motor vehicle accidents throughout the whole world. And the pattern which we are going to tell you about, every pattern which we don't find normally in the adult population, like this plastic deformation, buccal fracture, brenistic fracture, complete fracture, which is again we get in adult, and fascial fractures. There are other fractures too, like birth trauma, pathological fractures we have already told. Plastic deformation. One of the things we usually do not get in adult bone. The bone is angulated beyond its elastic limit, but the energy is insufficient to produce a fracture. No fracture line is visible, radiographically unique to children, and most commonly seen in ulna. And here we miss the Monteggia fracture or Monteggia lesion. Also in fibula, and bend in ulna is less than 20 degree in a 4-year child should correct with growth. I took these slides from Professor K. Wilkins' lecture. So what to do? If it is beyond the acceptable limit, we should go for gradual but constant pressure over fulcrum like this under anesthesia. And how long to keep it immobilized? That is 6 weeks, so that there is no recurrence. Now the buccal fracture, very commonly we find in radius. We all know about these buccal fractures. And or torus fracture. Torus is the lower end of the Roman or Greco-Roman pillars, widened part, and it's like that. You can see in the picture. Usually these are very stable type of fractures, and not always it should be plastered. Sometimes careful immobilization is enough, and takes about a month to heal. Brenistic fractures, we have learned in MBBS curriculum. One part is fracture, and the other cortex is having plastic deformation. So there are many controversies what to do and what not to do. Sometimes there is a rotational component here too. So according to Professor K. Wilkins, it can be reduced, but the arguments in favor that it prevents the tendency for recurrence of the deformity if we reduce it, and against the argument against that is it may destabilize the fracture. Then you might need further things to do. So Will's textbook is telling that how much is the acceptable alignment. In infants, up to 30 degree may be accepted, and we should consider reduction with completion of the fracture if it is more than 30 degrees. In children, up to 15 degrees is acceptable, and there is no need to attempt if it is less than 10 or something like that. So we can keep in mind that 20 degree will need reduction, and less of it will not. So complete fracture, I am not telling details. Spiral fractures, oblique fractures, transverse fractures, this is a fracture that we also experience in adult bones. fascial injuries, one of the most important pediatric fracture to be learned, to know, and we'll be knowing this thing. If you look at the picture and look at that SALTER, it is easy to remember. Straight across, so the fracture is through the growth plate. And metaphyseal fragment, so it is above. Epiphyseal fragment, it is lower or below. And it goes from metaphysis to epiphysis, it is T. And last one is compression. So there are many fractures. Whether this one is a fracture or dislocation, we have to know. There is a chips in Bangladesh. Whether that is a chips or biscuit, there is a controversy. Same is like that. What is this 2 days old? This is actually a distal humeral fascial injury. Let's see. It was like that. It didn't need anything except for some immobilization, and it healed well. Anything like this in elbow below 2 years should probably be fascial injury. Femur fractures, birth trauma, it heals very nicely. And what would be the take-home message from this lecture? Fractures in children are common. Children bones are different, fractures are different. We have to outline the principles of management, which are mostly conservative, non-operative. Specific treatment plans for each and every type of fracture should be outlined, and we should have specific precautions like avoiding infection and all those. And thank you, everyone.
If there is a time limit, just put a bell before 1 minute of the conclusion of the session. And I want to present some do's and do nots in pediatric orthopedics. We all know X-ray is the main modality of imaging technique in pediatric orthopedics, and this is necessary for classification, diagnosis, classification, planning and management. And every one of us, even pediatric orthopedic surgeon, should have some views, should have some knowledge of views, because orthopedic imaging, this subspecialty is not really developed in radiology till now in our country, and most of the X-rays are done by technologists and they are unsupervised. Rule of 2, the classic rule of 2 is not always applicable in pediatric X-rays. So there is some orders of unnecessary X-rays by clinicians which add unnecessary visiting time and cost. And last of all, but not least, radiation exposure is really a concern for pediatric population. Some do's. What should we do? We must do a quick clinical survey and X-ray of the injured area for initial evaluation, and review the initial or outside X-ray first before ordering a new one. Of course, do additional reviews if it seems reasonable. And regarding post-casting X-ray, perform only if you are confident enough about the quality of reduction and when the cuts are well molded. Limit check X-rays to a minimum. Some do not. X-ray of the joint and below, not routinely necessary in pediatric cases. Like this is contradiction to the rule of 2. And fractures which are already visible, no need to repeat them. Cuts applied for only immobilization, or you are going to open the fracture, do not check by any X-ray. Here, some fractures around the shoulder. For clavicle, X-ray of the clavicle is enough. If there is confusion of the quality of the X-ray or position of the bones, then you can do a 45 degrees cephalic tilt view for clavicle. For shoulder, proximal humerus and humeral shaft, AP and lateral X-ray is sufficient. And do not routinely perform an axillary view if you suspect for shoulder dislocation. And do not routinely perform any dedicated shoulder or elbow imaging. Sometimes to make sure of the fracture scapula, scapular body or coracoid process or acromion process, we must have to do some Y view of the X-ray. For elbow, AP and lateral view is mainly is usually sufficient, but for lateral condyles, if there is confusion, we should do an internal oblique view of the elbow. Sometimes radial head view is really necessary if there is any confusion in AP and lateral view X-ray. Do post-casting X-rays for all dislocation. This is a must, mainly if you suspect for Montegia or type 1 supracondylar fracture. And this is radial view technique, and the second slide shows the internal oblique view, which shows fracture in the lateral condyle, but in the contrary, that is external oblique view, which does not show any fracture. For in case of forearm, no dedicated elbow imaging for all isolated ulnar fracture. To do all dedicated forearm imaging for isolated ulnar fracture to look for radial head dislocation. And distal forearm buccal and physial scaphoid fracture, sometimes oblique view with AP and lateral view may be necessary to ascertain any wrist injury. In case of fracture in the proximal femur, do a frog leg view of the hip or pelvis, not both, because if we advise both, it will increase the radiation exposure. For femoral third fracture, we must do a X-ray of the hip if there is history of high velocity trauma. And in case of knee injury, we may do a sunrise view if there is suspicion of patellar dislocation or any osteochondral defect. Instead, also with AP and lateral view. Tibial shaft, only do not routinely perform any dedicated knee or ankle imaging, and in case of ankle injury, there is some role for mortise view with AP and lateral view. And for short bones, AP lateral and oblique view may be necessary. And our home message is, radiation exposure is really a concern in childhood. Guide technologists to have a proper view. Do additional views when deemed necessary. Joint just above and below, not routinely down. No post-cast X-ray if you are opt for open detection, and keep the number of exposure as minimum as possible. Thank you so much.
Okay. So how many of you take X-rays yourself? And how many who have a situation like me that you have trained a person to take X-ray? So majority of the people fall in the third category. So we sail in the same boat, and let's see what we can do about this. Okay. 5-year-old fall on outstretched hand. What is the injury here? Is the son of a gynecologist. Anybody? Quick idea? Yes? It's a Montegia fracture. Is it easy to diagnose or it is little difficult to diagnose? So which view will take? You will take? Lateral view. Sir, is this a good lateral view? Okay, so this is not a good lateral view because it's a lateral view of a forearm and it's not a lateral view of arm. And that is why this fracture was missed. And then when true lateral X-ray was done of a child, we could diagnose that there is a radial head dislocation, which was very obvious from the day one X-ray. But because in our mind we cannot look at the oblique X-ray of the elbow very well, this injury was missed. So this is how the child was treated. Another child, 7-year-old female with lateral side of elbow swelling. What is happening here? Any clue? Yes, doctor, you are saying something. Lateral condyle. Which type? Will you fix this or will you not fix this? You'll fix this? Are you sure that this is displaced fracture? So this is the exact fracture. So unless you take a proper orthogonal view, you will not be able to, like the previous X-ray, the child was sent home by just giving plaster because the person did not look at the X-ray properly, because the X-ray was not done properly. It was not that the person did not look at the X-ray properly. So how do you take a lateral X-ray of elbow properly? This is the best way of taking a lateral elbow X-ray. If you have a swollen elbow, if you have a elbow which is very painful, then you can do it like the shown in your right side. But if it's not very painful, if you can, and if you have given anesthesia to the child, and if you want to check how is the reduction, then you do an external rotation maneuver, and that will also help in checking the stability of the fracture. Okay, what is this fracture? It is lateral condyle. Will you fix it or leave it? Fix it? Yes. Sandeep, will you fix this or will you leave it? Advanced imaging. This is 1 week later. Fix it or leave it? Yes, 1 week of plaster immobilization, and this is a check X-ray after 1 week. Fix it or leave it? Fix it. No, always take an oblique X-ray and then decide. Right? Because the displacement is most visible and the fracture fragment is most visible in internal oblique X-ray, as Dr. Tapas has already said. Right? So internal oblique X-ray was made famous by Dr. Song. Dr. Song had come in our first mega IFICS which we did in Pune in 2014. Okay, 8-year-old boy, I think cricket is very famous where I come from and where I have come, and this child was just catching the ball and he injured his little finger. What should we do here? Should we accept this? Should we treat this? Do you need an advanced imaging? Take an oblique view. This is an oblique view. So there are more than one views required. It is not always orthogonal views which may be necessary. There is a third view which is required, which is sometimes necessary in ankle, it's sometimes necessary in hand, and sometimes more often necessary in elbow in a lateral condyle fracture. So need for spatial X-ray in special situation we must remember. This is the X-ray which was shown by Dr. Server. What is happening here? Right elbow swelling. Sir, this is a perfect X-ray, I would tell you. I agree, sir, but suppose this is the child whose parent come to you with this X-ray, what will you do, sir? But if they come with this reporting, you report don't believe. This is elbow dislocation, sir. Is it elbow dislocation? What is it? So it's a facial separation, but the radiologist who didn't know about the condition did not report this. So basically, as we discussed yesterday, there was a very good footnote in Love and Bailey textbook. Eyes don't see which mind doesn't know. So if you do not know what is the facial separation, you will not report that. So what happens at birth, this is how the normal X-ray looks like, because the distal part of the humerus is not seen. So when in a facial separation, this is how the condition is. Here the white parts is the cartilage, but it is unfortunately not seen. So when there is an X-ray, it just looks like this. And therefore it is most commonly missed, and the end result is usually a complication. So if you want to not forget this, you must learn what are the ways the elbow ossification centers appear, because they sometimes interfere and look like fractures. So if you remember this mnemonic, which is known as a CRETO, which stands for capitulum, radial head, internal epicondyle, trochlea, outer epicondyle, olecranon, and external epicondyle. Right? So if you know this pattern of appearance, and if you are not sure, always take an opposite X-ray, because missing an intra-articular fracture causes lot more problem than taking a just simple opposite X-ray. Okay, what is happening here? What injury is this? I agree, sir, the quality of the X-ray is not good. But the question is, can we make the diagnosis from this X-ray? What is it? Lateral condyle. Is it only lateral condyle? Olecranon. Is it only olecranon and lateral condyle? Radial head is also fractured, olecranon is also fractured, and lateral condyle is also fractured, right? Okay. Here, look at this. This is a posteromedial displacement. Here also, it's a posteromedial displacement, right? So let's see. And what is this? This is a posterolateral displacement. So what is this? This is elbow dislocation, but see that all the injuries were a little confusing. So how do you get it? When in normal elbow, when you draw a radiocapitular line, it usually goes through the center, almost center. It may not be in absolutely center when the child is about 2 years or 3 years old, but after that it always goes through the center of the radial head. So whenever there is a radial head dislocation, if you draw the central line of the humerus and central line of the radius, then radial line is not going to be touching capitulum. When there is a supracondylar fracture, this is how it is like that. But if it's a very low supracondylar fracture, you will be missing it because the distal fragment may not be very well visible, right? But when the physeal separation, the most commonly missed injury is that because the distal fragment alignment is not seen. And that is what happened in the injury 2, where you did not give me any answer. In lateral condyle fracture, the radiocapitular alignment is disturbed, but it is disturbed on the proximal side. But when there is a lateral condyle fracture with dislocation, which was the first case in which there was an olecranon fracture, you can see that this is usually little off. So this was basically lateral condyle fracture with dislocation. This was a physeal separation. And this was basically an elbow dislocation, which is a very, very rare injury. So radiocapitular line, if you draw in an orthogonal X-ray, you will mostly not need any further imaging. And advanced imaging like this, in which sonography was done, which was not interpreted well, and then this child had to undergo an MRI just to diagnose physeal separation, which required anesthesia to diagnose and no anesthesia to treat, was little an overkill. Okay, so this child had a fall from cot and he stopped walking. He went to an orthopedic surgeon and he took an X-ray. Any injury do you see here? Okay, the child was discharged after this X-ray and was asked to come after 1 week. At 1 week, mother said that he is not moving entire right lower limb, and this X-ray was done. Any clue what is happening here? Okay, now you will be able to diagnose within a second the moment I give you. So what is happening? There is a type 1, Delbet type 1 physeal separation, or Salter-Harris type 1 physeal separation of proximal end of femur, or a Delbet type 1 fracture neck femur. Both are same things. So whenever in hip there is a problem which you are not able to diagnose, always take a frog-leg lateral view and you will be able to arrive to a diagnosis. 10-year-old treated elsewhere, presenting with severe pain in elbow, is not able to move. What is happening here? Yes? Medial epicondyle. Where is it? But if you take a comparative X-ray, you could diagnose this at day 1, because this was missed for 3 weeks, and this is how the child needed very bad. And this is a nice clinical picture of how the entire epicondyle goes inside with the origin of the flexor muscles. So order comparative contralateral X-ray before you advise any further imaging, which may require. See, if you advise any ultrasound, then the diagnosis is not in your court; it is in his or her court. If you do an MRI, then child may require anesthesia. 13-year female, how will you treat this? Ankle injury. She is in plaster for 1 week and there is a significant pain. If she comes to you with 1 week old X-ray of this, what will you do? I think the second view is the mortise view as suggested by Dr. Talukdar. Does she need surgery or you can just continue with plaster? Anybody for surgery in this case? Why you want to do surgery, sir? So, are you confident to advise surgery from this investigation? Yes? Arthrogram requires anesthesia. You can just do a CT scan here. Right? The CT scan shows a telo fracture. You can see how big is the fragment, how much is it displaced. And now, what you need is surgery. Okay. What is happening here? I think Sandeep and I were discussing, we are getting younger and younger supracondylar. I have initially in my practice, I have never seen a supracondyle less than 3 years. And lately, at least 2 or 3 patients I see in a year which are between 1 to 2 years old. So what is happening here? Is this supracondylar fracture? Yes? Yes, doctor. Please, I can't hear you. It's a lateral condyle fracture. Anybody has any doubt that this is a lateral condyle fracture? Are you confident for opening this fracture? Okay. So, this is the clinical picture. Does your clinical diagnosis match with the clinical picture? So, what fracture is this now? So when you take a traction view, you will be able to. Okay. So it's not only imaging. I think Sandeep and I were discussing in the morning. And after 10 years, the only doctor who will do better than other doctors are the one who examine the children or patients clinically, because clinical examination has taken a toss. Everybody wants to investigate, and sometimes it is not necessary. If you look at the X-ray, if it is not consistent with the clinical picture, and that is the thing in which you want special imaging. Right? This child had a humerus fracture and presented to me with elbow stiffness. What is happening? Sorry? What is happening? So this is a very unusual injury in which there was a humerus fracture with elbow dislocation, but the entire concentration was given only to the fracture and nobody looked at dislocation, and this child ended up in open reduction of this. Okay. What is happening here? 3-year female, again I am telling you, the supracondylar age is going down and down and down. What fracture is this? So what will you do? Will you fix it or will you treat it in a back slab? Sir, in supracondylar or oblique view, I am not very confident in interpreting myself. So what more information will you get? Dr. Talukdar, which supracondylar requires internal oblique or external oblique view? Lateral condylar. So this is how this child was treated, and she presented to me with elbow stiffness. So what is happening here? This is the comparative flexion view. You can see that the coronoid process is jutting at the distal humerus. See, normal elbow, this is the line which is known as the antehumeral line or a Rogers line. And that is why this line is there, so that the olecranon can move very well along the trochlea. But when supracondylar malunites like this, And when there is a flexion, it abuts here. And therefore, when there is a very low supracondylar fracture, when there is a formation of callus in the olecranon fossa, then there is a restriction of movement. So it's a transcondylar fracture or a low supracondylar fracture. Even if it is undisplaced, I would go ahead and put 2 KYs because I don't want a callus formation there. That callus formation can lead to restriction of movements, right? And that is where the Rogers line was not first initially seen, comparative X-ray was not done, and hence the diagnosis of this fracture was missed. Okay, so these are 2 fractures of radial neck. Which one will you reduce and which one will you fix and which one will you do conservative treatment? I want you to take little bit of time before you give your opinion. Which one is more likely to require surgery? The one on the upper side, case 1, or one which is on the lower side, which is case 2? Case 2. How many? Just raise your hand. I am not going to make anybody. Anybody for case 1? Okay, this is case 1. What is happening? This is an extremely rare injury in which the radial neck is fractured and flipped. And if you look at the CT scan, this was missed. The articular surface is facing down and fracture surface is facing up. There are anecdotal case reports. So with this, I just would like to end my presentation telling that if you don't understand the previous rule, use another investigation or refer your patient to an expert who can diagnose this in time and treat in time. Thank you very much for your attention.
Axel for your deliberate presentation, and we will go for next session. Next session will be chaired by Professor Tarun Nagda and Dr. Mehdi Nawaz, and it will be on supracondylar fracture. And I am inviting Professor Tarun Nagda and Dr. Mehdi Nawaz.
I am Dr. A.K.M. Shahjahan presenting my case on ABCD of supracondylar fracture. Supracondylar fracture is the fracture of the distal humerus just above the elbow. It is the second most common fracture injury in the pediatric population, and almost 50 to 70% injury of the elbow fractures. Most commonly occurs in 3 to 7 years, and the boys are mostly affected because boys are more active, and the non-dominating hand is usually affected, usually left side, and incidence is 177 per 100,000 live birth. And where is the fracture? The fracture line passed through the bony mass, that is trochlea and coronoid, just above the bony mass, or through the olecranon and the coronoid fossa, or through the metaphysis or epiphysis of the fossa. And you see the humerus in cross section, that is almost circular in shape, but when it descends, it takes a flattened and more thin part. The medial and lateral column, when meets with the shaft, the site is very thin, so fracture mainly occurs in these areas. And in mechanism of injury, almost the fall from height, in sports injury, and fall on an outstretched hand. And in this case, when a child falls on an outstretched hand, the olecranon acts as a fulcrum to occurs the fractures in extension type, and here is the direct trauma to the elbow. It's caused the flexion type of injury mainly. And in classification, there is anatomical classification and radiological classification. In anatomical classification, most of the fractures are in extension type, that is 97% almost, and the flexion type is more rare. And in radiographic classification, there is Gartland classification, which is modified by Wilkins. 4 types of fractures, 1, 2, 3, 4, and type 1 is non-displaced fracture, and type 2 is angulated or displaced. and the anterior cortex is break, but posterior periosteal and cortex is intact. In type 3, both cortex are broken, but the posterior periosteal hinge is present, and in posterior hinge there is already medial and lateral hinge. If the medial hinge is intact, the displacement is posterior medially, and the lateral hinge is intact, the displacement is laterally. And in type 4, that is a complete fracture, complete periosteal disruption with unstable inflection and extension. And here we go to the clinical feature. The history usually fall from height or an outstretched hand in form a pull or bar. And on observation, we see the swelling of the elbow. Patient usually reluctant to move the elbow. There is ecchymosis, and in open type of fracture, there is some puncture wound in the anterior aspect of the elbow. And in displaced extension type, there is S-shaped deformity that shows a fracture on previously. And we must evaluate the neurovascular status, because 10 to 20% injury occurs with vascular injury, and radial and ulnar pulse and the capillary perfusion must be checked in every cases. In neurovascular injury, it is almost 7 to 16% cases, and most of our neuropraxia, and that usually recovers in 2 to 3 months. And all the 3 nerves, that is interinterosseous nerve, radial nerve, and ulnar nerve, are mostly affected. Now go through imaging. Usually imaging done through anterior posterior view of the distal humerus and the lateral view of the elbow. In AP, we show the Bowman's angle, and this is the Bowman's angle. This is the humerocapitular angle, interaxis of the humerus and the physis through the capitulum. This is Bowman's angle. This is 64 to 81 degree, and this is humero-ulnar angle. This is a radiological carrying angle. And on lateral view, we see the anterior humeral line, that is Roger's line. This is the coronary line. There is the fishtail sign, and there is the fat pad sign, anterior and posterior fat pad sign. Usually, occult fracture shows. And treatment, we do the non-operative and operative treatment. In type 1 and minimally displaced type 2 fracture, we go through the non-operative treatment, that is long arm back slap, less than 90 degree angle. And in operative case, we do the closed reduction and percutaneous pinning, that is displaced fractures or unstable fracture, flexion type of injury. And if there is an open injury or suspected vascular injury, we must give the open fracture. And as the complication, immediate, early, and late. Late, that is cubitus valgus and varus deformity, Gunstock, and the late tardial palsy, myositis ossificans, and elbow dislocation. Thank you all. Thank you. সবাইকে শরতের শুভেচ্ছা.
And it's a game of cricket and supracondylar fractures. So we have around 1 hour and 12 minutes to discuss supracondylar fractures, and I promise we'll complete sharp on time. The mahal or the environment nowadays is of cricket, a lot of cricket happening. Let's understand supracondylar fracture through the game of cricket. Every team requires 2 pillars, 2 pillars who are the either winning batsmen or winning bowlers. Without them you cannot win. And supracondylar fracture is based on 2 pillars. Dr. Shahjahan told us about the level of the fracture, but if you see, there is a medial pillar and a lateral pillar, and both the pillars have to be in contact. When medial pillar loses the contact, it's a rotational problem. It's a rotational problem, but it results in angular deformity. So whenever we see cubitus varus, we perceive it as angular deformity and we do a wedge osteotomy. But actually it is a rotational problem. We fail to maintain pillar to pillar contact, and that's something which we have to remember. So whether it's type 1 or 2 or 3 or 4 supracondylar, as long as your pillars are in place, you are safe. If your pillars are not in place, any amount of wires or immobilization is not going to prevent a deformity in a supracondylar fracture. So it's very important that whichever shot you play, your legs have to be on ground and pillars have to be on ground. Let's start with the simplest of these fractures. We were shown x-rays of these fractures. Premal spoke about some of this supracondylar fracture, and we also learned some lines. It's very important to even treat type 1 or grade 1 supracondylar fracture well. And this is something which what we know is it is undisplaced supracondylar fracture, supposed to be undisplaced, And many times you don't even see it on X-ray. Many times anterior humeral line also will go through center of capitulum. And the only way many times to diagnose this is to look at anterior and posterior fat pad. And it's important to realize that anterior fat pad can be normally present in children. Only when it's massively elevated, it can be indicative of injury, but posterior fat pad is never present, and if it's seen on a well-taken X-ray, it is indicative of a supracondylar type 1 injury. It's important to take an AP view and look for medial comminution, and very simply it has to be treated in a slab or a cast. Not so much flexion. This is not so much flexion required. This patient is smiling, but you can give around 80-degree flexion and in immobilization. Take check X-rays every week. These patients still need to be treated, because if you immobilize, that gives comfort. It prevents profuse callus formation. Type 1 supracondylar which are missed and not treated, you will see profuse callus formation and restriction of range of movement, which takes a long time to come back. And if these fractures not treated and they refall, then they will get type 2 or 3 supracondylar, which may require pinning. So these need to be treated. And you can see at 3 weeks, you see massive callus formation here. Okay. So X-rays which are reported normal on day 1, fracture will be seen at 3 weeks. So it's important to take X-ray at 3 weeks. Some sort of so-called undisplaced supracondylar fracture can be deceptive. As some of the deliveries. So if you see this fracture, this AP view, the lateral view was also normal. This was treated in a slab, and you can see over a period of time this has gone into varus, cubitus varus deformity. And why this happened is because there was medial comminution. There was a medial weakness to start with. The Bowman angle here was 87, and this is now known as type 1B. Type 1 supracondylar with a medial impaction, and these should be treated with close reduction and pinning or plaster in extension. 2 ways to treat it. If you don't want to operate, extend the elbow, maintain the carrying elbow and give a plaster in extension, or if you correct it, you have to pin it. So these are 2 ways of pinning, of doing type 1 supracondylar fracture. Many times even 1 pin is sufficient if you are treating type 1 supracondylar fracture which is with medial impaction, or you can put 2 pins from the lateral side. That's going to do well. Type 2 fractures, lot of controversies in type 2 fractures. Here the posterior hinge is intact, the anterior hinge is opened up. So this is a 6-year-old child with type 2 supracondylar fracture, and I want to know from the audience, the fracture is on the right side. This is where the fracture is. This is the fracture. Okay, you can draw anterior humeral line, and you know that it is not going through the capitulum, and you know that this is type 2 supracondylar fracture. From the audience, how many of you just want to immobilize in a plaster, and that would be end of the treatment? Just raise your hands. Okay. How many of you want to reduce the extension and then put a plaster? And how many of you want to reduce and then put K-wires? Okay. Sandeep, I want to ask you, how would you treat this fracture? Type 2 supracondylar in a 6-year-old child. Give him mic. Yeah. Rotationally stable, yes. Because on a lateral view, the cortex are matching, there is no spike.
So rotationally stable fracture can be treated in a plaster, but the plaster needs to be 90 plus,
90.
so that you want
Inflection.
to tighten the posterior periosteal hinge.
Absolutely.
Now the challenge is always when there is large swelling and you try to put a plaster and you acutely flex, there can be blisters.
Right.
So there has to be a way of doing the plaster correctly without impinging onto the cubital fossa to prevent complications, or then you would still explain to the family and put a pin, and then you can cast it in a relaxed position so that there is no risk of compartment or blistering in the antecubital fossa.
So this was treated in a slab.
So slab, again, we've been talking, even in the first talk I heard, back slab. I think we should discard that terminology completely. a cast which is circumferential offers far greater stability than just a bandage and slab. Large number of cubitus varus and complications are because of a poorly applied slab. You tell your what boy isko slab laga ke bhej do, and they come back to bite you because you have missed an unstable type 1 or a medial combination, and then the type 3s are always treated surgically. Don't miss the subtle ones which cause deformity, and that is because of bad primary management. I would always recommend that you do a good cast.
So anyway, this was treated in a slab, and if you're treating still in a slab, again check at 1 week, take x-rays. Clinically, by the time the patient's pain is less, you can check for varus and hyperextension. You can straighten the elbow in a week's time, and then if there is a varus drift at 1 week, you can still reduce and pin. So all these don't have to be fixed on day one. If your conservative treatment, as Sandeep says, is good, and you can apply a well molded plaster or a very good slab and maintain them, see them at 1 week. I'll show you what happened to this patient. So this is 2 years down the line. 2 years down the line, there is hardly any varus. There is just minimum varus you can see on that side, but not much. There is little hyperextension. So Premal, 8-year-old child with this hyperextension. Do you think, what will you tell the parents? This will remodel, it is okay, and the treatment which was done was acceptable. What would you?
I think we must remember which is the growing end in the humerus. The growing end is on the opposite side. So angulations, they don't correct very well. I think beautifully yesterday, Kosser sent me a case in which there was a beautiful remodeling of the supracondylar fracture at night. But that is the translation. The distal humerus only deformity which remodels is translation. Angulation does not correct. So just to add to the point of type 2 supracondylar fracture, there are 2 important papers on this. One is by one of our team IFICS member, Dr. Sheetal Parikh, who in USA, they believe that you can do a close reduction under general anesthesia, take an X-ray at 1 week, and then if it displaces, you go ahead and do pinning, and if does not displace, you continue the treatment. But I think in a country like India and Bangladesh, where a general anesthesia giving 2 times in a child may be a luxury. I think if you are just giving an anesthesia, it makes a sense that you just put 2 wires and then you can immobilize in a full plaster and then you may not call the child for X-ray or anything, just bring the child at 3 weeks and do that. The second study has come, there are 2 important papers which have come from Thailand. That's Bangkok, there's a good paper in which they have studied about 3 different angles and how that measurement of angles can give you decision making that whether type 2 will further displace or not. But drawing that angle in a very young children is again a big challenge. So I think if you are going to give an anesthesia, at least in my practice, I will put a pin and give a plaster. Otherwise, as Taral has seen, that you must be sure that that child is going to come back to you at 1 week, where you have got a window of intervention at that point of time. Because if a child comes back to you after 2 weeks, I don't think you will be able to make any significant difference.
So what is happening is we are trying to redefine the indications. Type 2 supracondylar fracture, child is younger, not much of swelling. You know that plaster will work for this patient. It's a stable fracture. Don't even reduce it. Just put immobilization in your OPD and that will work. And this child finally corrected. His extension is in the range of movement of the elbow, that corrected. He did not have much of varus and he did well. And he did not have to undergo any surgery or anesthesia. Okay, but if you feel that there is a lot of swelling and you are not able to give slab inflection, if the angulation is more than 20 degrees and you need to correct it, if there is some varus and you need to correct it, whenever there is need to correct, you need to fix. If you don't need to correct, then plaster will work for these patients, and it's very important to realize. So this is hyperextension. Now this is a patient, 12-year-old child. Again extension type supracondylar fracture, was classified as type 2, was treated in a plaster. And you can now imagine, by the time it is 1 month post-op, his age is 13. You are seeing that most of his ossification centers are closing down. and there is no way this hyperextension is going to correct. And you can see the amount of hyperextension this child has. He's a tennis player, it's difficult for him to hit, and so much hyperextension sometimes is pathological, and he had to undergo a flexion osteotomy just to correct that hyperextension. So it's important to realize that varus is not the only problem. Hyperextension can also be a problem in an older child, and if treated well on day one, it can be looked into. One more issue I want to say is, this is a 10-year-old child. Now we know that there is hyperextension, and somebody say I will treat this with close reduction and plaster. The problem is when you do a close reduction many times, the posterior intact cortex also you break, and then you need to stabilize it. Okay. The point I am again trying to make is type 2 supracondylar fracture here on lateral view, this doesn't look much displaced. It's just angulated. Posterior cortex is intact, but if you see AP view, there is medial comminution, there is a piece. In fact, the lateral cortex is also not in contact. So this is not true type 2 fracture. If treated in plaster, this will give rise to cubitus varus, and you have to do an unnecessary surgery later on. So this child, this is an 8-year-old child, significant posterior tilt and varus impaction. If I have to reduce this, I will treat this with fixation. Either you can put two lateral wires, that will also suffice. In this case, I put a medial pin. This was done almost 5 years back, but today if I have to do, I will put 2 lateral pins for this patient. If you are putting a medial pin, you have to avoid the ulnar nerve, and you can see that I put my medial pin from anterior to posterior because ulnar nerve is posterior, and you have to take all the care that ulnar nerve will not be affected by a pinning. Okay, so this is about type 2 supracondylar fracture. One more case here. This is type 2 supracondylar fracture. Anything unusual here? Premal, you feel that there is something which is out of the way, or it is an undisplaced fracture? How do you want to treat? If you draw antehumeral line, it is an extension. But if you look at
this is an oblique fracture which starts higher on the lateral side, exits lower on the medial side, and as you have already drawn the angle, because the lateral column is slightly turned, so this can collapse into valgus, which is very unusual.
But yeah. So sometimes you can have a lateral impaction. So this will go into valgus, but healing in valgus is not as bad as getting a varus. You already have a carrying angle, 5 to 6 degrees or 7 degrees of additional angle will not make a difference. The valgus fractures, valgus impaction, have profuse callus formation because the blood supply on the lateral side is more than the medial side. So you will see there will be profuse callus formation. So in this child, the problem was not mild degree of cubitus valgus. The problem was that he did not have flexion almost for 2 years because it took a very long time to come back. So valgus injuries are, again, you have to recognize it, and most of the time you can treat it close. But if you get a valgus injury like this is a massive valgus injury. There is not only impaction on the lateral side, there is complete opening on the medial side. So I want to ask Dr. Talukdar, what nerve will you be worried about in this patient? Will you be worried about any nerve issue in this patient? Ulnar nerve. So you have to be worried about ulnar nerve, and this needs to be treated by 100% close reduction and pinning, because this is a very unstable fracture, and if you don't take care of this, ulnar nerve you don't have to explore, because as we saw in the previous presentation, that will always heal by itself. Any questions, any doubts on type 2 before we go on to the type 3 supracondylar fractures? Dr. Mehdi, if you have anything to add to whatever we've discussed?
I just want to any participant from there to comment or questions about this Gatland 2 classifications.
Okay. So everyone is clear about type 2? Raise your 2 hands, then I know that.
So Professor Kori sir, do you have any comments about this?
Yeah,
Please.
Mic to Professor Kori. Give him the mic.
Not all are pediatrics orthopedic surgeons. where the general orthopedics, I mean adult orthopedic surgeons. And so remember that in type 2, the complications are varus and the deformity, but it is not this Bosman ischemia or vascular compromise. So when the facilities are not there for pinning, don't try to pin it. I have the cases from outside Dhaka which are pinned but not pinned well, lots of complications. So my advice for type 2 is you must know all these things, but don't try to pin it when you don't have the facilities to pin. You don't have the sterile OT theater at that time. Don't pin it in the outpatients, in your outpatient room without any facilities. This will be the comment.
Yeah, exactly. So we face this sometime, and what we do many times is there is a lot of swelling on day 1. You just immobilize it. Let the swelling subside, and you can give a plaster in flexion on day 3 or 4. Absolutely possible. And that would be safe. That's an alternative to pinning.
Yes, and even now in UK there are centers where they go where they are hanging cast for a few days and they pin it. They don't do any supracondylar fracture on the day 1. There are centers even now. So.
Yeah. So delayed
pinning,
delayed plasters or
delayed plaster or pinning is also possible.
Yes.
Look at the
type 2 supracondylar fracture subdivided into 2 types.
Right.
Type 2A, type 2B.
Right.
So is it necessary we go for always pinning in type 2B?
Type 2A are stable, have less swelling. Okay, these are the patients, I would give slab on day 1 and then do a plaster on day 4, 5 in flexion. That's absolutely fine. Type 2B are the ones which are problematic because they are more unstable, and I think if you want to avoid varus and at the same time avoid giving plaster in too much flexion, it makes sense to do pinning if your facility is available. Thank you.
There is a rotational deformity of the.
Absolutely, it needs to be corrected and
it should be corrected because there is a rotational deformity at the distal part.
In fact, if you don't have facilities available, I would recommend that you send to a center where facilities are available, because these patients will otherwise land up with cubital varus and you have to operate anyways. And the 1500 list very Sarovar, it will go on extending. Okay, so Prema.
I think supracondylar, we are always married to one classification, which is Gartland classification. There is a beautiful article in International Journal of Pediatric Orthopedics from India, which is on classification, in which there was a classification known as a Lagrange classification, which classifies distal humerus fractures much well, because it takes into care transcondylar, which behaves differently, and high supracondylar fracture, which is a metaphyseal diaphyseal junction fracture. Well, I'm sure sir will show the cases. But since we classify everything into one bundle, we have a problem that what do we do in type 2? But if you follow Lagrange classification and then another classification which Taral will show you, which is on the obliquity of the fracture, your decision making will change. So I think we need to subclassify this, because as Dr. Sarwar said that 30% of the fractures are elbow fractures. And of that elbow fractures, more than 50 to 60% fractures are supracondylar fractures. So in a pediatric fracture, if the most commonly treated fracture is some fracture which requires maximum decision making, is the supracondylar fracture. And absolutely, that's why we have the first session, the supracondylar fracture.
So now let's go on to type 3 fracture. This is the type 3 fracture, 6-year-old child. He has radial nerve palsy, and I want to know from audience, how many of you would still treat this in a traction, or how many of you want to do close reduction and pinning in this? Yeah, most of it. So let's go on and go to the stadium directly and see what's happening. This is a match highlight, and I'm going to show you how to.
Cross pinning is necessary in supracondylar fracture. So I want to know, yes. You always do cross pinning, sir?
No, if there is a medial condition, medial chance is great, then I go for medial.
I think that's a very, very just answer.
Yes.
That you don't need medial pinning all the time. You need medial pinning in special situations. Say you are dealing with this flexion supracondylar fracture. When there is a large big piece, according to Bach classification, it's a medial oblique where the fracture line exits from high medial side to low lateral side, and then there's an unstable fracture, which Taral will show you. These are the only indications where medial pin is required. It has been proven beyond doubt that 3 lateral pin is almost as stable as two cross pins. So why hit ulnar now? Because you can get away in majority of the cases, except the selected few, without cross pinning. Yes, sir.
Okay, yeah. Alok, you want to say?
And I have also a paper. This is not necessarily pin configuration, but stability is important. In my practice, after pinning from lateral side 1 or 2 pin, I on real-time video screen on image, I check for stability. If I feel this is not still unstable, then I go for medial pin, sir.
Okay. But if there is medial combination, you should must pin.
Yeah.
Medial combination, it needs it.
Okay.
Mr. Toll, please.
Yeah, the last
Yes.
comment on pinning. Yeah. So this is the fixation we used to do earlier, and think that this is the only way you can give stability. But putting a medial pin has very high chance of ulnar nerve injury, almost 10%. And of course you can remove the pin and patient is going to be all right, but it does create some hard feelings in patient's mind. So there are other ways to still get a stable fixation. So this is one more way in which you can get a stable fixation: 2 lateral pins. Okay, and if you realize this pin, this configuration is fixing your medial column and is also fixing your lateral column, and the medial pin, the medial of these 2 pins is actually going through the olecranon fossa. And many times people have worry that if it's going through olecranon fossa, will it hamper the extension? The argument against that is you're going to give slab in around 70-degree flexion, and by the time you start mobilization, you're going to remove the wire. So that really does not hamper the extension, though this pin is going through the olecranon fossa. So this is known as a 4-cortex pin or a lateral condyle pin, which goes actually through the lateral condyle physis. And this is another way of doing it. In a lateral view, both the pins should not be parallel. If they are at an angle, that gives better rotational stability. The pin diameter is also important. If you use too thin a pin, that is not stable. At least 1.8 or 2 mm, or in older children I also use 2.5 mm pins, and these should be used for patients. So this is how I would do 2 lateral pins, and you really don't need to do a medial pin. So this is how a lateral cortex pin is passed. It actually goes through the olecranon fossa. The direction of both these wires are different. The first wire is at 45 degrees to the humerus, and second is 60 degrees to the humerus. So that is how you know on table. Many of time you don't have a good C-arm, but if you know your angles, you can minimize the use of the image intensifier. This is one more configuration I do sometimes, as Tapas said, that you do 2 lateral pins, and after doing 2 lateral pins, if you feel that the medial side stability is not enough. So this is an oblique fracture. It's not a transverse fracture. If you see here, this is, the fracture line goes like that, from medial to lateral. And no, this is not sure. Yeah. So in this case, the fracture line is going oblique, and hence a medial pin was sufficient. So in my practice now, the indications for additional medial pinning are only 10%. I don't do it for all the patients. But if I find such a fracture geometry, or if there is medial combination of, there is an older patient, adolescent patient, 12, 13, 14-year-old child, then we put a medial pin, and that needs to put it safely. If there is swelling sometimes, you put from anterior to posterior. You don't keep the elbow flexed while putting a medial pin, And the third care, many times if there is a lot of swelling, you take a small incision, you put a drill sleeve and then put a wire through that. So you never have to expose the ulnar nerve for doing a medial pin, but make sure that your pin is not going through the ulnar nerve. There are sometimes people put the medial pin from the lateral side. This is known as the organ's pin, and there are instances where people have actually gone penetrated it outside and damaged ulnar nerve here, or you can damage the radial nerve here. So there are a lot of nerves around and you have to be very careful, know your geometry well for a perfect pinning. So with this technique, the video was not playing, but we will show it in the evening sometime when we have time available. But I want to invite Sandeep here for his own technique of doing a supracondylar pin using a simple arm board. Give mic to Sandeep so that he can give commentary as we are playing this video.
Okay, so this is something we've been doing for quite some time, which is now published in the POSNA video archives, where we use a simple arm board for pinning supracondylar fractures, and I've found that we've never had to open reduce a supracondylar fracture for nearly 15 years now. And Taral started doing it. I don't know if Premal is doing it, but most of us have got used to this arm board method, and you can supracondylar reduction with a standard table. But when you have a very big table, sometimes you have to put a sheet underneath because the drill keeps on hitting, and manipulation sometimes can be a little tricky or difficult. And some people have tried that we'll put the elbow directly on the CM tube. Okay, so that you eliminate the table. But all your cleaning liquids and your preparation, if they go into CM, they will damage equipment. Some people have described a lateral method. You put it in lateral position and reduce it. But again, orientation to the varus, valgus and rotation can be very tricky if you are doing in lateral. And you do need an assistant for giving traction. And if you try to do a lateral by rotating the arm, your reduction slips. So these are the practical problems. So this is a small solution for that, which a lot of you might find interesting and can use in your own practice. So this is a pre-op of a type 3 displaced supracondylar with a pucker sign. And this is the pre-op clinical picture. This is the picture of the arm board. It's just a simple wooden board which is about 4 feet in length and about 10 inches wide and about an inch thick, which is painted with simple oil paint. Do your pre-op check of vascularity. And now you can see I put the arm board underneath the proximal fragment. I use a micropore tape just to stabilize the proximal fragment. Okay, once I have my fragment stabilized, with a gentle milking maneuver, I can get rid of that puckering. Okay, I have extremely good stability on the proximal fragment. And now with the C-arm, first I will do my reduction. On the AP we check how the alignment looks and correct whatever coronal plane malalignment is there, varus, valgus, translation, and then you will acutely flex it and then rotate the C-arm. You don't have to rotate the arm. You raise your table, rotate the C-arm so that you get a perfect dead lateral. And now the entire humerus, distal humerus, is available to you with no obstruction for pinning. So after preparation and draping, I have a small O-shaped drape made, a disposable drape. And then without an assistant, I am just holding the arm in flexion, checking on the lateral view. The first pin goes in the lateral view from front to back. And that's the first pin which goes through the fossa. And then once my first pin is gone, I make it AP. So I've done my reduction earlier, then I've prepared it. AP and lateral are seen by rotating the C-arm and not the arm. Check that your AP alignment is good, and then put your second pin, as Taral said, at 45 degree and 60 degrees so that they are divergent and at least 8 millimeters distance between them. Then you can just, since it's a paper tape that I put, you do a little rotational maneuver and check stability. If on rotation this is not stable, I can add a third pin or consider a lateral pin and do your column views. So you do obliques and then just bend the pins using a small suction cannula and cut them off and put some antiseptic cream and you can put your plaster. I do a soft cast for all these patients. I find it's very useful and comfortable for the child. So Taral, back to you.
So very simple technique here, and some of things. Again, one more sort of a small tip I want to give you is using hypodermic needles, 16 number needles, to know what direction to put your pins in. And this was a little lowish supracondylar fracture, 8-year-old child, and this child, you can see that there is a lot of ecchymosis here. So anything special about this patient, Premal? It's a flexion injury. So this is not a typical extension, and the moment you try to flex, this is going to displace. Okay, so this is a flexion injury. And how do you know this is a flexion injury? If you see the patient's arm, the ecchymosis is not in front, it is at the back. So this was fall on the point of the elbow, and we saw in the previous talk that this was the diagram at the end, that this was thing. What you have to be careful about in this patient is ulnar nerve palsy. So you can see when you ask him to extend, the little finger is not extending. He's got hypostasia on the little finger. So ulnar nerve palsy is more common in the flexion types. And this patient, again, how did we do it? Use the same technique, arm board technique, which Sandeep showed you. I learned from it, and now I become board certified pediatric orthopedic surgeon because I use the arm board. And the reduction will be in not in flexion, not in extension. It has to be in 30-degree flexion. And then you can see I put a needle to know my direction of the pin. So this is the advantage of the arm board technique. You can see this is on the AP view, gets a very clear view without any hindrance. On the lateral, you get a perfect lateral with the arm board below, and now you see the fragment is in flexion, and all I have to do is give traction and push this fragment down in order to get my reduction in 30-degree or 40-degree flexion, and then just hold it in position when my assistant will put a pin. So what are the steps of putting a pin? You can see in the first X-ray I put a hypodermic needle here. So that tells me this is the direction. So you avoid multiple pinning attempts. When you do multiple drilling, you are making the bone weak. By putting the needle, you know this is the direction, and then you put your wire in this action, and then I put one wire at 45 degrees, the other one at 60 degrees to fix this. And then you can see these are the views. This is the lateral view, and this is a important internal rotation view. In the internal rotation view, you see the lateral column well, and in the external rotation view, you see the medial column well. This is the medial column, and we said that supracondylar reduction has to be column to column reduction, and the way to confirm it is not on AP or lateral but on these oblique views. And for you to remember, max medial column in external rotation, lin is lateral column in internal rotation. That's how you'll remember it. Okay, so that third pin added up because this was not stable, and again you don't have to pass a medial pin. This pin is going way medial here, just closer to the radial head, and this is fixing the medial column. So each wire is, it's a low supracondylar fracture. Just 2 pins are not sufficient. You need to add more pins here, and this is the fixation. And then you can see ultimately ulnar nerve is recovering, and then we've removed the pins. This is that, and after pin removal also I convert that plaster into a slab, and we use it as a brace for a couple of weeks for intermittent mobilization. So the same plaster which you've removed after pinning, what you do is you put Velcro and a liner, and it can be converted into a brace, and that is what we use for intermittent mobilization and just little protection for 2 weeks time. So that's about flexion type of supracondylar fractures and how we deal with this. So another fracture here, this is extension type, and again here showing a reduction. So what pinning would you use, Premal, here, and what type of fracture is this?
I think this is a simple type 3 fracture. The only concern about this fracture is that this is a horizontal fracture line, so if you really give too much pressure, this could get converted into type 4. So if with a gentle reduction, if I get this type of decent reduction, I would go ahead and put maybe 2 or maximum 3 lateral pins.
So some more little tips I want to give you, that we know about the anterior humeral line, which should be in order. We also know about the diameter of proximal and distal fragment, if they are same, then we know that there is no rotational problem. There is one more sign I want to describe to all of you here. If you see this X-ray, you see an hourglass here. Can all of you see this? Okay. If this hourglass is not distorted, your rotation is perfect. If this hourglass is intact, then you know that your rotations are fine. Okay. So this is one more sign you can use on C-arm while reducing a supracondylar fracture to know that your reduction is perfect. And again here showing use of this hypodermic needle. You put in a needle and you know that your direction is little off. You can just change the direction of the needle, and this is on the lateral view, and then parallel to this you can put your K-wire, and that would reduce the amount of number of attempts you do with K-wire. So 45 and 60 degrees. One more trick here is if you're passing two pins, use them of different diameter, so that on a lateral view you know which is which pin. Now I know that my medial pin is the one which is going more posteriorly and the lateral pin is not the same, and that avoids this this kind of confusion, and that's the reduction. Some more sort of jugards here. This is a fracture pattern which is based on obliquity, and I invite again Premal to just describe a little about this Bach's classification. He was talking about it. So what is this Bach's classification, and is it practical? How does it help us in selecting the pin placement?
So I think as we learned earlier that there are only couple of indications of doing medial pinning. So this third one, in which the fracture line is starting higher on the medial side and exiting lower on the lateral side, if you put two K-wires, what will happen is your medial K-wire will remain only in the distal fragment. So that is a perfect case in which you will, this is the case in which if you look at the fracture side is so much low on the lateral side that unless you start intra-articular from the capitellum, that is the only wire which will hold in this. So this is a child in which you always need medial K-wire, and maybe sometimes more than one medial K-wire.
So can we show a video actually, having done that? 1 second.
So for medial pinning, you can log on to my YouTube channel also. I think quite a few of you are watching that, and there is a medial pin, but we'll just show you a very young child with a medial oblique supracondylar fracture. So how to do supracondylar pinning. So again, a 2-year-old boy with type 3 supracondylar fracture where distal fragment is not visible well, but this is how is the fracture. So I usually bring the C-arm from the opposite side, because in 90% of the patients I feel that with external rotation it usually becomes stable, and I don't have a dedicated radiographer. This is the max view, that's the lean view. So once you have done a trial reduction, you know whether you can bring in on the other side or you want to bring it on the same side as Sandeep has shown. Again, doing a second check with APN lateral. Wire placement, you can do either via needle or you can just put a temporary K-wire on the skin. You know where you want to go. You want to go slightly anterior, but on the medial side you must always palpate and put a small incision. I do not recommend doing a blind pinning. So you put a knife there at the same place where you want to put a wire, put a small incision, take a hemostat and go all the way directly to the bone. And if it's a very small child, I would recommend that you use a T-handle, and this technique I would recommend when you are doing a physial cleaning also, because this generates a very minimal torque and you will be able to control the placement much better. So after you have taken an entry, if you find it little hard, if you have crossed the physis or say crossed the proximal fragment, distal fragment in such case, you can then use drill and go on the opposite side.
So initial entries with a T-handle, and then you continue with
So if you can go ahead, if the bone is soft and you can go ahead, you can continue doing that, or if you want to just save time, just you use this drill bit. But always use a drill or a K-wire sleeve when you're using, and that K-wire sleeve should be touching the bone. It should just not be hanging
So
outside.
though it's a medial pinning, you have not actually dissected the ulnar now.
No,
You
no,
just,
I have.
you made sure that it is on the bone and there is nothing coming in the way.
So because you don't see a lateral fragment here, child is only 2 lateral side, so you put small dye. So this is an arthrographic assisted, so you know where the lateral fragment starts now. You know now the alignment is good, carrying angle is good. Again you can start, because you are now starting again from the cartilaginous part. So you use initially, there's no need to use now a drill sleeve. So you can use this now. Check in the lateral view. Lateral view also shows you are in the center of the humerus, center of the capitulum as well. And then you can, now that you are confirmed with that, you can just drill it. So it's a cross pinning because the fracture geometry demanded it like that. And that is how the final position is. You can see there's a nice carrying angle. One more thing I usually do by end of it is, my anesthetist has a stimulator. We'll put a stimulator on and then see if there's any flicker, because if at all by chance if we are very close, we can change the pin at this point of time.
So excellent. We learned how to put a medial pin from you. We also learned how to recognize a medial oblique fracture. And third thing what we learned is, in a very young child, use of a T handle and use of an arthrogram to delineate the fragment. Would you also use this in fascial separation if you're fixing this? Again arthrogram and T handle.
I think that's when your distal fragment is a lot of cartilage, the best way to visualize is put a little bit amount of dye. So very low supracondylar fracture in a younger child, I think that's an indication, or a lateral condyle if you are doing close reduction. I think Sandeep also has significant experience on that.
Absolutely. So again on transverse view, you need to classify these fractures. If you have a transverse on transverse view, then it's a stable fracture. And your pins will go from anterior to posterior because your lower end of humerus, it's tilted 45 degrees anterior. However, if you see this configuration, your pins, which are put from here to here, are really going to not stabilize the fracture. You need to put your pins from posterior to anterior. So, supracondylar pinning is just not passing 2 to 3 pins. It's important to study the fracture geometry well. And when will you study the fracture geometry? In a traction view or after reducing the fracture. It's very difficult to make out the fracture geometry on a pre-operative X-ray. It's really not possible. So these have to be done on a pre-operative, after a reduction film or a traction film. So one more supracondylar. These are little different kind of supracondylars. And Professor Mehndi, if you're treating this supracondylar fracture, how would you pin this?
There is options.
So this is not actually a supracondylar fracture.
No, yes.
It's much higher up.
Much higher up.
Yes.
Is there both pinning from both sides, 3
Medial and lateral.
lateral.
Okay. The only problem here, what happens is, this is Dr. Sheetal's case. It's very difficult to pass cross pins when the fracture is so high. And what you really need to do is start really low down, absolutely close to the articular surface, and then go vertical. Now in this case, the only pins they got were intramedullary pins. And this patient actually went for a varus deformity later on. And what I recommend is, when you have a high supracondylar fracture like this, it is easy to reduce but difficult to fix. So moment you go above the supracondylar area, be prepared to enter low down, not from the epicondyle. You have to enter from low down, and of course some of your pins will go intramedullary, but see, at least if one of the pins can go to the opposite cortex, that will. So this is how this was pinned. 2 pins here, so at least one of them got into the opposite cortex, the other went intramedullary, but this is how this was fixed and it healed well. This is another type of supracondylar fracture, and it is below the supracondylar line, below the condyle area. It's almost like a fascial injury, but has a very thin sliver of bone. And this is a low supracondylar fracture. And again, this is a problem because it's difficult to fix. You don't see the fragment well, you don't see the bone You don't have a good hold because most of it is cartilaginous. And as Premal said, this can be fixed by doing an arthrogram using multiple wires. And the problem is many of these will go for what is known as avascular necrosis of the trochlea, because the blood supply of
Osteonecrosis.
absolutely, osteonecrosis of the trochlea, absolutely. And then they can go into varus, and the problem with this varus is moment you do an osteotomy, they will recur because there is a growth arrest on the medial side. So if you correct cubitus varus in these patients, you also have to fuse the lateral condyle in those patients, otherwise there will be a recurrence. So one more patient like this, very low supracondylar fracture, went into varus, treated with an osteotomy, but over a period of time you can see that the medial condyle is completely atrophic. Many times it subluxates and creates a problem for fixation. So avascular necrosis of trochlea can happen in low supracondylar fractures. So high supracondylar,
it's called Heisman necrosis.
yes, it's absolutely.
Heisman
That's
necrosis.
a name for it.
Heisman necrosis.
Absolutely. Avascular necrosis of the trochlea, because the blood supply of the trochlea comes from this blood vessel which gets damaged if it's a low supracondylar fracture. You don't see this in normal supracondylar fractures. Adolescent supracondylar fractures are again different. We are all seeing these. Very rarely you will have a standard supracondylar. We all see this bike injury. Is it common for youngsters to ride a bike in Bangladesh, two-wheeler? And at what age they start doing it? At 18, 20 or much earlier?
Before this. In Bangladesh they start before 18.
Before 15. That is official. Unofficially, at 10 years. All right. So you see these injuries, because of bike accidents. And these are different because many of them have comminutions. So this patient, supracondylar 13-year-old, has an anterior piece, a comminution here, and you need to be careful about this. Of course, this got reduced in a closed reduction, but you can see that we have had to pass multiple pins. 2 lateral pins, medial pins, and divergent pins, and all in different directions to fill up the canal, because then only this becomes stable. Another, sort of a adolescent and high injury. And then there is a comminution here. You can see there is a comminuted piece, and most of this can be treated closed with K-wires fixation. But it leads to a lot of new bone formation, and the range of movements take a long time to come back in these patients. This is another 13-year-old, and there is supracondylar fracture with a medial epicondyle. And in this patient, we could treat both close. We fixed the medial epicondyle, fixed with a screw, and then fixed the supracondylar with K-wires. So all these combinations come in adolescence, and it's important to recognize them. They take a longer time to get range of movement, and hence many times when patients come with difficult fractures, a fracture like this, for example, which is in very old child, almost skeletal maturity is close, electron apophysis is close, there is no growing end. This can be treated with plates. This need not be treated with K-wires because they need early mobilization, and you want to prevent callus formation in these patients. An intra-articular supracondylar fracture, supracondylar fracture with an intra-articular extension. Again, this patient, we did an open reduction and plate fixation. You don't need bipillar plates. So this is neither adult fracture or a child fracture. One plate would suffice. Even when you put a transarticular screw here, it need not be in compression mode because children's bones are soft. They are not yet adults. And all you do is just put a holding screw. You don't have to you can put a fully threaded screw here and don't tighten it too much. We don't need washers. Pardon? You can put a K-wire, but that will not hold that well if you have to mobilize early, and K-wires you will need to remove early. A screw can stay in for 6 months, 8 months, 10 months. You don't have to remove it. A K-wire will always irritate and will hamper your range of movements. So because the plate was also put put from the same side, from the same approach. You could have put a screw from the other side also. But these are not necessarily compression. You just hold the fragment, reduction, but you don't want to tighten as we do it in adults. So some of the adult practices are not applicable in children. Just a holding screw or a threaded K-wire in a younger child for intra-articular fracture would do. And again, these patients, when we use plates, in older children, there is hardly any callus formation, and the range of movement comes early in these patients. Some irreducible supracondylar fracture, some tricks I'm going to share. When you cannot reduce through a standard method, don't jump to open them. Okay? So some of the methods we have tried, and one of the methods is a joystick method. So you can see this is an unstable supracondylar type 4, which previous speaker described about. And here, if you flex, the fragment flexes. If you extend, the fragment extends. So what you do is, pass a wire through the fragment and then get the reduction using it as a joystick. So this fracture, if you see when we are flexing, it is flexing. When you are extending, it is extending, and both medial and lateral soft tissues are completely damaged in this patient. So in this patient, what you do is pass a K-wire, hold the fragment, okay, align it to the proximal fragment, and once you align, I would definitely use Sandeep Sambot technique in this patient. Pass that wire through and through, and then add additional wires. So 3 wires here, no medial pin, and this unstable supracondylar fracture you can treat by joystick. A second technique I want to describe here is use of a suction tube when there is a lot of swelling. So this is a patient in which you can hold the fragment, you can suck the hematoma and have a control over the proximal fragment with a suction tube. So this is a patient, it's ecchymosis, medial spike, and you can see this was a pink pulseless hand. He came with a CT scan, and I just want to demonstrate that just because there is a brachial block, it doesn't mean that you have to go and repair it, because there is good collateral circulation. So this patient had no pulse, but the hand was pink, and hence all you require is close reduction and pinning. You don't need to explore the vessels in these patients. And this patient had massive swelling, oblique fracture, and reading this paper from Korea, what we did is made a small opening, put a suction tip, sucked out the hematoma, used that suction on the anterior cortex to push it behind, and then use the joystick wires here to maneuver the distal fragment, and got a close reduction, 3 pins here perpendicular to the fracture, no medial pin, and this patient healed on in a good way. One more technique I want to show you when you can't get a reduction is the intrafocal reduction. So this patient came after 10 days, 10-year-old child, was treated in a slab. He had he had polytrauma and had some medical issues, so the surgery was deferred. He was transferred to us in this state, 8-day-old fracture, and this is the condition. Now should I leave it alone, give a slab, allow it to malunite, or should I fix this? If I fix, should I do open reduction, or can I try with close reduction? These are the questions. So again, coming on to the audience, 8-day-old fracture with this condition, how many of you want to open, reduce this and fix? How many of you want to just leave it alone, let it malunite, and then we can take care of the cubitus varus later on? How many of you think after 8 days the reduction will come in a closed manner? 10-year-old child. 8-year-old fracture
8 to 10 years old.
and 10-year-old patient.
Patient came to you after 8 days.
Patient came after 8 days. Yes. Reduction is still possible. So in these patients, there are 2 options. One case, if you just check under anesthesia and see if there is mobility at fracture site. If there is callus formation, there is no mobility, I will just leave it alone, let it malunite, let it remodel. He's still 10-year-old, growing, and whatever the deformity you can correct at later date, rather than opening and then creating stiff supracondylar. So this child, we were able to get a reduction, the technique I do is use a small hemostat. I don't use a K wire, but I use a curved instrument, a small artery forceps, which you put in the fracture site and then turn it around and get a reduction. And then put a wire. So I will actually show it on this video here. This is working. So you put the artery forceps inside and turn it around. Either the tip can go into the medulla or onto the anterior cortex, and then push it and lever it. You can also see there is a wire in the proximal fragment which is controlling the rotation. This wire has to be put very carefully because you don't want to catch the radial nerve. So it has to go from anterior to posterior so that the radial nerve, it has to be at a sufficiently lower level and go from posterior to anterior, because the radial nerve which is traversing, you don't want to go through this. And once it is done, then you get the rotation corrected, you get your hourglass in place and then pass a wire. And again in this patient, we pass 2 lateral and 1 medial pin to hold this on, and that went on to heal well. There are some patients you still need open reduction in acute situation. There is a medial spike here, and this medial spike is dangerous. That is what is causing buttonhole. And to deal with this medial spike, what you do first is a milking maneuver. But in this patient, there was also anterior interosseous nerve palsy and pink pulseless hand, and we made an opening, not posterior. The opening is made anteromedially over the spike. Just a small incision, and you will see that spike is penetrating the intermuscular septum and the fascia. And in this case, the nerve and the vessel were entrapped in the fracture site. So we carefully separated the nerve and the vessel and then fixed it in a closed manner. So when you have a pulseless hand with a pointing index which indicates median nerve, both can sometimes be entrapped at the fracture site. So you should try a reduction, but if the reduction is not possible, or if you feel that there is a gap in reduction, or if it's a mushy reduction, keep it at back of your mind that nerve and the vessel both can be entrapped at the fracture site, and these are the patients which will require an open reduction from anteromedial aspect. And in these situations when there is a lot of swelling, don't forget to do a fasciotomy, because fasciotomy is very, very important in these patients. So there are many other topics to be covered, late presenting supracondylus like this, and we will try to cover them in cases before the IFICS gets over. I want to come finally to what IFICS recommends, and we have just 5 minutes left, so we'll end with that. So what we have learned in this session, starting from ABCD of supracondylar fractures and now a long session we've had. If you have to summarize, if when you go back, if somebody asks you at home, what did you get back? What did you bring for me? There are lessons which are important, and I'll directly come to those lessons, what we have learned in this session. It's important to take supracondylus seriously and apply little mind before treating. Type 1 supracondylar fractures, we learned that we will watch, can be treated by simple immobilization, but be careful about varus. Type 2, we have learned that many of them can be conserved if extension is not more than 20 degrees. If there is no varus, you can give a slab, let the swelling subside, and then can give a plaster and still treat them close. But if the extension is more than 20 degrees, if the patient's age is more than 10 years, if there is varus impaction, if you need to reduce it. And when you need to reduce, you should fix type 2 supracondylar fractures. Type 3 supracondylar fractures, we learned that you should watch for nerve and the vessel. Always feel the pulse. Now you can use a pulse oximeter and get a waveform to be sure about vascular status. You don't need to do a Doppler or angiography for these patients, but simple clinical evaluation will do. Look for a medial spike, because that can be hindrance to reduction. You must close, reduce and fix, and you should prefer 2 or 3 lateral pins. Medial pin is reserved only for certain situations. where there is medial instability or an older child, it's important that you keep the patient on for 24 hours. Okay? If you are applying slab or a plaster, whatever you apply, it should be in 70-degree flexion, not in 100-degree flexion. Very important that tell your anesthetist this is not a case to give a supraclavicular block, because the pain will go away, but you will also miss a compartment syndrome in these children. So these should be dealt with IV anesthesia or general anesthesia, but there is no case for giving blocks in these children. If the supracondylar fracture is irreducible, there are many methods available. You don't have to open this directly. You can use joystick method, put a proximal K-wire to control the proximal fragment. You can use intrafocal reduction as I have shown. You can also use a suction tip method, whatever suits, and it's appropriate for the situation you can use. If you have a delayed supracondylar fracture, less than 10 days delayed, you can still try a closed reduction. Put them into a good position. If nothing happens, at least prevent a varus and try to fix them in some way so that you can avoid deformity in these patients. Now, if it's more than 10 days, you cannot correct them without opening, but resist an open reduction in this patient. Just put a plaster in a better position and see if they can be corrected. Sometimes we also put an IFICS. Dr. Bari is here, so you can put an IFICS and manipulate and correct them and put them in a better position. But if they come delayed, really late, and there is no mobility, don't break your head over reducing them. Let them heal, and then you can do a osteotomy later on. Pink pulseless hand, you have to be treating them immediately, which is important. The treatment is not exploration, the treatment is reduction and observation. But if you have a pink pulseless hand with nerve injury, then there are some chances that both can be entrapped and you need to explore them. If you have pink pulseless hand with pain, this is important. Pain which is not responding to your regular analgesic, then look for compartment syndromes, because agitation is an important sign, agitation and anxiety, and need for analgesia, important signs of compartment syndrome, and you must look into that. Nerve injuries with supracondylar fracture don't need exploration. However, if you have nerve injury after your fixation, that is a problem. If you have an ulnar nerve injury after your medial pinning, the consensus now is that retain the medial pin, don't be in hurry to remove it unless the child has too much pain. And even if you remove at 3 weeks, the nerve will recover. Because by removing the pin, you are jeopardizing the stability of the fracture and the fracture will malunite. But if the child has too much neuralgic pain, then you'll have to remove the pin and fix another pin. If there is a median nerve injury after fixation, it is a problem, because this is generally caused by entrapment of the interosseous nerve in the fracture site, and that will require exploration. And I've had one of my own patients where I had to explore this next day after fixing, and I found the median nerve in the fracture, and then it recovered completely. So it's important to realize what's the type of the fracture you're dealing with and deal accordingly. And with this, we complete this session. Dr. Mehendi, okay.
So that will going to help you guys for the next 1 hour. You all remember that all the physes has got 5 sublayers. If I consider it from the epiphysis towards the diaphysis, germinal zone, proliferative zone, hypertrophic zone, zone of calcification and zone of ossification. It is important to remember its order. Towards the epiphysis are the most 2 important zones. These are the germinal zones and the proliferative zones. We have to be very careful not to injure them during your treatment procedures. So I mark them as red. The 2 zones towards the diaphyseal region are the most stable one, because they are almost like normal bones. These are zone of calcification and zone of ossification. These are a little bit relatively safer to handle. So I mark them as green. And the middle one is the hypertrophic zone, which is in transitional phase. If you remember the Salter-Harris type classification, you will have the idea how to implicate this information. In Salter-Harris type 1, the fracture line passes through the hypertrophic zone only. It's a relatively safe zone, so Salter-Harris type 1 can be managed effectively by conservative method. If you think that if it goes through the hypertrophic zone towards the diaphyseal region, this is Salter-Harris type 2, where it injured the hypertrophic zone, zone of calcification and ossification, but do not hamper the germinal and proliferative zone. So it's again a relatively safe. But it is the zone of 3, Salter-Harris type 3, that involves the germinal zone and the proliferative zone along with the Salter-Harris type 4. And in Salter-Harris type 5, all the layers are become compressed, so this is the most dangerous one. You remember one important point: every long bone has two fascial physes at its two ends, but only one is very much powerful. So almost 75% growth potential comes from that one. And we can all remember it by remembering the direction of the nutrient artery that we all remember in the first year of our medical life. To the elbow I go, from the knee I flee. That is the direction of the nutrient artery. And the maximum growth potential physis lies opposite to the direction of this nutrient artery. In case of Salter-Harris type 1 and 2, we recommend not to manipulate after max 7 to 10 days. But in case of Salter-Harris type 3 and 4, because of the intra-articular extension, they must be reduced to get the optimum result. Remember these few points before taking any decision of treating a fascial injuries. Amount of time has elapsed from the injury. As I've already mentioned, in case of Salter-Harris type 1 and 2, you do not manipulate them after 7 or 10 days. Age of the patient: younger the child, more will be the remodeling and healing capacity. Location of the injury: if the injury is towards more the 75% growth potential side, it will remodel well. And that is why supracondylar fractures usually do not remodel well as the proximal humerus fracture remodels. And definitely you have to determine whether the remnant of the physis or the physis are going to help you to remodel, or is it going to cause more problem in the later on with future as the time goes, because the physis, when the physis is actually itself involved. So these are the points you need to remember before making any treatment plan. One of the most complication of this fascial injury, you all remember, is the fascial bar that we are going to talk about shortly. So these are my take-home messages. Fascial injuries is definitely common in pediatric orthopedics. Most of the time they have a very good outcome, but it is always not like so. A lot of cofactors that I've just mentioned you need to take into your account before making any treatment plan. A long-term follow-up is important, and always don't forget to warn the parents about the possible deformity that may come later on, but assure them they still have a treatment option at that period of time. Thank you all.
Outset, IFICS Foundation would like to thank POSB for inviting us for a long overdue IFICS. We did one many years ago and missed out on one. And I would request everybody to stand for 30 seconds in the memory of Dr. Faruqi Raza, who passed away. Unfortunately, this IFICS is dedicated to departed soul. The philosophy of IFICS. We want you to learn through cases. There are hardly any didactic lectures. Whatever text gives you, everybody can read from the textbook. But we are here to see how cases can teach us, what can our experience teach you. And as Dr. Bobby has already said, the only universal truth is that the child grows. And we are dealing with a child that is growing. So what is more important than treating injury to the part that grows? That is the physis. And he just beautifully told us that the child grows towards the shoulder. That means away from the elbow and around the knee. So the fast growing physes are the ones which are going to do the most damage to the child's growth in case they have any kind of injury. Whereas the slow growing physes around the elbow are not going to be much of a problem. The worst case scenarios are proximal humerus, distal radius, lower femur, upper tibia, and lastly the ankle. So let's start with a case in our typical fashion. This is a 9-year-old male who came with a 5-day-old injury. Now this everybody knows is a Salter 2 injury.
and I am going to pick people random, especially those close to a mic. Right? So be careful where you sit. So the gentleman there who is standing already, can you answer this question? For this physis Salter 2 injury, okay, I'll show you the X-ray again. He's run away from the mic. Okay, he has the mic in his hand. What will you do? Close reduction and pinning, open reduction and pinning, percutaneous technique and pinning, or you will leave it alone, it will remodel?
Sir, I will try close reduction and pinning.
Close reduction and pinning. Okay, so Salter 2, 5 days old. Anybody wants to do open reduction? No, very good. Percutaneous techniques and pinning. Some leverage technique, some intrafocal. No. Leave alone will remodel. Fantastic. Very good. So I don't need to take this lecture. Most of you are already well educated. So somebody who was not so well educated decided that he must get a good looking X-ray. So he went ahead, did an open reduction and did some internal decoration with 3K wires. Okay, so the X-ray looked good. He was happy. He could charge the child for putting 3K wires. And he was very happy. His wife was happy. Okay. And this is what typically happens in a real time scenario. After 3 weeks, he said, now time to remove the wires. So he removed the wires. And after removal of the wires, everything looked perfect. Child had no pain, good range of motion. Everybody was very happy. But as time went by, his child started coming back. And now what was happening is, his hand was deformed and his ulna was overgrowing and his radius had stopped growing. Right? So this is a typical scenario of what can happen if you don't treat a proper treatment is not given to a physical injury, especially those who come delayed. Whereas this is another child, same injury, he came about 8 days later, and this is the X-ray who has come to you for second opinion. Okay, Dr. Mehdi, what will you do for this child? Let me ask you. 8 years old child, look at the lateral X-ray, look at the quality of plaster. I am not very happy. Would you like to do something, improve the situation? Or you accept it? Reduction. So you take him to anesthesia, OT and reduce and give a cast. Okay. Okay. So the surgeon who was treating this child was not very brave. He said, let me leave it alone. So he did nothing. Nothing was done. 3 weeks later, he removed the plaster. Child had no pain, but the X-ray looked terrible. And there was a bump. But what happens after some time, 3 months later, you can see that the physis has started remodeling. And in 6 months, he had no deformity, full range of motion and no growth arrest. So what has this case taught us? Delayed presentations and physical injuries unite very quickly. 5 to 7 days is all that they need for the physis to stick and gum up. You remember, physis is growing end. It has largest blood supply. It is in a hurry to heal and start growing again. If you interfere and do any kind of manipulation and damage those germinal cells, then you are the culprit. Whereas left alone, the physis did much better. Right? So this is what happened. So always there is this dilemma that when you have a Salter 2, which is the commonest injury, how many attempts should you make to try to heal or reduce this fracture? And the answer to that, repeated efforts at reduction do nothing but damage the physis. These injuries unite very quickly. Any attempt to correct any malposition after about 5 to 7 days are likely to do more damage than any good to the physis. Please remember this statement. Okay, so anything that is more than 3 to 5 days old in a fast growing physis, better left alone. Resist the temptation to put wires at all, especially when it's a physical injury. This is a 2-year-old which was treated with a K-wire and later on ended up with a growth arrest with a focal bar where the pin was placed. Right? So these things do happen in day-to-day practice, and that brings us to the next question. Do pins really cause growth arrest? all of us use K wires left, right and center, and in fact in pediatric orthopedics that's the only tool we have. We hardly use any other implants. K wires, at the most elastic nails and a lot of plaster. So what is the evidence? The evidence is really unclear. Between 1965 and 75, that is long time ago, published data says that Muller from Germany had pinned all lower end radius and he did not encounter a single growth arrest. Okay, this is what is reported in literature. But a Swedish paper said large diameter pins, in 3 cases they found growth arrest. Okay, and what they said was repeated attempts to pass the K wire is the one that caused damage. It is not the K wire, right? Recently, Min Kocher from Boston Children's Hospital, they did a MRI study and they tried to find out if the pinning has any effect after stabilization of the physis. So 11 patients, they did MRI at 3 and 6 weeks after pinning and they did not find any damage to the growth plate. Okay, but they did not consider threaded pins as was being talked about, the duration of pin placement or the attempts at placement, right? So what it means is that a smooth pin done in single attempt and kept for minimum time does not cause a growth arrest. If you do too many attempts, use large diameter pins and damage the physis, you are going to cause a growth arrest. So please remember in your practice, don't use pins more than 1.8 or 2 millimeters when you are crossing the physis. Please remove all those pins in less than 3 weeks because as I said, physis heals in 10 days. So no need to keep pins for longer. You can keep the plaster longer, but remove the pin as early as possible. Never use threaded pins, never use titanium pins, which evoke a very strong bony response. Don't use too many pins, don't use too many attempts, and try to be as perpendicular and as central as possible. So, secondly, avoid the perichondrial ring. You might think that you are away from the physis, but you might hit the periphery. And a perichondrial ring injury can also cause a growth arrest. Keep them for a very short period of time and you can continue immobilization with plaster for longer. Or then there is a way of avoiding the physis which is called intrafocal pin. So this is a pin which is going into the fracture. It is not holding the distal fragment at all, but it is just buttressing it. Okay, like the Saw-Kapanji intrafocal pin for lower end radius, similarly you can put an intrafocal pin which can stabilize. Biodegradable pins have been tried by some people, but again evidence says that they are very weak, and to put a biodegradable pin you have to first drill multiple times, make a tract and then put the pin. So it makes no sense. You are damaging the physis in any way. So not really recommended at all. There is displacement and breakage of pin, right? So those were a few concepts about a fresh fracture which I wanted to share. Let's move on to the next case. This is a 10-year-old boy and this is his ankle injury. Premal Bhai is going to talk on ankle fractures later, but this is a fascial injury. Most injuries around the ankle would be fascial injuries. So let me share with you this case, and I want again opinion from the delegates. I think, sir, you can pick out somebody to answer. How will you treat this?
I am requesting from the delegates.
Okay. Okay. Anybody wants to volunteer? Nobody wants to volunteer. Yeah, okay.
Sir, I want to do a cast and just simple reduction.
Okay, reduction, close reduction and cast.
Yes,
okay.
Sir.
Okay, okay. So what is the fracture? Can you just tell me the classification for this?
Here we are seeing there is a fascial injury and medial condyle.
Medial malleolus.
Medial malleolus.
Okay,
fracture.
but what Salter type is it?
Type.
It is going intra-articular and intrafascial. So this is 4. It's going into metaphyseal region. Okay. Right. So now this was treated by an adult orthopedic surgeon. Yeah, as they do. This was treated by a closed K-wire and a plaster. Now I want somebody to point out all the errors in it. Yes, sir.
I think this was a type 3 shoulder radius injury.
Okay.
And the pin should go, pin or either the screw should go leaving the epiphysis intact. It should go second term?
Transverse.
Transverse.
Okay.
Transverse,
So-
avoiding the injury to the epiphysis.
Correct. Good. And is the reduction satisfactory, doctor?
No.
Are you happy with the reduction?
Though there are some stepping is there.
Yeah, there is a step here. So again, you have to realize that these 3 or 4, type 3, type 4 injuries are intra-articular. Okay, and they are cutting across all the layers which Bobby told us. Okay, all the 4 layers of the physis, and they are likely to create a growth arrest. And they are shear injuries, okay, they are push-off injuries because of an adduction force, right? So this was kept for 6 months, and this is how it ended up with. Now you tell me, is this acceptable to the parents or to the surgeon in any circumstance? These are the things that we need to highlight and make you aware that should not happen, right? So please don't treat like this. So this is exactly the same injury, a Salter 4, acceptable or operate. You can see there is always, when you see this adduction injury, you will see intra-articular and there is a small metaphyseal break here, right? So these kind of injuries, especially if you take a lateral x-ray, this looks like a triplane fracture, right? Always try to get additional imaging if it is possible. If it is possible, that will give you a clearer picture and you can give a better prognosis to the parents. I have been coming to Bangladesh, this is my I think 5th or 6th visit, and every time I come I discuss with Sarwar and I tell him the roads have improved, the bridges have improved, the quality of presentations have improved, people are absolutely on dot nowadays, things are getting better and better and better. So sooner or later, Sarwar, you are going to get patients in Dhaka who are going to demand the best because they can afford the best. And you cannot say, I will not do CT. I am in an area where nothing is there. I will treat it with plaster. It is time that everybody upgrades to the newer investigations also. You will need the CT. I am not saying that clinical examination is not king. It is still king. In the morning you saw Premal and Taral show. Clinical examination gave you the diagnosis most of the time. Where is the ecchymosis? How is the pulse? Similarly, the deformity of the ankle will tell you what is the injury. But to quantify it and fix it accurately, a CT scan for ankle injuries and fascial injuries is pretty useful and should be used. So this can be treated percutaneously with a system like this. Minimally invasive with an arthrographic control where you have arthrogram, a transverse screw because this is a shear fracture, and that posterior Salter 2 component has been fixed by an anteroposterior screw. So this is really minimally invasive, just a puncture here, a puncture there. You have reduced it well, you have assessed your reduction with arthrogram, you have shown and demonstrated articular congruity, and you have good holding screws. As Taral said, we don't need too much compression. You can put a fully threaded screw also, but it is important to hold it with a threaded implant and not a smooth pin which can displace in a transverse plane, right? And these screws again can be removed in 6 months. This is how it healed up, and this is the result at 6 months when everything was healed up nicely. This, yes. Yeah, sir.
The one had complications, growth arrested medial malleolus. What did you do?
We'll come to that.
Okay.
I'm building up a story. So you will get the answer. Like picture abhi baki hai. So at 6 months of age, this is how it should be treated and this is what should be done. So another example, a comminuted type 4 intra-articular with a fascial injury, the plan should be percutaneous aspiration of hematoma and arthrogram. You can see here when I put the dye how everything is just disorganized, and when I reduce it how nicely it gets organized automatically. This is just a dye. It is 1 cc iohexol omnipack, 1 cc normal saline. Diluted dye, put it intra-articular, take a C-arm shoot, reduce it, get a good reduction, put your percutaneous guide pin, put a screw, and you will have a wonderful reduction and a wonderful stabilization with just that small hole, and then a plaster. So we can't do without a plaster. There is no need to put big plates. There is no tension band wiring for medial malleolus in pediatric ankle fractures, please. Pronation external rotation injury, again you should be aware that periosteal sleeve may get trapped. Another example, a screw is in the metaphysis and a small smooth pin is across the epiphysis. And remove the pin as early as possible. The screw can be removed later. Okay, so there are small tips and tricks, and that is its function at healing. Type 3 and type 4, again, just to summarize, are intra-articular and intraphyseal or transmetaphyseal. Both are the highest rate of physeal arrest. 1 and 2 are decent. 4 and 5 give higher rates of arrest, and 6, of course, which is a peripheral injury. So these have to be treated by intra-articular alignment and removal of interposed soft tissue, and may have other associated injuries. Again, this is, you have 2 X-rays in front of you. Both are lower end femur. One is a younger child, one is a slightly older child. How would you approach these now that you have some background? Right? Salim? You want to answer that? You are in trouble because a lot of you have come to Pune and worked with me. I know your names. Okay? Anything you want to say? How will you treat this? What type is it? Come on, use the mic. Type 4. Which one? The smaller child is type 4? Left one. Okay, you feel that is type 4, but I can't see intra-articular there. So, this smaller child is Salter 2. It is a big Thurston-Holland fragment. And this one, which seems to be like a type 1, okay, actually if you blow it up, there is an intra-articular component there. So again, as I said, a CT scan or an MRI is not a bad thing to do when you are dealing with physeal injuries. So this was treated with percutaneous assisted reduction. Whenever you want to use a screw, keep it metaphysis to metaphysis or epiphysis to epiphysis. Never cross the growth plate with a screw. If you are going to cross a growth plate, a smooth pin, and remove it early, right? That should be your philosophy. So K-wire assisted reduction followed by a screw fixation and then a plaster. This is how this was treated. And this, which was a Peterson 3, which seemed Salter 1, actually had an intra-articular component. So all these fractures must be treated by small screws, 4 mm cannulated screws. Rarely do you need anything larger like 6.5. Nowadays you get headless screws, the Herbert screws. Larger ones also are available, and you should protect them with plaster. So take care of your soft tissues, the perichondrial ring and the periosteum. Use your instruments very carefully. Smooth pins have to be inserted in one shot, and screw thread should never cross the epiphysis. So yes, use the mic so that everybody gets.
If it is Salter is 1 or 2 with a very small metaphyseal fragment,
yeah,
then what should I do?
So like again, so the Salter, the Thurston-Holland fragments have been classified into 3 types. Like you said, very small, medium size and big.
Right.
When you have a big one, a screw in the metaphysis is the best way to fix it. If it is a very small one, simple reduction and plaster well molded is good enough.
No need for any K-wire?
Nothing.
Okay.
Because as I said, it heals very well.
Right.
If you feel it is very unstable, if you want to pass a pin, one smooth pin going into the center to hold the pieces together, and then a plaster. But again, in 10 days you can remove that pin and continue with plaster. Don't leave a smooth pin in for too long.
Thank
okay?
you, sir. Thank you, sir.
So these are the principles. So let's go back to the earlier cases, as Sarwar was saying. Now that 9-year-old who had that growth arrest. Now let me go to the experts. Premal Bhai and Taral, time for you to contribute. What will you do when you have a growth arrest in a 9-year-old child, distal radius? Leave it alone, tackle at maturity, bar excision, fat grafting, corrective osteotomy, or epiphyseal disease of the ulna. I'll go back to the X-ray for you.
So I think at 9 years there's a significant growth left for the ulna. So if you decide to ablate that growth, you have to take a consent of child parents that there is going to be at least about a centimeter or 2 shortening of that forearm, which usually doesn't matter. So if they do not choose to accept, I think the only option we have is to do distal radial lengthening. You can lengthen slightly more and maybe you want to come back again, or then at later date you can fuse the ulna. If the child does not want, the parent doesn't want multiple surgery, I think the best option here would be just to do ulnar shortening and at the same time fuse ulna.
So you will do ulnar distal epiphysiodesis with shortening.
With shortening.
Primarily.
So in one surgery, everything is.
Forget the radius.
Yeah. So radius, if the from the X-ray, the left uppermost X-ray, I can feel that it's almost about.
So
30
again,
to 40%.
the next question, I spoke about advanced imaging. Do you want something more?
From this X-ray...
means imaging wise.
Yes, of course MRI will help, but looking at this X-ray which you have given...
I have MRI.
Yeah, so there is about 30-40% and distal radius do not have a very good track record of success of distal physial bar image, physial bar opening or physiolysis.
Okay.
So that is why I think a patient, I think what patient wants and what you can give is somewhere the balance you have to balance that you have to match.
All right. Server, any inputs from your side? How would you tackle this? You have this 9-year-old child who's been treated by your colleague by open reduction K-wire. Unfortunately, now he's got a growth arrest and now he's coming to you. Doctor, you are the greatest in Bangladesh for pediatrics.
No.
Do something for me. Become God.
It was that case had 3 K-wires.
Yeah.
Okay. So
same one.
Bar excision is an option, but it will be difficult.
This is the MRI. You want more imaging? This is MRI. Taral, I want your inputs also on a couple of things later.
Do you have CT?
No, I don't have a CT, unfortunately. MRI is there. MRI is showing you there are 2 bars. One is here, one is here.
So bar excision, metaphyseal window.
9-year-old, bar excision, metaphyseal window, and what about ulna?
Ulna, I'll leave it alone. If I have to do, I'll do it later.
Later.
I mean, if it can catch the growth and compensate.
Okay. Taral, couple of inputs from you. One is about reliability of causing a distal ulnar physiodesis and reliability of bar excision for lower end radius.
So any physis which can grow fast will also recover fast. So any physis which is growing slow will also recover slow. That's generally a dictum. Lower end radius grows fast, but somehow it doesn't recover fast. And hence I have not found a bar excision to be of much value in treating physial bar of lower end radius, unless it's a very tiny bar. See here, you can see that almost 40% of the physis is gone.
Yeah.
And we don't know condition of the rest.
Correct.
So rather than putting efforts into recovering that physis,
correct,
it is better that we stop growth on the other side, because equality of lengths will not matter in upper limbs as it matters in
correct. So you would ablate remaining physis of the radius and the ulna.
And ulna.
Okay. So fair thoughts. So you got a lot of inputs. Now you can see these are very tricky decisions. These are best left to experts. General adult orthopedics, I don't think should venture into bar excisions and recovery of growth plates. Let it, because they are not predictable, number one. And the outcomes may not be what you want in spite of your experience and in the best hands. So like Taral said earlier, server, I had decided that I have identified the bar and I have isolated the bar, so let me excise the bar. So I went in, I had all the tools, steps of surgery, I took all photos saying that some conference I will present this as a success. Okay? So this is long time, about 2013. So I put the markers, you can see I resected the bar, I used a burr, you can see that cavity here. Then I put the markers, then I put a screw to stop the growth of the distal ulna. I put fat graft and I was waiting patiently. Now this will start growing. I waited for 3 months. I waited for 6 months and nothing was happening. Right? So to cut a long story short, what I wanted, nothing of it happened. He came back later. At maturity, you see the screw has migrated inside. So Allah also didn't fuse. So a man's best laid plans are put to naught by nature. Whatever you might plan, you don't know. Okay, so bar excision can be a little tricky job, especially lower radius, as Taral said. And now at maturity, this boy had an ulnar plus with impingement, and now quietly I did the second surgery. I resected and shortened the ulna and lengthened the radius with a monolateral fixator, and I got the length and the variance back to what he wanted, and eventually he's got good movement, right? So that is what had to be done. This is another 11-year-old Taral. This is post-infective osteomyelitis with growth arrest, with ulnar overgrowth. Will you approach this the same way or something different you will do?
This is a difference in the radial ulnar variance.
Okay.
And you have two choices here. Either to lengthen radius or to shorten ulna.
Okay.
Third choice is to do both.
Both. Okay.
So if someone wants one surgery approach,
okay,
versus a two surgery approach, if you have to lengthen radius, you do an osteotomy, put a fixator,
Okay.
let it lengthen, put a graft, big procedure. What you do is you break the radius, lengthen acutely on table as much as you can, then shorten the ulna and use that graft and put it in radius.
Correct.
So one surgery will,
take care of both. Okay, so we are seeing that everybody is concurring that you may need more than one surgery. So when you counsel the parents for fascial bar excisions or reconstructions, please be sure that you talk about that there may be a need for further surgery at maturity. Younger the child, you will need to do something. You can't let it worsen under your watch. But Taral, this was a post-infection, and you know what I did? I said, let me see the behavior of this particular fascial arrest. So I just observed, and you know what happened? It started growing. The radius which was not growing, after the vascularity came back and the infection went away, it just started growing because of hyperemia. And I did not have to do anything. So sometimes again, our biology can fool you. So for various situations, I would always recommend give it 6 months of observation time to see how is the behavior of a particular fascial arrest. Is it recovering? Is it worsening? If it's worsening, you will go in. But this fellow kept on recovering and I did not have to do anything. So the fasces just recovered. Okay. So going back to the ankle, Sarvar, this is for you again. So what do we do for this? The wire was removed. Now again, this child was still young. I had a focal bar and this was the MRI. So you can see 80% of the distal tibial fasces looks good. There is a focal bar on the medial side. The fibula obviously is overgrowing and pushing the ankle mortise into varus. So 5 years of growth left, overgrown fibula, arrested medial distal tibia. So my plan here was I did an opening wedge distal and I went into that fascial bar through the metaphysis, and then I used a distractor. I cut out a segment of the fibula about a centimeter and I used that here like a strut to correct the ankle, shortened the fibula, and from this entry point I removed the fascial arrest bar with a burr. So we excise the bar, put a fat graft, I put a plate on the fibular side, I put the fibula which I removed from here on this side, and I removed that tether. And this is the longer follow-up. This is after 1 year. You can see that the column healed up. This did not stick back. This kept open because of the fat graft. Okay, and the ankle mortise was restored and he had excellent function at maturity. So this is the way we tackled this particular problem, right? So he's fully functional today, completely healed up and completely normal as an adult. So there are a lot of reconstructive procedures. So just to summarize, we don't have too much time. I think I have 20 minutes more, 11:20. Yeah, so 15 minutes more and 5 minutes for discussion. So we should know which ones cause arrest. As Bobby has already said, anatomy of the fasces is important, but also the blood supply to the fasces. From where does the blood come? So any epiphyseal injury which injures the blood supply and resting cartilage will cause a growth arrest. So type 3, type 4 and Peterson 1, that is comminution or missing fasces, compound fracture. These are going to cause growth arrest. And rank type 6, which means a perichondrial or a peripheral injury. These are always going to cause some kind of a peripheral arrest. Now the growth arrest may be complete or partial, it may be central, peripheral or combined. You should understand what does the bar do to the growth. If it is peripheral, it will cause a coronal plane deformity or a sagittal plane because it's on one side. If it is central, it will cause tenting, tethering and change in the articular alignment. And if it is patchy or mixed, it is going to cause a lot of shortening. Okay, so when you look at a bar, you try to quantify it morphologically into these three types, and the early signs you must detect, the Harris growth arrest lines. Whenever you don't need MRI, MRI can come later, but if you see after a fascial injury, you see a parallel line of bone growing parallel to the physis. It means there has been temporary growth arrest, it has started growing, but it is not going towards a certain point, it's parallel. So growth has resumed, there will be no problems. Okay, and when you have a bar, you must map it with an MRI or a CT scan and then see where it is, how big is it, and then how do you tackle it. So again, this is a posterior peripheral bar which can be tackled very nicely. So the determinants of treatment are: what is the age, which bone, is it slow growing, fast growing, where is it, central or peripheral, how much is it, less than 30 to 50% is better, more than 50 you don't excise a bar, and is it traumatic, vascular, infection or radiation, right? So these are the determinants, and your options are either, as Premal Bhai said or Taral said, you can completely ablate it, do an osteotomy, repeat the osteotomy later, do bar resection for restoration, lengthen, or a judicious combination of all of these. So I'll give you some examples. This is a progressive valgus deformity because of a diffuse peripheral bar in a very young child. Okay, this was not resectable, so what we did was we excised the medial physis completely. So I created epiphysiodesis distally and corrected the deformity. This is another example where there was a runover injury, Peterson 6, with fascial arrest. So this was treated by an external fixator, BB Joshi type. We distracted and then I did a medial fasciodesis and corrected that deformity to a neutral position for the child to be able to walk. This is a 15-year-old with a fascial arrest. As Taral was telling us, ulna is overgrowing, the slope is changed, length is not an issue. Simple osteotomy, just an osteotomy with ulnar shortening. So there are so many options available to you to get a reasonably good outcome, and that is how it healed up over a period of time with good function. 17-year-old, old radial fascial arrest. Now this was purely a short radius which needed lengthening. So again I shortened the ulna a little bit and I lengthened the radius with a monolateral fixator. This is again long time ago. This was his balanced forearm when the healing was done. This was his function and this was his ability to do all his routine activities. So bar excision is a specialized animal. You have to map the bar, excise the bar and interpose something. And that interposition material can be fat, cranioplast, cement, a lot of things. So again I'll run through a few examples of fascial bar excisions here. This was a femur fracture. Somebody thought this is isolated femur, Thomas splint treatment was given. But he came to me with a progressive flexion deformity in the knee. They first thought that this is likely to be because of Thomas splint. So they kept on giving physio. But he kept getting worse and this was his MRI. He had a posterior fascial bar which we mapped and then we went ahead with a posterior approach. You can use these arthroscopes, C-arm or dental mirrors to visualize the bar and when you resect it. So this is the way we went in for him posteriorly, and with curettes and burrs I removed the bar. To look inside the cavity you can use an arthroscope which will magnify and give you good light, and once that is removed we put fat interposition. These are the materials, like I said, you can use, and we use fat because it's cheap and it works quite well, and you can put markers to monitor growth, whether they are moving apart as the child grows. So this 9-year-old, this is the bar excision and this is a 7-year follow-up. His deformity reversed and his range of motion was maintained. So that is at maturity. He did have 1.5 centimeters of shortening, but that we did nothing because it was manageable with a simple shoe raise. Now this is a Salter 2 injury in a 2-year-old girl. Now this child had a progressive varus deformity and that was the fascial bar that the child had. We mapped it. Now this was a very young child, so what I did was I went ahead and did a metaphyseal osteotomy. This is a very old case of mine. So metaphyseal osteotomy, went into the center, removed the entire bar, put a fat graft there, and I used a small Jess fixator, mini fixator to hold it till healing. So this was how the bar was excised and fat was inserted, deformity corrected. Very small child, we gave a plaster in addition. This is a 5-year follow-up. Ankle mortise looking quite good. And this is her clinical appearance, and this was her function. Running, jumping, doing all activities without any problem. And she kept in touch with me. Fortunately, this is a 12-year follow-up. She is now studying in BSc, and this is her fully grown up with completely normal ankle mortise and no pain and all functional activities restored. So well done bar resections, well chosen indications, the child can do really, really well. This is an example of a central arrest with tenting of the tibia. Like I said, the articular margin can get tented, fibula overgrowing. So that was resected and we did a distal femoral epiphysiodesis, and that is the restoration of the plateau as is seen, and the deformity which was improving. This I showed you. So this is Taral's case. This is another interesting case. This child was hit by a cricket ball on the medial side of his knee, and he started developing a progressive deformity. This is an example of a rank type 6 peripheral perichondrial injury and a peripheral fascial bar. So this Taral treated by excising this. Okay, so what he did was he excised that bar to restore the growth and untether it, and he did a growth modulation on the other side. He put the markers and the cement. Okay, and you can see the effect of this. This was 6 months post-op, this was 12 months post-op, and this was 18 months post-op. So gradually the medial side grew, lateral side we slowed down, and when we removed the 8 plate, he had grown so much with perfect restoration. So this is one way where you can restore growth very reliably. This is an iatrogenic lateral fascial bar. 8-year-old fracture femur, somebody did elastic nailing, they put a lateral sided nail through the growth plate and progressive valgus on one side. You can see that on MRI. Again, peripheral resection, epiphysiodesis on the medial side, and gradual correction over 1 year. Okay, again one more case, unilateral progressive valgus, peripheral bar. This I did recently and I was surprised, Taral, this is interesting for you to see. I put growth modulation one side, I put cement here, I put the markers and did fasciodc. You know, the cement broke too. The power of growth, not only did the markers grow apart, even the cement broke into 2 parts. So I was quite surprised. I took that X-ray to show that how much the growth can come back provided things are done well. So she's got excellent correction now.
And so fast, just 4.5 months.
Very fast. It just happened within no time. So let me summarize. What does IFICS recommend for you? You have to classify fascial injuries for proper treatment and prognosis. You have to use advanced imaging when required. Early reductions will help, but do them within the first 5 days. Don't treat aggressively after 1 week except when they are intra-articular, because you have to restore the joint line and warn about growth arrest. So use minimally invasive methods, and you have to counsel the parents. For the fascial bars, diagnose the bar early, monitor the effect of it. What is happening because of the bar? Which bone is affected? What is the age? Use an MRI to map it. Plan the appropriate correction. This is a specialized surgery with a learning curve. You need some equipment for it, and always keep a long follow-up. Thank you very much. So we have 5 minutes for discussion.
Yes.
Any questions from your side? 5 to 10 minutes.
Thank you, Sandeep, for your nice and valuable discussion. Now, now we are inviting questions from the junior delegates.
We can have the lights on.
One question just. Fat or bone cement, which you prefer?
Fat or, yeah, very good question. So, cheap, readily available is fat. The problem with fat is that when you release the tourniquet, the fat can, with the blood supply, go away. Sometimes there is a gush of blood and get washed off. So if you are using fat, I still use it. I take a vicryl stitch to anchor the fat into the bone so that it doesn't get flown away like when there is bleeding, because all this is under tourniquet. Okay, that's one, and it works quite well. my rationale always has been, somehow I feel that fat has got some kind of a enzyme. If you see congenital pseudoarthrosis or synovial pseudoarthrosis, wherever there is non-union, you will find fat. Fat has some property which does not allow bone to form. So where you don't want bone, put fat. So fat works very well. Cement, you have to use a big packet and only so much is used. So cost is one problem. Second, there is a small concern that whether the heat may cause further thermal damage to the remaining facies. It doesn't happen. A lot of papers are there on cement. We are using cement. We haven't seen any untoward thing happening. But it's your choice. Both can work.
Thank you.
Thank you, sir. My question is distal radial growth arrest with positive ulna. And there is already dislocation of the inferior radial ulnar joint. I am lengthening the radius or shortening the ulna. What about the stability of distal radial ulnar joint?
Correct. So good question. But if you see, these are not traumatic disruptions of the DRUJ. Because of slow growth, it is just overstretched. So when they come back to their length, they contract also, the soft tissues. So there is no problem with instability like in traumatic DRUJ disruptions or TFCC that you feel. That doesn't happen.
One question from my side.
Yeah.
Why author that a gluteal fat rather than the abdominal fat?
Same thing. I think Langenskiol studied it and said that gluteal fat has that peculiar property of inhibiting. But I don't use gluteal. I take it from wherever it is locally available. If I am doing ankle, I'll take from the calf. But they say, and they say gluteal because probably you can't see the scar. So you flex and take from the buttock area, it grows within the clothes. So it's probably a cosmetic and totally Western concept. So
now we like to hear from the other two bands.
Yeah, last comments, since there are no questions, Taral and Premal, and we are well within time.
I think facial injuries, the first chance is the best chance.
Condyle, the average age is around 6 years, and as the fracture pattern is less distorted, so in case of lateral condyle facial injury diagnosis, clinically, radiologically is less obvious. So for accurate diagnosis and decision making, we need internal oblique view, as Tapas sir maintained. And there is two mechanisms that fracture occurs. One is push off and one is pull off. And between these two mechanisms, pull off or avulsion theory is more advocate. Avulsion force on the condyle fracture causes fracture extend to apex of the trochlea. Facial fracture that occurs through the ossific nucleus of the capitulum is less common, but it occurs when child falls forward on his or her palm with the elbow flexed. The radial head is forced against the capitulum, and it can be classified by either Mills, Jacob, and Song classification. Mills classification is anatomic classification where fracture extend through or around the capitular ossific nucleus. And in case of Jacob classification, it shows amount of displacement. One is Mills classification, and another is Jacob classification, and this is Song classification. So distal humor facial plays around 20% of growth of humerus. Result is good if we do operative treatment within few days. Why? Because when clot comes with fibrin, it develops. Fibrin develops and it becomes more difficult to operate. In operative technique, we should go through brachioradialis and tricep interval, and we shouldn't go posteriorly through auriculum fossa. So here are some complications that occurs. There is a lateral spar formation, elbow stiffness, cubitus varus valgus, delayed non-union, neurological complication at growth disturbance. And that's all from ABCD of lateral condyle fracture. Thank you.
He will start his interesting case discussions on lateral condyle fracture of humerus.
So lateral condyle fractures are again very interesting. They are a fascial injury, right? And it's a controversy what type of fascial injury they are. They are type 2 or 4, but definitely they are intra-articular fascial injury. Now I want to ask Professor Query, sir, what is the challenge in lateral condyle fracture? Why are we so much concerned about this simple fracture? Because it doesn't cause myositis, it doesn't cause ischemia, but still, it's an enigmatic fracture. And sir, what do you feel about lateral condyle fracture which is bothering us? Yeah, mic to Professor Query.
This fracture is peculiar that it ends up with non-union and deformity later on.
Excellent. The problem is non-union, and the whole idea is how do we decide, which are the ones to be left alone, which are one to be fixed. Fractures in children always heal, they always unite. Supracondylar fracture will malunite, but it heals. Lateral condyle is an enigmatic fracture because sometimes it doesn't heal. Now from the previous talk, we know that good x-rays are essential, good quality x-rays are essential, and we need to take x-rays out of plaster or out of slab. This is essential. We also know that internal oblique view is essential, so all of us know about it, and it's important to know the classifications. We have been told about the classification. The Jacob is undisplaced, which is known as just a crack. Jacob 2 is split. It is not completely turned around, just split, and Jacob 3 is completely turned around. The problem is with Jacob 1, because Jacob 1, we really don't know whether to conserve or to operate. Should we operate all Jacob 1, or should we conserve some, or should we conserve all? That is the biggest dilemma, and I am trying to solve this dilemma. Because when you have a patient like this, we really don't know what to do. Should we treat it in plaster? Should we do MRI? Should we put a pin? Should we do arthrogram? And somehow this dilemma doesn't get solved, and we sulk. The sulk stands for seemingly undisplaced lateral condyle fractures. So that's the name for it. It's not an official name, please, so don't quote it in the exam or literature. It's just done by me. And when you sulk, we need to have something wow, and wow stands for words of wisdom. And what we know from literature, that undisplaced lateral condyles are almost half of lateral condyle fractures. They have very little pain because there is not much of hematoma, and that's why many of them are just elbow injuries, not much of pain, and a pediatrician will give analgesic and send the patients home thinking that is elbow sprain, but actually it is a fracture, and it's difficult to diagnose. Almost 40% of them will displace if they are not treated, which means 60% of them will still heal in plaster. Just because 40% will displace or go into non-union, you don't have to treat each and every lateral condyle which is grade 1. This is something which is important. We know that, if we fix all lateral condyle fracture, we are over-treating 60 to 90%, so which is also not correct. We can't say this is fracture of necessity, and moment there is a lateral condyle fracture, all should be pinned. Because as Professor Query mentioned, the resources are limited, anesthesia facilities are limited, the OT timings are limited, and expertise are limited, so you can't pin all. We know now that if displacement happens, it will happen in first 5 days or a week. After that, it is very rare for a fracture to displace. For example, if someone is stayed married for 10 years, it is very difficult for that person to divorce later. Okay, so similarly, if the fracture of lateral condyle is not displaced in first 7 days, it will not displace early. So now we know that X-ray to be taken at 7 days is important if you are conserving a lateral condyle fracture. Okay, so basically lateral condyle fracture which are undisplaced are of two types, because we can see only the upper part on the X-ray. We can't see the articular surface on the X-ray, we are unossified. The one on the left will always unite even in plaster. The one on the right, which are extending to the articular surface, will displace if treated in plaster. But unfortunately, on an X-ray, it is difficult to make out. On an MRI, we can make out this, but it's difficult to do MRI for all the patients. You cannot advise MRI for all children with lateral condyle fracture. And hence, it's important to arrive at some logical conclusions, some wisdom in treating this fracture. Now we know that if fracture gap is less than 1 mm, 0% will displace. It's a safe zone. You can conserve everybody where fracture gap is less than 1 mm. But Sandeep, how do we measure this 1 mm? With what caliper or which scale do we measure? We can't measure this 1 mm distance. If fracture gap is more than 1 mm, then almost 48% will displace. But to an orthopedic surgeon, it's very difficult to measure. So rather than fracture gap, we should come up with fracture patterns. And I'll come to these fracture patterns in a while. So fractures which stop short of epiphysis, which are only in the metaphysis but don't penetrate into epiphysis, will not displace. So if you have a fracture which is only in the cortex or in the metaphysis, not going into physis, you can 100% put it in plaster. Fractures which are parallel, they are likely to go into the physis. The fracture which is convergent, it is likely that it will not break into the articular surface, so you can definitely conserve them. So these are some of the guidelines we will use, in the algorithm which I am going to say. So apparently lateral condyle, apparently undisplaced lateral condyle fracture, you take X-ray in internal rotation, that's the first step. Then you measure the medial and lateral gap. So if the displacement is less than 1 mm, or if the fracture is convergent, or fracture is only in the metaphysis, then you label them as a stable lateral condyle fractures. Whenever you have stable lateral condyle fractures, what are you going to do is just put a slab, a well molded, thick, good slab for a week. And that should be done with wrist in extension. Why wrist in extension? Because the dorsiflexors of the wrist are attached to lateral condyle, and they are the ones which are going to displace the fragment. So you relax them. And then you take an X-ray again at 1 week. If it's still undisplaced, you maintain then you convert into plaster, which you give for total of 4 weeks. Okay? If they displace in fracture, then you will pin them. You can still pin them, there is no problem. Now those which are undetermined, meaning they are displaced 1 to 2 mm, they are parallel, you are still not sure, you have two choices. If facilities are available, you can do MRI. And if MRI shows that the fracture is going into the articular surface, then you pin them. If it's not going into articular surface, then you don't pin them, you just treat it in plaster. If MRI is not available, you can still plaster them. Take X-ray at 1 week, and if they don't displace, you continue with plaster. If they displace, then at 1 week also you can pin them, there is no problem. However, if the fracture is more than 2 mm displaced, and it has a large medial gap as compared to lateral gap, then those are unstable and those have to definitely be pinned. So now we know from this algorithm that not all lateral condyle fractures need to be pinned, you can be selective. And almost 70% of lateral condyle fracture you can do away with pinning. So let's see some real life examples. So this is a lateral condyle fracture, again not seen on any of these X-rays. You take a internal oblique view, and the fracture is only in the metaphysis, it's not going into the physis. So I want to know from audience, this is Jacob 1 and Song 1. This is a stable fracture. So how many of you want to treat this in a plaster immobilization? Raise your hands. How many of you want to do an MRI for this patient? Anybody? No. How many of you will still go down and fix it with a K-wire because you don't want to take a chance? So it is, consensus clear, Sandeep, everyone feels that this is the patient which should be put in a slab. At 1 week you take out the slab, take AP, lateral and internal rotation, all X-rays, okay, out of slab, because within slab the X-rays won't be clear. And if there is no further displacement, you will not see healing. But if there is no further displacement, you continue plaster. And in younger children at 3 weeks or older children at 4 weeks, you remove the plaster, take X-ray again, and if it shows good healing, then you continue, you just follow up them till union and then discharge the patient. This is second patient in which the fracture is going ahead, okay, going ahead, and this is the geometry of the fracture. This is the internal rotation view. Internal rotation view. So how many of you want to conserve this fracture in a plaster? Many. How many of you want to pin this? It's a more extensive fracture, you don't want to take a chance. okay, in plaster. So this was indeterminate. You really don't know what will happen. You need to tell the patient that follow-up is a must. This patient, ideally we would have done MRI, but patient refused the MRI. So we give a above elbow slab in 90-degree elbow flexion, forearm in supination, wrist in dorsiflexion. All the three components are essential. This is the X-ray at 1 week. You see that there is some bone formation laterally already happening there. There is no further displacement. So you continue with plaster, and at 4 weeks this fracture has completely healed. Another lateral condyle fracture, 4-year-old elbow trauma. This is a convergent fracture. You can see that lateral is wider, the medial is narrower. Okay, so this is a fracture which is there, definitely more than 1 mm displaced. So in this patient, how many you want to treat with plaster? How many of you want to fix this with K-wire? Okay. So this patient was a doctor's child, and we still wanted to take a chance, and I just want to show you, this is the patient. If you take an MRI, what will it look like? I don't want to say that you should do MRI for this patient, but if you take an MRI, this is a fracture where it was going into the articular surface and definitely this would displace if this fracture was treated conservatively. You also know here the direction of the fracture. The direction of lateral condyle fracture is not vertical, it is oblique. And because it's oblique, you will know that the wires have to go from posterior to anterior. If you pass transverse wire, it will not hold this fracture very well. Okay, so these are again MRI images to show the direction of the fracture, and again here the wires have to go from posterior to anterior because that will fix the fracture very well. So this is just to know the anatomy of the fracture. And this patient, we did a arthrogram and then put just 2 cross K wires, divergent, maintain it for 4 weeks, confirm that the fracture is healing, then the wires were removed. So minimally displaced lateral condyle fracture, where you are putting wires just for holding, preventing redisplacement, you can leave the wires outside. If you are doing K-wire after a reduction, a displaced lateral condyle fracture, if you reduce and put a wire, those wires should be kept inside because that fracture will take a longer time to heal. And if wires are outside and if you remove them early, those are the patients which will go for non-healing. So these are some of the tips I'm going to share with you. This fracture healed very well. This is an 8-year-old child, and again here you can see there is a big fracture gap. Medial and lateral both are same, parallel fracture. So this is definitely an unstable fracture. In internal rotation you can see that it's a fracture which is going into the articular surface. This is Jacob 1 but song 3. So when you learn this music that the notes are different, Jacob 1, all Jacob 1 did not be treated in plaster. This is something which 100% requires pinning. And these patients, when you see under Siam and take a varus and valgus view, you will realize they open up on varus and they reduce in valgus. So you should reduce them with valgus of the elbow, valgus stress of the elbow joint. And once you reduce, then you fix them with K wires here. Okay, it's a choice here. We don't need to do an arthrogram in these patients. Jacob 1, song 3, where articular surface may be broken but it's not displaced. It's not a must to do an arthrogram. You can just reduce and pin and fix them with wires. You don't have to use screws, and these wires can be left outside and then removed at around 4 weeks. Now if when you come to fractures which are little more displaced, 6-year-old child, more swelling, okay, more pain, instability, clinical examination, as Sandeep said, is something which is important. Then you suspect that this is not a simple lateral condyle fracture. On AP and lateral, it doesn't look much displaced, but when you take an internal rotation view here, this fragment completely rotated. This tells that this fracture doesn't have any connection to the parent fragment. It's an unstable fracture. This fracture needs to be reduced and fixed. It cannot be fixed in situ. It needs to be reduced and fixed. And how do you reduce and fix? You put a tourniquet here, because sometimes you may require an open reduction. So put a tourniquet and give a varus stress. during the surgery, what you do is rotate the arm internally, because internal rotation will bring the fragment in profile. If you try to pin in AP and lateral, it's not going to work. You have to rotate the arm internally and then push in a wire through the fragment. And this is how the wire, very gently, if you're using a drill, use a low torque, just gently put it. You don't want a very fast drill here. And then you pass the wire. This is gone from posterior to anterior because the fragment is posterolateral. The direction of the wire is important. Once you pass the wire, then you do an arthrogram here. If you do an arthrogram before passing the wire, your dye will spill all over and you will not have any vision. So it's much better to first put in the wire and then do an arthrogram. This is to confirm the congruity of the articular surface. There are two ways you can do arthrogram. My needle has gone above the radial head into the elbow joint. You will get some hematoma, and then you give around 1 or 2 cc of 50% diluted dye, and then once you put in a dye, this is how you will see. Once you put in the wire here and then put in a dye, this fragment will be delineated, and you will see as you pass the dye, you maintain elbow in around 15 to 20 degree flexion so that the elbow joint is seen well. If you keep elbow completely extended, you will not see the elbow joint well because of the overlap. So now you see that, this is very well seen. Can we have a pointer? Okay, so this is the sulcus. This is not the fracture side, and you can see that the elbow trochlea is very well, delineated. There is no step, so your reduction is proper. Okay, and then you keep these wires on, and then you realize that there is a distraction at the fracture site, and that's why the only wires are not going to work. So what you do is, over the second wire, pass 2 wires, and over wire which goes through the column, you drill the wire across the fracture site, not through and through, across the fracture site, and then you pass a threaded screw. Now this compression is required because this is a shear injury. It is an unstable injury. Just putting K wire may not work. So if the metaphyseal fragment is big enough, you will pass a screw through the metaphyseal segment. So now you have a wire and a screw. And in these patients, what we do is, you follow up the children, the wire is kept outside, the screw is inside. The wire is removed after a month, because then you can mobilize the patient. The screw is kept inside for 6 to 7 months, and then screw you will remove later on once the fracture completely heals. Okay? Now once screw is removed, many times you see this bump here. And I want to ask Professor Mehndi, what do we do about this bump? Is it a failure of treatment? Is there something I did not notice? Should we remove this bump? What should we do? Mike.
I think if it does not create any problem,
it feels bad. It looks bad and hurts. Sandeep, what is the cause of this bump, and why do we see that? Yeah. It is not painful, but
it's just bump, and it's maybe the lateral part of the trochlea.
No, it's not lateral part of it. It is the common extensor origin. Sandeep, you want to answer that? What is, in your experience, why is this bump formed?
So lateral spur formation is a known phenomenon in all lateral condyle fractures, even if you conserve them. So you will get hypertrophy of the lateral condyle because of hyperemia, periosteal irritation, and a pseudovarus. The parents will come saying that hand looks different and straight. It's not a real varus deformity. Yeah. I have cases with conservatively treated lateral condyle with the same bump, and nothing needs to be done. It goes away after some time.
Absolutely. You just tell parents that it's going to go away. The parents are worried because it looks like a varus because of the lateral bump. And it can come with plasters, it can come with screw. Ideally when you remove the screw, you can remove the fragment. But if you're not going to, if you're treating conservatively, it's not required to remove it. You can see that over a period of time that blunts away. That blunts away and becomes completely alright. And then you stop feeling this pseudovarus feeling. So this is a longer follow-up which shows that everything is alright. Now coming on to open reduction and fixation. And the important thing here is when you have a lateral condyle like this, which has been missed, and then a displaced lateral condyle like this, when you take a clear X-ray, you realize, at least in my hands, I don't do close reduction and pinning for these patients. A completely displaced lateral condyle fracture, which has restriction of movement. You can see on a lateral view also, this is displaced anteriorly. And on an AP view, also there is an opening up and displacement. So these require open reduction and fixation. Those which are flipped over definitely require open reduction and fixation. And the approach here, CT scan is of course not required in these patients. This patient came with a CT scan and had restricted range of movement. So you have to restore the anatomy. The choice of approach here is a lateral approach. And what is important is that you have to preserve the posterolateral attachment to the fragment. So I'm going to show you how we do this case. It's a curvilinear incision over the elbow joint, center over the lateral epicondyle. You have to take a longish incision. You don't want to struggle through a short incision. So you cut skin, subcutaneous tissue, and then reflect your flaps. Because you are not interested in lateral condyle. You are interested in opening the anterior capsule of the elbow joint. You want to see the joint. And what you do is you ignore the fragment, and from the lateral sharp border, lateral border, you erase the mobile VAD, the brachioradialis. You erase that and go on to the shaft of humerus, the lower shaft of humerus. And from there you go on to the anterior capsule of the elbow joint. And then you open the anterior capsule of the elbow joint so that you can see the fracture very well. You are not disturbing the fracture. You are not trying to, mobilize the fracture from the fracture fragment. You are trying to mobilize the fracture from the joint, from the fracture line. Okay, so from fracture line you slowly mobilize it. You try to move it. Be very gentle. I am using tissue forceps, Adson forceps to hold this fragment, and not bone holding fragments, not bone holding forceps. One of the other thing you can do is pass two wires through the fragment like a joystick. So I'm using a periosteal elevator into the fracture to just mobilize it very gently, turn it around, rotate it, use Alice forceps, tissue forceps, because you don't want to damage the blood supply to the fragment. Now you can see the fracture line is seen very well. It's clear. You can see the articular surface. You can see the physis, which is white. Okay. And now I am passing the wire to act like a joystick to help me in accurate reduction. And then same wire will help me to fix this fragment. This has to be done very calmly and patiently, in a very non-orthopedic manner. Ask your assistant to give a valgus force. Don't forget all these steps, because valgus will reduce the pressure over the fragment and will allow it to reduce. And then fix this. I've used one wire into the column, as Sandeep said, and then the other wires are going across the joint, para-articular. So multiple K wires to provisionally fix this. So this is how the wires look like. And then one screw across the column to give compression when I retain the other wires to maintain rotational stability, because you can not use multiple screws here, and you don't tighten it too much. So this is intra picture after putting the screw, and there are some of the pictures again to see. It's important to see the joint. It's important to remove the capsule, anterior capsule, so that you can see the joint well. This is after fixation, and you can see this other one wire and a screw fixation. That is the construct I use. start early mobilization after 3 weeks of plaster, and wires we remove early and the screw later on. That's the protocol I follow. So this is at 3.5 years, no deformity and has full range of movements. I want to also describe one peculiar approach, posterior approach for open reduction, which was described by one of our seniors from KM who is in UK, Dr. Neil Kamal Mohan. 4-year-old child with lateral condyle fracture and elbow dislocation. And how would you approach this? I want to know. So Sandeep, fracture dislocation, what approach? Would you reduce this close? Is it possible, or you have to open and treat? So for these kind of injuries, acute injuries, which are unstable, I have used a posterior approach. Now when you take a posterior approach, also the blood supply of the lateral fragment remains intact because it is posterolateral. The approach is posterolateral and you can keep it intact. So this is the blood supply. So whether you go from front or back, you can still preserve this as long as you're this pedicle, you are fine. And this is how the approach is. It's a curved posterior approach, going from posterior and curving around the olecranon. So this patient had this amount of instability, because it was a Milch type 2 fracture going all the way medially. And this is how the surgery actually happens. Pretty easy surgery. Anteriorly, of course, you can open the same fracture, but posteriorly it's much easier. So moment you cut skin and subcutaneous tissue and go and split the triceps or cut it with a knife, you are immediately, I'm cutting the triceps here, and immediately you are onto the fragment. Immediately. You see the fragment, you see the fracture, because most of this fracture is better seen posteriorly. Because anteriorly, the olecranon and the ulna covers a lot of lower end, the distal end of humerus. Posteriorly, moment you flex the elbow, the entire humerus, lower end of humerus is open in front of you. So this is what you see. This is the fragment, the pedicle is intact and it's completely rotated. So for these rotated fractures, I feel a posterior approach also works. Again, you pass wires very gently. You don't allow this fragment to rotate. Hold it with a hand and pass the wire, because this is going to act like your joystick. By mistake, if you don't hold that fragment and the wire rotates the fragment, then all your blood supply is gone. So it's very important to take care that way. And then you are going to turn this fragment. So always use 2 joystick wires, because you get then 360-degree mobility of this fragment. You can turn it front and back, anteroposteriorly, mediolaterally, or in whichever plane you want. And that's the reduction. You can see the articular surface very well through a posterior approach, and that's an advantage. And you can see this is a 4-cortex wire. It is going through the olecranon fossa, and because it gives a good stability. I hope you all can see this is how a capitulum wire for supracondylar also goes. And here we have an opportunity to actually show it to you live, how these wires will go. And because this was a stable fixation here, we did not put any screws. We just put 3 wires, we bent it, buried it inside and closed the skin. So overall, a very simple approach again here to a problem. So what we have learned is we have learned the indications for Jacob 1, which would be song 1, 2 or 3, undisplaced fracture. When do we want to fix, when do we want to put a plaster. In unstable, undisplaced fractures or minimally displaced fractures, we've also learned how to do pinning in situ. For hinged fractures, we learned how to do a closed reduction, arthrogram and fixation. For a completely displaced fracture, we have also learned today two approaches. One is a lateral approach and a posterior approach with different indications. And I hope with this, any lateral condyle fracture, anybody in this audience, will be able to treat well. So if there are any questions or comment on acute lateral condyle fractures, I'm happy to take. We still have around 20 minutes to go, and after some of the questions, I will go on to the delayed presentations. Professor Query, you want to say something? Yes, please come on to the mic.
Yeah. Taral, when in which cases you go through posterior approach, whether they are more
unstable ones.
Unstable or older one or the younger boys?
No, especially Mills type 2, which are extending right medially, sir. Where an anterior approach, it's very difficult to see and see the intra-articular portion.
Yes.
The fracture which are more lateral, the lateral approach is good enough, which are going between the lateral condyle and trochlea. But if something is going into the crista of the trochlea or way medial, then I would prefer to do a posterior approach.
In recent cases, in old cases, is there any difference? Say in the recent cases, is there?
Yeah, in the recent cases, I think posterior approach works much better. But in older cases, anterior approach will be better because you can dissect much better over there. The fragment is flipped anteriorly. So I think I would do a lateral approach. But everyone should experience both approaches and see which approach they are more comfortable with.
We always learn in our learning period, not go posteriorly. But he is saying this posteriorly is also safe.
Yeah. No, we can't hear. Can we give him another mic? You know by attending this, my previous lecture, but this is ununited. Not much pain, has 40-50 degree range of movement. So this is range of movement which the child had. How do we treat this? I want to know from audience, how many of you will leave this alone? Don't treat it. Yeah, one person, two, no treatment. How many of you want to still continue plaster 4 weeks, 6 weeks and feel this will heal? How many of you will open this, reduce it back? And of course, keep your hands on. How many of you will also bone graft this? Okay. So this is what we used to do. I have treated fractures like this with open reduction, maybe sometime minimum grafting, sometimes screw, sometimes K-wire, till the time we came across this paper. This paper is from Andrew Howard, and he said that non-union within 4 weeks can be treated with a percutaneous screw fixation without grafting, without even opening. Okay, without Professor Bari doing Elizarov, this non-union can still heal. So it doesn't require active intervention. Now this fracture was 20-week-old, and Premal, are you going to defy Howard and say I'm still going to try putting a closed screw in a 20-week, 5-month-old non-union? Premal, over to you.
Taral, I think what Andrew has written in his paper is that up to 18 months they were successful. They had so many which were beyond 18 months, and the cutoff period was 18 months. And we also have in our paper published that up to 18 months we had all who united with a technique which you are going to describe.
Absolutely. So this technique, I'm just going to show you how to do this. Take X-ray in Siam in internal rotation. Try to do varus valgus to see mobility of this fragment. and do arthrogram. Arthrogram is just to confirm that articular surface is reasonably well aligned. Okay, and there is no step. And then you pass first K wire, and this wire is going to hold this fragment. So this is passed in internal rotation, and then over the wire you pass a drill percutaneously, and over the drill you pass a canceller screw. Again, there is no washer here. You will always see that the screw of the head remains away from the bone because it is over soft tissue. It is over the soft tissue, and this screw is probably doing the job of just holding this fragment. Maybe it is irritating the bone and causing the new bone healing. But this is post-op X-ray. This is after 4 months. You can see new bone formation without any grafting, and at 7 months this is completely healed. So, and this is the range of movement. Initially the range of movement was restricted, but after fixing and getting union in a fracture which was not 100% aligned, this is not anatomical reduction, but the range of movement improved and this fracture healed. So, these patients, Premal, me and Sandeep, we have done number of these patients now, and now published in Indian Journal of Orthopedics. Premal, can you just summarize our experience about lateral condyle fractures which are not united, somewhat displaced, and you can still fix with screws?
Just to go through a little bit of history, Andrew described this in about 2014 or 15, and he said he was the first person to describe that percutaneous screw can heal a minimally displaced lateral condyle fracture. And then when we wrote a paper, I did a research and we found out that somebody in 2000 had already reported it.
So it was a republication.
Yeah, the credit was taken by Andrew and his team, but
So Premal, it was not invention, it was a discovery.
It was a discovery.
Right.
And that gentleman actually wrote after this paper to JPO, and they just published at a small footnote at the end where nobody can find out. So sometimes it's not all the discoveries come from US and Canada. There are so many discoveries come from a smaller African countries or European countries. Anyway, coming back to the paper, so our experience is that Dr. Andrew Howard felt that every time you do this surgery, you must have full flexion, full extension, and full movement before you can do that. And we have proven that once you fix it, you get a movement. Because say in India and Bangladesh, if a child comes to you with a delayed presentation of lateral condyle, if you ask them to go for physiotherapy, if he gets full range of movement, he will run away and not come back to you and come with the cubitus valgus. So when you have an opportunity, if you pass a screw, it's most likely to get union in majority of the cases, and then gradually the movement comes back. So in a situation like us, if we are going to learn, as Taral described, there is an Eastern problem. If you look at the West for the treatment, we are not going to find the answer. For the Eastern problem, we have to look within ourselves and on the Eastern side. So whenever the child comes with you with the presentation with Taral showed, there is a reasonable articular alignment. It's not very late. You don't wait for recovery of the movement. Pass a percutaneous screw, get a reasonable compression, and it is most likely that you will not read any open reduction. You will not dissect anything. There will be no elbow stiffness, and probably you will be able to avoid avascular necrosis of your wrong dissection, and child doesn't get a big scar.
So disclaimer is, quickly, one more comment, please.
My question, there are some patients come at the age of 18 years, 20 years.
We'll cover that.
Very old age with a cardiac and pulse.
Coming to that. I also have a lady who came to me at 45. Don't ask me as a pediatric orthopedic surgeon why a lady came to me at 45, but I'll answer that. So disclaimer is, this is also 3-month-old fracture, but it is displaced, tilted. This cannot be treated with a percutaneous screw fixation. This requires to be opened, reduced well, and then fixed with multiple K wires or maybe addition of a screw. Sandeep, you were saying something? All right. Now, people who come really late, as Professor said, after 6 years, after 18 years, sometimes after 45 years. This is an 8-year-old girl. This is 3 years after injury, a non-union lateral condyle. She has good range of movement, no tardial nerve ulna palsy, Nothing, no symptoms. I want to know from the audience this non-unions. This is a bad complication, non-union. How will you treat? How many of you want to treat this with close reduction and screw fixation as Premal has written? Nobody? How many of you want to do a bone grafting and osteosynthesis? Bone grafting, osteosynthesis. How many of you want to do osteotomy to correct this deformity, correct it and fix it? How many of you want to don't do anything for this? Nobody wants to do nothing? Sandeep, what will you do for this girl? You know, she has no problem. She's, you know, girl from Kutch, she's playing, has no ulnar nerve palsy.
Yeah.
What are the chances that she will get ulnar nerve palsy in future?
No, more than the ulnar nerve palsy, what we feel is no problem is highly tolerant Indians and Bangladeshis probably. Because if you ask them to compare and lift right and left hand weight, the entire extensor mass is attached to the loose fragment.
Absolutely.
And they have pain. Only thing is it is not very significant, so they won't complain of it. Because they are extremely tolerant. And there is no high impact sport involved. So this left untreated will drift and drift and drift and cause more deformity and more problems. So fix it while you can.
Is it written in a horoscope? What will happen?
I don't believe in horoscopes.
Okay. So we need to know the natural history of what happens to a lateral condyle fracture if it's not treated. So this is a lady, 40-year-old, and she came to me not because of elbow problem. She came to me because of hand problem. There was tingling numbness in the hand, and she was finding it difficult to work. And when we look at the elbow, you know, there was a deformity. Now she came to me because her child had a supracondylar fracture which we had pinned. So if you treat a pediatric fracture well, maybe the child's parents will come to you, father will come to for ACL injury, and grandmother will come to you for TKR. So it's very necessary to treat all pediatric fractures well. Stop attending AO meetings, joint replacement meeting. First attend IFICS so that you treat your pediatric fractures well. Okay? Alright. Anyway, she had good range of movements, but tardial ulnar nerve palsy. So what do we know from literature? See, this is a literature, long-term literature. 84-year-old follow-up of a non-union lateral condyle. So which means the patient must be 90-year-old. And this report says that that patient was a musician, not a patient at all, normal human being, and was able to do everything. Another follow-up, non-union lateral condyle without ulnar nerve palsy, 60-year follow-up. So such follow-ups are available, which tell us that if you don't treat, non-union really doesn't create a problem if there is no problem. But if you fix a non-union, open reduction, internal fixation, anatomical reduction as it was done in this case, it leads to stiffness, it leads to pain, it leads to avascular necrosis of the fragment. So a traditional approach to a non-union, which is osteosynthesis, is not treatment for lateral condyle non-unions. If there is no problem, you can leave them alone, or at least treat only the problems and not the non-union. So if there is cubitus valgus, you can do an osteotomy and correct it. If there is tardial ulnar nerve palsy, you can do an anterior transposition of the nerve or do an osteotomy and relieve the pressure on the nerve. If there is instability, which a lot of patients have, which we don't ask for, you need to fix this fragment in situ so that the common extensor origin gets some anchorage, and then they don't complain of pain while dorsiflexing the wrist and can do their work well, they write the papers well, because writing for 3 hours requires wrist to be in dorsiflexion. Do you have to still write your papers? In Bangladesh, in 10th standard, you write a paper? Right, we don't type a paper, we still write a paper, and it's required to be done. So long-standing lateral condyle fractures requires a problem-oriented solutions. What is the problem? This is a child, has good range of movement, lateral condyle non-union, 2-year-old, acceptable deformity, no instability, no palsy. Either you can fix this in situ with a screw still, or don't do anything for this patient. Absolutely fine. This is a girl who has tardial ulnar nerve palsy but not much of deformity. So you can do a transposition of nerve, get her ulnar nerve to recover. That's also fine. This is a child who does not have palsy but has instability, can't write a 3-hour paper. A brilliant student but not able to complete her answer papers. You just fix the fragment in situ, maybe with little bone grafting, and this will work. Or when patients have all these problems, unacceptable deformity with a palsy, with instability, you need to take care of all the three. And I'm going to show you a small video. This patient was operated by me and Sandeep alone, a doctor from Bombay and from Pune, operating in Ganga Hospital at Coimbatore. A case which no one wanted to take up in a live surgery course, they gave it to us. And I'll just tell you what we did. We planned to do a osteotomy with ulnar nerve transposition. So this is how it was planned. A medial osteotomy to get a bone wedge, put a plate medially, put a screw in situ, and put that graft in that gap, so that we took care of the entire problem. And this was all done with ulnar nerve transposition, with a single approach. So posterior approach to the elbow. I think that's Sandeep, your hand or my hand? I think that's me using scissors. So we were operating together. For all those who don't know, we are batchmates from 11th standard. We know each other since a long time. We end up wearing same clothes. We have similar mobiles, same laptops. He is married to a pathologist. I am married to a radiologist, and we have both 2 sons. So we are living parallel lives and operating. So ulnar nerve separated, going on to the non-union and the posterior aspect of the elbow. You can see this is Sandeep's fingers feeling the non-union. In Hindi we call it as ungli, fiddling around there. Then a medial plate, very simple plate, recon plate, just need 2 screws above and below after the osteotomy. You do the osteotomy, take out the wedge, translate. It's important to translate, because otherwise you will have a big bump on the lateral side. Milch's osteotomy, you need to translate. So this is how we planned it. We put a wire through the fragment and check the elbow movements to see the elbow joint movements were not blocked. Some blockage you will have, because some movements do take place at non-union. But if there is complete blockage of movement, this is how we translated it and fixed it provisionally. Fixing the non-union at the same time with that wire. A plate, you can bend this plate easily. You don't need anatomical plates. So this was a non-locking recon plate which we put. This case we finished surgery in 45 minutes. Sandeep, you remember? And that's a screw over a wire, and whatever graft we removed from the wedge, it was put in this, and then we compressed it. You can see that bone over there, which is compressed with this screw. So that's the sort of a fixation post surgery. The valgus is corrected. You have a normal carrying angle. The fracture is fixed. The ulnar nerve is taken care of, and this patient did well. In this girl, this lady, also we did an osteotomy. I planned the wedge and then translated it. This is how it is done. So this is angulation and then translation, and then this is fixed. So in the video, this is how it looks. You don't take a wedge. You can just angulate and translate it and fix it. After, ulnar nerve you can see it's been separated. So that's how the osteotomy was done. And in this girl, this lady, because most of the movements were occurring at non-unions, and it was, we decided to leave the non-union alone and fix this just with a plate. We didn't fix the non-union in this. So you have to be little, as far as decisions are concerned, you have to be little legitimate and do it. So in summary, as far as late presentation lateral condyles are concerned, this is what IFICS recommends. If they come below 6 months, those who are minimally displaced and has at least 50 degrees range of movement, you fix in situ. Those which are tilted and displaced, you should do open reduction and fixation, but this should be done by an experienced pediatric elbow surgeon. You have to keep the blood supply intact and make sure that you don't get restriction of movements post-operatively. If they come after 6 months, If there are no functional issues, you just leave them alone. But most of them have some functional issues if you really probe deep. Ulnar nerve neuropathy, you do transposition. Cubitus valgus, you can do osteotomy. Instability, you can do in situ osteosynthesis. But most of the patients have all three. So you will end up doing, through a posterior approach, osteotomy with in situ fixation with transposition in most of these patients. So I hope that answers the question which one of our delegates asked. Yeah. And with this, I end this lateral condyle session. From my side, I think we have 3 minutes. We have overshot the time here. Sarwar, do we have time for few questions? We should. Okay. Before the inauguration. Yes, please.
What is your preference for anterior transposition on either subcutaneous or subpostal or submuscular? Or what is the better?
Subcutaneous anterior transposition works very well. Submuscular can be done, but it involves more dissection. You have to dissect more. So that should be okay. It's not a problem. But you must write that in the notes, because if somebody is going to operate again, that patient must know that ulnar nerve has been transposed. Yeah.
Sir, again, in cases of late vegetation, less than 6 months, you have mentioned that minimally rotated conditions you can fix by percutaneous cannulated screws. How much minimally rotated? My experience, I am sharing 2 or 3 cases I have tried. If I fix it through the screws, to the metaphyseal area, there are some stepping remains in the epiphysis, in the trochlear zone, where there's some rotation remains inside. And later on, there is a big gap. The lateral column on one side and middle column on the other side grows, and there is a big
like a valley,
gap.
like a valley. Yeah.
Like a valley. That happens.
Yeah.
That happens.
If the range of movement is good, that doesn't matter.
That is what happens all the time.
So my target is to fix the mobile fragment.
Yes, target is to fix the fragment,
right.
and child having full function, good range of movement,
not looking
and no
at
instability.
The anatomy of the trochlea.
Not required.
Okay, thank you.
Your job is to fix the condyle to the column. Forget the trochlea.
Yeah. But if it's badly displaced, and if that rotation is
free, if it is type 3, you have to undo it, of course.
Undo it, yeah.
Let's finish this session.
Yes.
So next session is our inauguration of this IFICS 2023. This session will be conducted by Professor. This session will be conducted by Professor Sarwar Ibn Salam.
Session, and I call Professor R.R. Koiri, a great teacher of ours, to come to the stage. Sir, Professor R.R. Koiri. Professor Imamuddin Ahmed. Sir, to the stage, please, sir.
We will take 15 minutes time. So within 15 minutes, I say a part. Senior to me. So he is the senior most. He is the partner and the next senior. And so I have asked him to rate our sounders. So this is, I don't spend much time in the inaugural session in all my meetings of the, initially I started hand surgery in 2006. For 12 years I was the president and I led this subject. Then I started pediatrics orthopedics in 2012. Sarwar is the main man, I am only his guide. So this subject has grown so much that we could create posts of 37 posts in different medical colleges, in different categories from professor, assistant professor, and registrar, etc. So this subject has grown up within this since 11 years. And Baral is our
Taral and Sandeep and Premal. They are our friends, guides, and they have helped us in many ways of forming the association as well as in our all academic activities. So thanks. I will thank all the three giants of the pediatrics orthopedics, not only to us, even they are known in the whole world. And IFICS is so important and so interesting now that they are going to different parts of the world to conduct this. This is like AO of the pediatrics, not the adult orthopedics. So this is the beginning of this inauguration. I will ask now Professor Imamuddin sir to say some blessings to us.
So, thank you very much, Mr. President, Professor R.R. Koiri. He is truly innovative. Whenever he invites me, wherever I stay, I do respond. And whenever I came to know that three giant pediatric orthopedic surgeons are also coming to share their knowledge, share their experiences with us, with the junior surgeons as well. I could not keep myself seated in Chittagong or away from Dhaka. I came here to see you all. Inauguration, what is inauguration? Inauguration means whenever you have entered and you started saying, teaching something, it is inaugurated. But when the special word inauguration is there, I inaugurate this function with my heartfelt gratitude to the particularly the three academic experienced surgeons from Bombay, Pune and Ahmedabad. Am I right? Very much thankful to Sarwar, particularly holding this function in time. That is a great achievement. That is a great teaching. Truly a great teaching for us. And to the speakers and to the surgeons from abroad, the way you have maintained your timing is really honorable. And your teachings, I hope, our junior surgeons and seniors as well will keep it in mind. And we have learned so many things from you. We thank you very much again, once again. One more word from my experience. This is truly pediatric. When we treat a pediatric patient, possibly what I feel, we shall have to keep it in mind that you will have to treat a whole family of a patient. Because the pediatric patients may not cry enough, but the parents, they start crying. Supracondylar fracture, pulse is not available. The surgeon explained, oh, the pulse of your son, the pulse of your child is not available. They will start crying. So what should be our duty? We shall have to treat their tears, right? So that I will have my request. You must have to have some patience, and you must have to have a good counseling to the parents, to the whole family. I must thank the whole houseful audience. If I say audience, it will be less. I will be saying learned audience, because you are already orthopedic surgeons, but yet to be the pediatric surgeons. You have taken enough teaching from yourself, sir. Last night also I understood. I will be learning so many things, and really I learned so many things this morning. I thank you very much once again and invite you for your coming once again and enrich our knowledge and enhance the glory of the functions. Thank you. Particular thanks to Professor Koiri and Salam for their particular maintenance of timing in particular. And the venue, I do not know who has selected. Wonderful venue, wonderful venue, wonderful venue. Thank you very much, sir. Thank you so much.
I would request Dr. Tarulad to say something.
So Sandeep, come on, please. So on behalf of them, we want to really thank you all for coming here in large numbers and making all our efforts worthwhile. IFICS is very dear to all of us because Dr. K. Wilkins' teachings we were able to continue. I think we did 2000 in Bangladesh first time, and then this is the second time we are doing IFICS. I think the fracture management has changed a lot between the Posi-Posner course and the first IFICS and this IFICS. So we'll have to do this regularly, once in 4 to 5 years. I want all delegates to keep participating, and we should also do a feedback form for us to know what else they would like to have. More model demonstrations, hands-on demos, more videos. What is it additionally you would like to have in the next IFICS? Plus let us know. One more announcement I want to make is, I've spoken to Premal and Sandeep, and as part of IFICS Foundation, we will tie up with USD and have some of the orthopedic surgeons from Bangladesh to come to India for either short-term or a long-term fellowship. So this is between IFICS and USB, and those who come will get to spend time with Sandeep, Premal and me. Either it will be a short-term fellowship for 2 months, total, or 6 months or a year. We will work out the mechanisms for doing it, and the server will let you know about how this is going to happen.
I wanted to share that today I finished 21 years of my hospital, and what a best way of celebrating that is coming here and teaching you. I think the desire of we all had was that the way fractures were treated in children, because there's no specific teaching in a curriculum anywhere in the world to teach pediatric fractures. This idea was born way back in 2013, first time executed, and this is the 11th year of that, and it has grown such a way. And looking at the presence here, full house of such a big hall, it gives us immense pleasure that what we saw as a small seed has grown into a wonderful shrub. I think it still has to grow into a tree, and we are there to nurture it in coming years.
Thanks, Kevin. So again, let me thank you all for your hospitality. One, COVID taught us a lot many lessons. We could continue a lot of work of IFICS online. We did online courses. So the teaching never stops, and the idea is generally to make general orthopedic surgeons more fluent with handling children's fractures. It is not a specialized pediatric orthopedic surgeon's course. Trauma everybody needs to do in their country, and 30% of your trauma practice will be a child. The problem is, when we studied, we were also taught the same way, that children's fractures heal on their own and they remodel on their own and everybody is alright. Because nobody critically evaluated what really happens to them, or nobody gave that much thought. They thought that time takes care of everything. And we know now that it is important that we treat them well when they are children, so that they don't end up with problems in the future. Thank you again, Sarwar. You've been very greatly instrumental along with Dr. Koiri in spreading the word. And I would, more important, sir, is always to have a second line, which is equally capable and enthusiastic, and to develop that team is the true hallmark of a great leader. So, Sarwar, I appreciate, I was with Bobby in Vietnam, and he's an outstanding young man with excellent presence and teaching capabilities. You will never see him there. He will be sitting outside somewhere, managing the counter or something. So, Bobby, you are a great asset to Bangladesh. Noman and all the younger people, training them and making them aware
So like I said, sticking to time, making it crisp, cutting down on didactic lectures and no cut paste lectures. That is the key of success.
Thank you. There ends our inaugural program. Now till 2 p.m. we have lunch and prayer time. So এখন থেকে গেলে লাঞ্চ শুরু হয়ে যাবে 2টার সময় আমরা again sharp at 2 আমরা next session শুরু করি।
Plastic deformation very difficult to reduce. In case of complete fracture, there may be transverse fracture, oblique fracture or comminuted fracture. In pediatric field, comminuted fracture are rare. In case of complete fracture, need acceptable reduction and casting, whether it is conservative or operative. The vast majority of pediatric forearm fracture can be treated by close technique. Children heal faster than adults. Remodeling potential is high when is less than 8 years old and decreases as skeletal maturity is reached. Bayonet apposition will remodel. Montagia fracture. Dislocation of the proximal radioulnar joint caused by ulnar fracture or both. But in case of radiographic X-ray, true lateral view must check radiocapitellar joint. The radiocapitellar line must intersect the capitulum. Sorry, sir. In case of Galeazzi fracture, dislocation of the radius, the distal radius fracture with dislocation of the distal radioulnar joint. Galeazzi fracture treatment method: close reduction of the radius fracture and the cast approximately 3 to 4 weeks. If distal radioulnar joint does not reduce completely or it is unstable after 6 weeks or casting, consider open reduction and temporary pin fixation. Take home message: the closer fracture is to the physis the better remodeling potential. Thank you, sir.
To become lazier. You know, earlier when we were younger, we wanted to do elastic nailing for most cases. Now we are finding ways of avoiding those. How can I not do a nailing? कौन करेगा इतना झंझट, वो नेल डालो फिर निकालो, और ऊपर से then patients are not completely satisfied. So is there a way that we can treat them as conservatively as possible for as long as possible, for as many age groups as possible, in as many indications? So what we are going to do is run you through some interesting cases and tips and tricks. So 9-year-old, we have seen this since morning. Taral, this is one of Taral's favorite. So an intact green plastic deformation of the ulna and a metadiaphyseal fracture of the radius. How will you manage this? So let me start by waking up Taral. Can you give a mic to Taral? So what are the essentials of managing forearm fractures? We'll come to that. So this is a 9-year-old child. This is the X-ray, and how will you treat it?
Yeah, so one needs to differentiate in my mind. See, there is an isolated radial fracture and there is a radius and ulna fracture.
Okay.
If there is a radius and ulna fracture, then the radial and ulna lengths are matched. And if the alignment is maintained, there is evidence that even if you just align it and put it in a slab or a plaster with complete displacement, it will heal and remodel if the child is less than 10 years age.
Okay.
Isolated radius fracture, I want to,
treat
reduce
aggressively.
Reduce, yeah.
Okay.
I want to reduce and put it back.
So you will do a close reduction or open reduction?
In this, because of the edges, if you see a lateral view, there are sharp edges. Even on AP view, there is a sharp medial edge. And the reduction will be difficult. Now milking maneuver you can easily do when radius and ulna both are fractured.
Both are fractured.
With radius alone fractured, that's difficult. I'll be prepared with the intrafocal reduction here.
Okay.
But I know that if ulna is intact and once you reduce radius,
it's not going to displace further, and just a plaster will
Stable.
be adequate.
It will be stable. So a couple of interesting points Taral has brought out. One is that you have to differentiate between both bone fracture and single bone fracture. And between radius and ulna, you have to remember one thing, that the ulna is a straight bone and the radius is actually a bow. It's a curve. And when you want, what do you want in forearm? You want full pronation and full supination. Ultimately, that is the aim of all treatment of forearm fractures. How can I give full pronation and full supination? And if you look at the ulna, when you do pronosupination, you feel in your own hand. Turn and see. The ulna doesn't move. The ulna is a straight stable bone. So unless you have that curve of the radius going through the arc, you are not going to get full pronosupination. And the single most important determinant of that is adequate tension of the interosseous membrane. So the radius must be as away from the ulna as possible. So if you look at this fracture, what Taral said is that on the AP view, you can see that fragments are encroaching onto the interosseous membrane. So if you allow this to malunite, you are likely to lose pronosupination. So single bone fracture, especially the radius, has very low tolerance for conservative treatment. You need to do some kind of accurate reduction, restore the length and restore the bow of the radius. If you can do it closed or with intrafocal, very good. But Taral, this is what somebody was done, open reduction and K-wire. Now, what is your opinion?
So, of course, we'll take Premal's opinion also on this. But whenever you open a pediatric fracture,
this is like Sachin Tendulkar telling Sehwag, next ball to kill.
Yeah. So, if you open a pediatric fracture and don't fix it well, then non-unions are very common.
Guaranteed.
As long as you don't open, the pediatric fractures heal very well. Moving to open, you are for a trouble.
Correct. Premal, any comments on that?
So I just take 1 minute. A classmate of mine is a spine surgeon. His son had exactly same fracture. He's a second year postgraduate student now. And one of my colleagues, I was a very young pediatric orthopedic surgeon, fresh out of bakery, so he thought that a senior person would do a good job. So he took him to a senior orthopedic surgeon who did an open reduction and put a K-wire. Fortunately it united, but now that boy has about 2.5–3 inches scar. Then we started attending Dr. Wilkins' lectures and we started learning one of the reduction methods which he will show. Then came an era where Sheetal Parikh, one of our partners, published a paper in which joystick reductions were done. And then a beautiful paper, one of the best paper I have ever read in last 10 years regarding pediatric trauma, which came from Hawaii Island, where for the same distal end radius fractures, they just don't do anything. They just put it in a plaster. They just see to it that there is no angulation. They just don't do any reduction.
So that is what Taral quoted. He said less than 10 years. It was a paper which said less than 10 years, both bones. Just correct angulation, let it overlap, everything remodels.
And we have published our result. The only cause of distal ender and radius fracture to not unite is doctor. If they go to bone setter, it will always unite. It is always the doctors which make the things worst. I'm sure Sandeep will show in the story.
Yeah, so what happens, as Taral and Premal both pointed out, please resist the temptation of doing an open reduction in forearm fracture, one. And if you do it, your fixation cannot be an intramedullary single K-wire which is not even of the correct diameter. So typically this is what you can expect. Okay, this was a non-union with a bad angular deformity, and like I said, the interosseous membrane is encroached upon and you lose pronosupination. You can see the nice dorsal scar of open reduction and a bad outcome. So this is typically what happens. Second situation, Taral, both bone forearm, close reduction and K-wire. What do you think is going wrong here?
the issue is, wires are encroaching on the hematoma.
Correct.
In the interosseous space here.
So same level fracture and too long a wire and encroachment. So why I am harping so much on the interosseous membrane is, see, this is what happened ultimately. Yeah.
But this level of fracture is always a problem.
Yeah, so we had a fracture which was isolated only radius, second was radius and ulna, and both cases surgery has not done the job and they have actually given bad results. Now this is the third situation I am going to put to you. Apex dorsal injury, metadiaphyseal fracture again with apex dorsal. Premal bhai, you would normally put a cast in supination. That's all you need to do for correction of this. Somehow enthusiasm. Okay, again 2 K-wires and 1 transfixing wire. I don't know, somebody attended a lecture on Galeazzi fracture.
I think this is what is something extension of the adult trauma into pediatric orthopedics. I think if they had listened to Server well, that children's fracture are different. They are not miniature variety of adult fracture. I think what the gentleman has done is that he has miniaturized the principle, and instead of putting a screw, he has put a wire. Otherwise, all the principle of adult orthopedics has been very well followed in this patient, which were absolutely not.
Correct. So that is the thing, surgery is the answer, because then now what you have created from a simple torus fracture is growth arrest. Okay, so all the time passing K-wires is not such a good idea. Now this, again one more example for you. This patient had again a distal radius fracture, intact ulna, and somehow the surgeon thought that I must open reduce and put wires. So he got a beautiful looking X-ray, and at 3 months fibrous non-Indian. Why I am showing you all this? Because unless you see the failures which we see as specialists, because they come to us later, referred from elsewhere, okay, and then we have to deal with them, and then it's very difficult to justify and protect your colleague also as to why that surgery was performed in the first case when it really did not need any surgery. So if you look at the literature, Cullen has written about hardware migration, infection, loss of reduction, reoperation, nerve injury, loss of motion, synostosis, muscle entrapment, delayed union as the multiple complications which can all be avoided if you just do close reduction and casting. Again, Shoemaker's paper, 9 complications in 8 out of 32 patients, and so you must understand the principles. This is an example of a complete forearm fracture. 11-year-old, complete forearm fracture. This is how it is. Now the surgeon has done a close reduction. Premal bhai, would you accept this? This is the situation now. He has come to you with this situation.
So I will not accept this, but I will not do even open reduction. What I will do at this time is just do a wedge and get a better alignment. I am not much worried.
That is just a 15-degree coronal malalignment.
It can be accepted, but even then, if you can just get little bit better with a wedging,
okay.
You can
so
do
you
that.
would like to wedge and improve on the correct.
So I just want to quote Dr. K. Wilkins here. He was a big proponent of conservative treatment. But he said that just because children's fracture will remodel, you should not try your best to give the best alignment. So you must try to get your best alignment and leave the rest to the nature. You can't mistreat it.
Yeah, you can't accept anything.
Yes, yeah.
But you should know what is the limit of acceptability. Right?
So the only problem here is, of course, this will 100% remodel, but the thing is, for about a year or so, the ulna looks so bad that mother or father will keep on taking different opinions, and 1 or 2 people will definitely say that I would have operated. So then the confusion and litigation and misunderstanding starts.
Correct. So this was 2 months post-op, as you rightly said. Bayonet reduction, overlap, both bones, lengths are maintained, and at 5 years post-op completely remodeled with a full range of motion, right? So it's not that a bad looking X-ray means bad function all the time. you should just be aware, as Taral said, as to understand how to reduce the load on biology. You may not fix it, but you do a reduction good enough to reduce the load on biology and give a morphologically acceptable looking forearm. As Premal was saying, they will otherwise keep on harassing you if there is a big bump or a big deviation. Okay, so hanging on to these patients can be a big problem, and for that you need to know what is the accurate cast index. So cast index is basically the AP divided by the transverse diameter at the level of the fracture when you do a plaster. So casting techniques, I think today afternoon we have a workshop, right? Tomorrow we are going to show you how to do a good cast. Yeah, more and more we are talking about cast and how to do a good cast and how to prevent a displacement and how to manage it more and more conservatively. So if you have a cast index of 0.7 or less, which means they always used to say to have a straight bone you must have a crooked cast, right? Which means your cast should not be the same in AP and lateral. It has to be molded and it should be oval. It should not be round. If the cast is round, that means your bone is crooked, displaced, right? You must make sure that the 3-point molding is very good. Another example, an 11-year-old with a forearm injury. So, Mehdi sir, would you accept this? 11-year-old. So he is now into the adolescent age group. This is his X-ray, and fresh fracture. Acceptable? You will do a reduction. Okay. So after reduction, this is the position. Position is. Yes. So plaster molding is one thing, but are you happy with the correction that has been done? So let's go back to the X-ray. This is the position, and now this is the position. Does this look okay? If it is not okay, what is not okay? Okay, I'll spare you the torture. And we'll just go ahead. You look at the width of the proximal fragment of the radius and distal. These seem equal. Yeah? But on the AP film, look at the elbow. Look at the elbow on this film, the lower one here. You can see elbow in AP. Can you see the elbow in AP? And radius ulna in lateral. And here you can see elbow in lateral and radius ulna in AP. Yeah, so what happened is there is 90-degree malrotation. So be very careful of how you judge rotation. Okay, angulation is not the only problem. Malrotation is the single largest culprit of getting bad function. Right? So note the rotary malposition or malalignment, and how do you judge that? You have to look at the radial styloid and the radial tuberosity on an AP and a lateral view. So this was undone, okay? Distal fragment was supinated and it was put back into the earlier position, and that was the correct position. So when you look at an AP film, the radial tuberosity and the radial styloid have to be at 180 degrees to each other. Please remember that. And on the lateral, the ulna, coronoid and ulna styloid have to be at 180 degrees to each other. So the Evans concept, published long ago in 1951, I am repeating it. The bicipital tuberosity is at 180 degrees to the radial styloid. Okay, this is normal rotation on an AP film. And on a lateral film, the coronoid process is 180 degrees to the styloid process. So whenever you do close reduction of your forearm, make sure that on your AP and your lateral, these two parameters are right. And if they are right, your rotations are good. your rotations are good, you will not have a malrotational problem. Okay? So that is the second concept that you need to understand. If you go back to the original X-ray, actually when he came with the fracture, it was lying exactly in that same position. You just had to give a cast. In situ cast would have done the trick. Somebody took for close reduction and changed it to 90-degree malrotation. And then you wonder why there is no supination. Because you made it malunite in 90-degree malrotation. Okay, so that is very, very important to understand the rotatory malalignment and how to judge that on AP and lateral views. Okay, the bicipital tuberosity and the radial styloid and the ulnar coronoid process and the ulnar styloid on the lateral. So AP and lateral, that is what you need to look at. Both, yeah, so that tells you whether your fragments are in the correct rotation. Now this is another child, a 12-year-old, right dominant hand was a goalkeeper. Somebody gave a big kick and he was trying to defend the ball and it hit his hand and he got a fracture, he fell down. So this has been reduced. Taral, is this acceptable? So he's 12 years old. Again this boy, single bone, distal radius fracture on the first pronation X-ray, the X-ray apex dorsal injury of course. So it looks as if there is a distal radioulnar disruption. Again went to adult orthopedic surgeon, was advised plating. This is standard. Like Premal Bhai said, don't extrapolate the concepts of adult orthopedics onto children's orthopedics. He was just put into supination cast, nothing, just a supination cast, and this is his healing and function is completely alright. So as far as possible, if you know how to correct the angulation rotation complex, you will be very successful in doing excellent close reductions. So the art should be to secure supination and nature should be trusted to secure pronation. That is what has been written. What about redisplacements? Now most of us would do a close reduction. The patient goes home happy. After a week or 10 days, I don't know how many of you call patients for follow-up, but standard post-reduction practices, you have to call the patient after a week. Take a check X-ray and see how much the plaster has become loose. Because the minute edema goes away and the plaster becomes loose, it displaces. And you may need to wedge it or change the plaster, which is very important. So conservative treatment requires more attention. Every time you see a redisplacement, it doesn't mean surgery. Okay? So when you see such a thing, and as earlier X-ray showed, you should know what is acceptable and what is not. So this is a very important slide, the limits which were set by Price. How much angulation can you accept? Less than 9 years, about 15 degrees to 20 degrees. More than 9 years, about 10 degrees. Rotation, about 40 degrees to 45 degrees in younger kids. Above 9 years, not more than 30 degrees. And shortening is not a problem when there are both bones fractured. So this is what is acceptable limits. So if you know what is acceptable, then you will decide when to intervene. And this is a very good paper which is again written by Sheetal on re-reduction for redisplacement. Okay? So please remember that when you do a close reduction, after a week, 10 days, you might require a re-reduction. It is not a one-time procedure. You don't do a reduction, forget it and call him after 1 month. Okay, then they will be unhappy because inside some things may have happened which are not to anybody's liking. So checking a plaster after 1 week, but what they published was re-reduction after redisplacement following an initial close reduction gave excellent or satisfactory radiological outcomes and were safe, effective and less expensive as compared to open. So surgery is not mandatory even if it displaces late. So this is an 11-year-old who came with this injury, and in the plaster this displaced, and this was not an acceptable angulation. Okay, for his age this was definitely more than 15 degrees in either plane. So we had to correct this. Now the thing is, when there is a displacement there, immediately again the adult orthopedic surgeon creeps up and you will say, okay, open reduction and plating so that we are more secure, but that is not really required Okay, so what can be done is percutaneous drilling and osteoclasis, even if you have a little bit of callus there. Yeah, so if it is less than a week, 10 days, you can just crack that callus under anesthesia, make it corrected and give a plaster, and that will go on to good healing and good remodeling over a period of time. Okay, and that is his function, and that is the appearance of the forearm, and he continues to improve. This is a lower fourth radius ulna, 8-year-old child. This is what Taral was talking about, a young child, less than 10 years, with an X-ray which looks like this. Okay, now this was accepted, and this is the X-ray after 6 months and 1 year. So there is no reason to panic if there is a redisplacement, provided you know what are the limits of acceptability, at what age you can accept what. And please, as we showed earlier, open reduction for lower radius, lower fourth radius is not a very good idea. You will end up with more complications than good results. Yeah, so this was his outcome. Now another 11-year-old displaced in a plaster. Okay, so this was the original plaster, and at 4 weeks he came to me. Now this was a 4-week-old injury. He had no pronation. His hand was stiff. He was advised again plating, and parents were obviously agitated, and he was quite an active boy. So this is just a small video for you to see how we do this procedure. Okay, so percutaneous drilling and osteoclasis. So you can see that this is an apex volar injury. Distal fragment is in supination. So at the apex, I just made a small puncture with a stab wound, and then using a drill, you can just make a little small drill puncture on the dorsal callus which is formed. Make sure you are right at the apex. So just a small drill, and then you change the angles. You don't have to come out and go in again. So just weaken the callus a little bit. So we weakened the callus all around after drilling it a little bit, and once it was sufficiently weak, then we did a manual osteoclasis. So we broke that callus, and from that apex volar, that is supinated injury, I pronated and got my reduction, and then I did a casting. I use fiber cast for all my reductions, and as I said, now we are molding. So you can see that especially with late presentations or redisplacements, you will need to hold the pressure for quite some time, as well as you need to create a crooked cast. The cast, if it looks straight, that means you are not molded enough. So even with this kind of molding, I found on Siam that it was not adequately corrected. So then we did a wedging of the cast. So we made a cut in the plaster, and you can see that I have made a cut in the plaster, and now I am checking. See, that wedge has been opened. You can see the triangle there, and in that wedge I put a small wooden block. So once this is done, we put a small spacer. Taral has made a very small jugaad in this. If you don't have a wooden block, you can use the plunger of your syringe, right? So your syringes which are lying around plastic, you cut adequate size, and you put a small wedge there, plastic wedge, like I put this wooden block. And now you see the amount of angulation that is seen in the plaster. So when the patient came out of anesthesia, the parents might think, ye kya kar diya? Hand looks worse than earlier. But I had promised them that I will make your child's hand okay without surgery. Yeah, so they were banking on that, and you have to be very, very confident that you can do that. And believe me, it is possible. So we made that open wedge, and now you look at the X-ray. It looks absolutely well aligned, and that was osteoclasis with wedge casting, which made the child straight, and that was his correction. And in about 4 months' time, it remodeled completely, and now you have no scars, no surgery, and the child is perfectly all right. So this is a very, very well thought out way of treating conservatively all the forearm fractures. And I think we shouldn't get carried away by elastic nails just because they are available. Okay, that is number one. Conservative treatment really works. And there is more and more literature coming out in favor. It's like the whole thing goes in a circle. Okay, very old days it was only that because there were no implant. Now there are implant. Now we are rediscovering conservative as being equally good or better sometimes because of the number of complications that you see. So both bone forearm fractures with 4 years of growth remaining, can a cast achieve good outcome at maturity? And they found that non-operative treatment has good to excellent outcomes in children who have at least 4 years of growth remaining. So as late as 12 years you can still do a close reduction and cast. But when you do a cast, what is not acceptable is missing an early loss of reduction. So it's important, like I said, 8 to 10 days, call your patient back, check that his plaster is well fitting. If it is loose, then change the plaster or wedge it. Second thing, what is not acceptable is missing a tight plaster. Okay, none of your children should end up with a compartment syndrome. Third, always measure the cast index. Look at the apex, where is the fracture and how I can give the best possible cast index. And finally, failure to detect rotational malalignment, right? So rotations are very, very important. So you shouldn't have a blistering and bad skin condition like this. So a little bit about rotational malalignment. Now this child, you can see again, came to me with inability to supinate. So in the neutral position, his hand was remaining mid-prone. And if he tried to supinate, he had to use his shoulder. So he was compensating in the shoulder. And that is not a good result because on a day-to-day basis, you do need rotations. So malrotation, rotational malrotation, non-union, malunion is not acceptable. And in these cases, you may have to break both the bones. And it's not necessary always to put plates. You can use nails, but the rotation has to be corrected. So this child, I had to do an open, I had to do osteotomy of both the bones. The crooked ulna also we made it straight. The radius we corrected the length and angulation and bow. And I put plates. After the deformity correction, he was okay. He got good function, but still there was no full supination. Okay, and then when we saw very closely, you can see that in the intraosseous membrane, the intraosseous membrane had undergone a contracture. In spite of correction, I was not able to stretch out the intraosseous membrane. What I was telling you earlier, tension of the intraosseous membrane is very important. So when we removed the implants, this was on table when I removed the implants. At implant removal, I made sure that I released the intraosseous membrane from one side, and then I could demonstrate a gap between the two. So that allowed that contracture of the intraosseous membrane to relax at time of implant removal, and that then gave him a better function. The gap was released, and finally he got full supination, whatever he wanted, right? And his deformity went away. So he did not have to strain himself for doing this supination action. So please remember rotational malunion in forearm fractures. It is very, very, very important. Coming to distal radius fractures from the forearm fractures, I already spoke in the physeal injury talk about epiphyseal injuries, okay, which can cause trouble, and we'll not talk about it again. But you have these other type of injuries which are distal radius metaphysis with ulna. This is the second common injury. This is metaphyseal, it is not epiphyseal, but you can have it with the ulna, which looks okay on day 1 reduction, but again 2 weeks later this can displace back. That is why that X-ray is important and the cast index is important. But as we have shown, conservative treatment still works. Even if there is bayonet reduction and the child is less than 8, if there is no angular deformity, it will remodel. You just need to counsel the parents. This is the second situation, metadiaphyseal with an intact ulna. So this is single bone fracture, which at 1 week is going to go into an angulation like that. So this is all day-to-day orthopedic practice. You will see, you might have experienced this, that in your own situation. Now, like I said, at 1 week when you see this, promptly you should redo the cast because it's still correctable and it will give you an excellent result. So metaphyseal fractures between 9 and 14 mostly in boys. Okay, biomechanical patterns, already earlier our speaker has told you that torus fractures and compression green stick fractures are stable, but if both cortices are broken they will displace. So you must learn to differentiate between a compression green stick and torus versus bicortical green stick, because bicortical green stick is unstable and needs good cast. And then you can have lower fourth with length maintained or bayonet reduction. Now the bayonet reduction may be dorsal or volar, either ways, depending on how the child fell. Okay, and management depends on the pattern. So torus fracture, just give a splint and they will be okay. Green stick fractures, correction if more than 25-degree angulation is there. Okay, and the question is whether to complete the fracture, break the opposite cortex or not. And there are papers on either side. They say, so many people have said that if you don't break the opposite cortex, the callus is weak and you can have a recurrence of deformity or they will spring back. And then there are people who say that completing the fracture may make it unstable. So you should follow the Evans rotary concept, which I will come to in a minute, and 3-point molding. If you do it well, you don't need to break the opposite cortex. So as I said, we all think about radius ulnar fractures as bending fractures. But from today, I think I should urge you, when you see a forearm fracture, think about it as a twisting injury. Okay? It is not a bending injury, it is a twisting injury, which means somebody has held a forearm and twisted it around. So you get a combination of rotation and angulation. And the minute you correct the rotation, the angulation goes away. Right? So rotation, angulation correction is needed. So look at this. This is an apex volar injury where this is a supination. Okay? And you just have to untwist it for getting reduction. And the second is apex dorsal injury where you have to untwist it to get a correction. And we'll show that to you. So this is an example. You can see this. This is a supination injury. Apex is volar. Distal fragment is supinated. And what do? No traction, no counter traction, no assistant. This is all you need to do. Untwist the injury. It is like a twisting injury and you will get a complete correction and then you cast it. Okay, so please remember the rotary component into a green stick fracture. It is a supination injury, apex is volar, you pronate it for correction. And if it is a pronation injury, apex is dorsal, you supinate it and you will get your correction. Okay, so this is the apex dorsal injury, pronation. So what do you do with pronation? You will supinate it, right? So what you do is, manipulation is to be called derotation under short anesthesia and derotate it into supination and immobilize. That's it. It is as simple as that. Okay, there is no need to struggle, there is no traction, there is no counter traction. Green stick fractures are simply treated by untwisting and correcting the deformity. Unstable fracture lower third radius ulna. The reduction maneuver is as described. You have to exaggerate the deformity, right? This I am sure everybody knows, but again you can see how I am reducing it. No assistant, no traction. Exaggerate the deformity, make it worse, and then with my thumb I am pushing it down and milking the fragment and just gently rotating it. And the minute I get that and it snaps into place, you will get an absolutely perfect reduction. Okay, I'll show you again. I am holding both the fragments in both my hands, then I am exaggerating the deformity. I am bringing the dorsal cortex to the edge and then with my thumb I am just milking it down and pushing it back into position. Once that happens, you will get a perfect reduction. And that reduction has to now be maintained by a cast which is of very good cast index. 0.7 or less. So a fiber cast in this position and that's it. So the Canadian cast index again is very important that you make it in a very well fitting plaster. Surgery is very rarely needed only for severe swellings or unstable injuries Whenever you need to do surgery, make sure you do percutaneous technique. Don't do open reduction, no plating. You can offer a pinning when there is remanipulation done for delayed re-reductions, or for ipsilateral fracture where you have elbow fracture with forearm fracture, then you can do some surgery. And open reduction is only if it is irreducible or open fracture. Again, irreducible is very relative. You can do a percutaneous joysticking and you will get a reduction. And finally, the outliers. So Premalbhai, this is just again 4-year-old child, fallen outstretched hand, treated in a plaster, came to me like this. Any thoughts? Normally a close reduced may malunite and remodel. I showed you examples. He's just a 4-year-old child. Looking at the X-ray, does anything come to mind? Correct. So Premalbhai has seen enough. You need to strip the child and examine for café spots. So neurofibromatosis does not cause only tibial pseudoarthrosis. Sometimes you can have radius ulna and clavicle. Both of these structures can undergo non-union. So he had neurofibromatosis and the surgeon did not realize. So he gave a plaster, which was fortunate, there was no surgery done, but it refused to heal, and ultimately we had to do a fibula grafting and elastic nails, because without which it would not have healed up. Always in your OPD keep a remodeling series. So on IFICS website I have a presentation which I can share where all the fractures which are there, we have kept remodeling series. So when you need to counsel your parents, you can show them, ये ऐसे change होने वाला है over the years. Okay, so you need not worry, and you can counsel them that things will be better as time goes by and nothing to worry about. So lessons to be learnt, I think important lessons are you should identify the pattern, reduce in 1 or 2 attempts and look for an early slip of reduction. Epiphyseal slip should not be manipulated, we know that. You can use percutaneous techniques. You can use remanipulation as a method only in metaphyseal fracture, not in epiphyseal. Non-unions will need, this we have spoken about. So it's all self-evident. That's it. So I'll take a break here and we'll take some questions on forearm fractures if anybody has. Before I will talk a little bit about Monteggia, because that is what was requested. So any questions on radius ulna? Taral, you or Premal want to add anything? Everybody is asleep after food.
Assalamualaikum sir. I am Dr. S.A. Chaudhary Shoykot, Medical Officer, Department of Orthopedics, Noakhali. Thanks sir for your nice presentation. Sir, I have a little one question for you.
Sure.
Sir, you have shown us some reduction techniques. So they may be done under general anesthesia.
Yes.
So can we use hematoma block for such kind of reduction technique?
So you can also do it as something that is called as conscious sedation abroad, which means they give a little ketamine in the OPD itself.
Well,
in casualty. Okay, conscious sedation is where the child doesn't get full anesthesia, there is no tube, but he gets confused and some pain relief, and then so the paper which was from Hawaii, which Taral and Premal quoted, is exactly that. Hawaii has a peripheral center. It's away from USA, it's on an island, and they do not have anesthetist.
Yes sir.
So all lower radius fractures, what did they do? Everybody they gave in the casualty a little sedation and corrected only the angulation to acceptable limits. No attempt was made to close reduce it, no anesthesia was given, and they just straightened it out when there are facilities are not there, and then they gave a plaster. And if you correct the rotation and the angulation, bayonet reduction doesn't matter, all of them heal and all of them remodel. So hematoma block involves putting a syringe into the fracture area. If God forbid some infection happens, I am not very comfortable. Second, it is very difficult to hold a child down to give an injection into the painful area which he has come for. So adult hematoma block is different. Again, don't extrapolate that to a 8-year-old or a 7-year-old child who's jumping because he has pain. So you hold him and then give injection into the fracture, which is a very tough thing to do. You know, you might get assaulted by the parents also. So I am not very comfortable. Yes.
Thank you, sir. For the intrafocal reduction, what instrument do we use? Either hemostat or any other devices?
Yeah. So when you have a delayed presentation in an older child, so we are doing a intrafocal reduction in two situations. One, when you are having a fresh fracture and you are not getting reduction. So you take a 2.5 mm K-wire on a T-handle and just puncture, go into the fracture and lever it out. Now this is to be done under anesthesia in OT after preparation. If it is 3-week-old or if you have given plaster and it has displaced in the plaster and you want to re-reduce it and it's stuck, it's not coming, then again a small puncture and put a periosteum elevator of small size, or the spine, in the spine surgery you have the dura dissectors, blunt. So go dorsally, just peel off the callus a little bit and enter the fracture and then lever it out. So that is broader and flatter and thinner, so it does not damage too much. So artery forceps, yes, but artery forceps can, because of its curve, it's good in supracondylar, but here it can break the dorsal cortex if you put too much force. So I prefer to use a flat instruments like a dura dissector, and in fresh cases you just need a K-wire to just push it across. Any other questions? Yes.
Sir, in case of green stick fracture, it's very difficult to reduce the fracture and keep it in plaster. So what is your idea?
It is difficult to?
Difficult to keep the reduction safe in plaster.
Why do you think so?
Sir, it's become displaced.
That's what I said. So if it becomes displaced after 1 week, the reasons for a plaster displacing is, one, swelling has gone down,
yes,
and in the hand is moving inside the plaster. Once the fingers start moving, initially the patient has pain, so is not moving much. Within a week, when the edema reduces and the flexors start working, it starts angulating. So you will necessarily need to change the plaster in the OPD with a well molded cast. And the second reason is to have a cast index. If your plaster is a gypsona plaster which is very bulky, then you are not able to hold it down, then it is going to displace.
So in case of green stick fractures?
Yes, green stick I am telling you. So green stick fracture, the third reason, as some people have said, is you have not broken the opposite cortex. So they say that the opposite intact cortex has got a springiness. So you have reduced it, but there is a springy motion which allows it to redisplace. So for that, the 3-point molding has to be really good, and you have to follow the rotary concept, not the traction. You untwist it.
Thank you.
So do you have any more pictures of osteoarthrosis of the forearm? Or
I have treated 2 cases. One was operated 9 times or something like that. But same thing, distal 4th radius ulnar pseudoarthrosis. You have to resect like a CPT all the fibrous tissue, all the hematomatous tissue, and then put a bone graft. If the child's hand is big enough, you can use the titanium lock plate. Or then in smaller child, this was 4 years old, so I just passed elastic nails 2 mm over the fibular graft, through the fibular graft, and then gave him plaster for 3 months. And then he uses a brace, and you still have to follow up. You cannot promise union. It's a difficult disease to treat.
What makes you suspicious?
So one is, in any forearm fracture left untreated or conservatively treated, non-union is unknown. Malunion is the common thing. So why would a forearm fracture which has not been opened or infected go into non-union? Second is cafe au lait spots. You strip him. So when you see such a thing which is something atypical, you must examine him thoroughly. Like Premal Bhai said, people would send for an MRI before they open the child's clothes and examine him. At least that's happening in India. Patient will come with 2-3 MRIs And the only thing you do is नहीं कपड़ा उतार के दिखाओ पहले. बोला MRI देखो, नहीं कपड़ा उतारो. सब कैफे वाले स्पॉट्स है दुनिया भर का, तो क्या है उसमें, MRI क्या देखना है? Pardon me? That's what I said, no, pseudarthrosis with tapering content. Why would you get that in a 4-year-old child, non-union, with tapering edges, sclerotic, atrophic? Otherwise, there will be malunion, no? Yes, Tapan. Till edema subsides. Yes, there is one approach. Yes. Absolutely. See, what we are trying to highlight here is that follow the principles, 2 principles. One, open reduction is a bad idea, especially junctional fracture. Second, correct the angulation to acceptable limits. Perfect reduction is also not needed. You need to have acceptable angulation. So for that you know what is acceptable. Third, indication for surgery may be isolated radius fracture, where ulna is intact in older children with muscular forearm, where you don't want encroachment on the interosseous membrane. So how you do it? Apex dorsal, apex volar, complete fracture, radial tuberosity, radial styloid, rotational mass. Just make sure rotation is right and angulation is acceptable and give plaster. You need not reduce it accurately at all. And last thing is counsel. So counsel the parents that I will save you 2 surgeries. Don't look at the X-ray. I will look at the X-ray. That is my job. That is my counseling. This is how I counsel. I tell the parents, you don't want your child to be operated? No. I will give you 100% result. You will not look at the X-ray. That is my job. Because ये टेढ़ा है, इसके पास जाओ. All the problem comes when they start seeing X-rays, going to Google and take second opinion. Premal bhai, anything?
Sir, my children diversion fracture displaced at the age of around 7, 8, 9, 10. Can we do the care fixation under intensive guide? Closed.
But that's what I'm saying. If you are going to do intramedullary fixation, instead of elastic nailing, you can use thick K wires. Lambda wires have been used as long as you are closed. But then don't put the wire half. Your entry point should be correct, your seating point should be correct, and the length should be adequate, and then protect it with a plaster. Open reduction and half-hearted something wire is not a good idea. If you are doing a surgery, do a good surgery. Or then don't go for surgery, do conservative, it will work much better. Okay. Any other question? Yes, sir. Antibiotics. So if I am going to do a close reduction, I don't give any antibiotics. If I am going to do an invasive procedure, then I will give 1 perioperative shot, that's it. That is my protocol. Premal, you have any other antibiotic protocol? For close fracture, for close reduction, you use antibiotic.
Never.
Before 12 years, no, we don't use antibiotic. Unless child has osteomyelitis, you know he has some skin infections. But with that logic, they should eat biryani with antibiotic every day. Because they always have tonsil and everything everywhere. Yeah, I understand. Bacteremia, but that's what I'm saying. Even after the fracture is healed, they still have bacteremia. So they can get pneumonitis, they can get lung infection, skin infection. If I'm doing invasive procedure, I will use. And I guess hygiene levels have improved now. That was an old thing which was maybe relevant at that time, because you had too many osteomyelitis cases. Now we don't see so many. So, because I'll tell you what happens is that antibiotic resistance is a bigger problem. If you just start giving antibiotics for everything, they start getting resistant. So, we don't use too much antibiotic now. Okay, so little bit about Monteggia. How much time do we have? Huh? 20 minutes, enough time. So I'll cover just Monteggia a little bit. We are using elastic nails. Only in adolescent or young adult age group, junctional, I might use a plate. So I have a different talk on indications for plating in children, but simple DCP. I use a simple DCP. No, so again I'll tell you one thing. The problem of adult orthopedic surgeons doing pediatrics is that they are using locking plates for no reason. You don't need to use locking plates. Questions that I need you to get answered are: how early can you treat it? How late can you treat it? Can we leave it alone? Does the radial head relocate spontaneously? Should we pass a radiocapitular K-wire? Do you need to do ligament reconstruction? And what are the problems with surgery? Right? So let's try to answer these questions. So typically you see this child like this, proximal ulnar fracture, radius fracture, and Premal Bhai has shown in his morning talk, unless you draw the lines. Okay, there are two lines that every elbow, anywhere you see an ulnar fracture, no, isolated ulnar fracture, first thing you should do is look at the radial head. Okay, if you see an isolated green stick ulna, first look at radial head. And how do you know if it is in position or not? You draw a transcapitular line, it has to bisect in the center. And you draw the Mubarak's line. So proximal ulna should touch the subcutaneous border of the ulna till the distal part. Okay, so this was conserved and this went on to, now this was plated and typically this went into a cross union. So a very early surgery can cause problems. Okay, something like this. Premal Bhai will show some cases afterwards. And second is, this is a Miss Monteggia again. You can see the anterior angulation and treated with an angulation correction osteotomy, and the radial head has relocated. Okay, so what it means is that if you detect it quickly enough and you correct the angular deformity, then the radial head can spontaneously relocate. You may not need to open the radial head at all, or you may not need to do any kind of additional procedure for the radius. How late? How late? Now this is a 13-year-old boy who had pain on exertion with a deformity and a flexion deformity. This was 5-year duration. Okay, he had a flexion block and he had a 50-degree flexion deformity and he had valgus instability. And these were his X-rays. So now this child, again with proper counseling, he had a CT scan. Why do we need to treat it? Because people would say you have decent range of motion and no pain, why treat? So the reason for treatment is that if you don't treat, you get valgus instability, and valgus instability over the years will cause medial collateral stretch, which cannot be then reconstructed. Second is you can have a block to movements where the radial head is lying, it keeps on abutting against the humerus, and that causes arthritis later and pain. So this is an example of a young adult who came, 24-year-old, left untreated, and you can see he came with pain in the forearm, and the radial head had created a sort of a big hollow here on the lower humerus for itself, and whenever he flexed he used to get pain because of arthritis in that pseudo joint, and he had valgus instability. So now at 24 years of age it is very difficult for me to treat this other than excision of the head, and the valgus instability doesn't go away. So it's better that we treat the missed Monteggia even if it is late, with full knowledge that you may lose a little pronosupination, but you are treating it to prevent valgus instability, which is very important for the stability of the elbow. And what we do is, after a prone, I put them on the lateral side on a bolster and with a posterior approach, expose the ulna and the radiocapitular joint, and then we put a couple of K-wires into the proximal and distal fragment, and I use a small Jess fixator and I distract. So acute distraction on table. So we distract it acutely, and once I get the radial head back, you can see the radial head has come back to the position. Then I will temporarily transfix it with a K-wire, and then looking at how much distraction angulation I need, I put a plate. So we put the plate and fix it and remove the fixator and then remove the pin. So the pin is not left inside. It is temporary to hold it till the plate is fixed, and then you see, then you check rotations, make sure that there is no instability. If after the angular distraction osteotomy you still have instability, there are two reasons that can be there. One, it has been out for too long and the shape of the head is now all deformed. So in certain angles it sits in certain angles it goes out. Okay, so in that situation you may consider resecting part of the overgrown head if you want to, or then what you can do is transfix it for some longer time, for 3 weeks, and then remove the K-wire. Okay, but make sure that there is no motion happening and the wire doesn't break. That is one. Or then if the head is looking decent, you may add an annular ligament reconstruction around the neck. Okay, only after the first two are done. So this is the child, function at 8 weeks, head remained located and his movements improved, instability went away. At 12 weeks he got further motion and he keeps on improving with time and he became much better. So deformity came down to just 10-15 degrees with full flexion, and everything was remodeling quite well. But valgus instability went away and his pain went away. So if you look at literature again, if open reduction for a Miss Monteggia is to be done, Japanese paper which said that age of the patient less than 12 and duration of disease less than 3 years, you will have decent outcome. Okay, so 12 years or low, and within 3 years after injury, good long-term outcome can be expected. More than that, we don't know the outcomes. Okay, but this you will definitely get decent outcomes. And most often you will need a proximal ulnar osteotomy, and most patients did very well in a longer follow-up. Ligament reconstruction did not add value. It was only the angulation distraction as osteotomy which added value, and type 1 gives good results, type 3 gives bad results, and associated ligamentoplasty does not seem to be very useful. So type 3, as I said, is a little tricky. You may need to put a K-wire for longer period of time. I put a plaster, and after 3 weeks through a window I remove that K-wire and continue plaster for 6 weeks. So this is again the same thing. I put a distractor. Now you can see this was type 3 BADO. So the plate is on the medial side. So I am using the forces to pull this into an angulation so that the head sits back in. And that is how that has come back. And the plate placement here is medial because this was a lateral type. When it is anterior, the plate is posterior on the subcutaneous border. And that is how it healed, and she has decent function. Annular ligament reconstruction, you can use the triceps fascia, belt toss, central slip or Lloyd Roberts, and you can hook it around the head. Rarely do we need to do it. Once in a while, yes, we might do it. Again, that makes pronosupination a little more stiff. But that is how you manage a neglected Monteggia. So anything to add, Premal Bhai, Taral, or any questions? Yes, you can get. So sometimes you do get posterior intraosseous palsy, not anterior. Yeah, but you get a pin palsy. I have had patients with acute injury with a pin palsy. Wrist drop and finger motion extension is weak. So posterior intraosseous palsy is known to happen with dislocated radial.
Sometimes you get delayed Monteggia, very rarely. You know that all the acutely radial head is in place. Everything looks good, ulnar fracture.
So those are osteochondral fractures of the head you are talking about?
No, without any fracture, just a delayed dislocation of the radial head. Okay. It can happen, but treatment is same as Miss Monteggia.
Miss Monteggia. No bone graft.
So
acute distraction, no bone graft, it heals.
What fracture is this? Fracture olecranon. Do you want any more imaging? What?
Sanjay, do you want any more imaging on this? Better views, comparative views. Any more information you want? Unless it is tricky, I will not bring it here. Look at the child. Olecranon fracture usually happens very rarely, and whenever it happens, 48% chances is that there is more than one fracture. So whenever you see olecranon fracture, you should always look for another elbow injury or injury in the same leg. Most likely it is other elbow injury is always associated in 50% cases, half the cases of olecranon fracture. And when it happens with trivial injury, you must rule out osteogenesis imperfecta because there is a avulsion fracture here. This was the skeletal survey done. You look at the size of the fragment. I think you're going to see one of the delegate cases which was done little differently, but what we do is we don't use tension band wiring, we use tension band suturing. So once the fracture is united, you can just pull out the wires and the child can be saved from bigger surgeries of removal of KYD. It's just a small stab incision and you bring out the wires. And the same child after some years had a trivial fall and presented to me with comminuted fracture shaft fever. So that corroborates our first diagnosis, because when the child came to me, we did not have access to genetic testing, which is very prevalent in India. You can get it tested for about 15,000 Indian rupees. Okay. On the left side, there's a girl who is having 1 month-old injury. And on the other side, you've got a 9-year-old male who has got a fresh injury. Which one will you fix and which one will you leave it?
More information?
What more information do you want?
Like neurovascular status or something?
Normal. Close injury. She was 1 month old, so now she has a reasonably good range of movement. This boy has acute injury, significant pain. Sorry, sir? So medial is out, so it's not entered. Yeah, that is also. Is this a medial epicondyle or a condyle? Which one is medial condyle? Which one is medial epicondyle? Or both are medial epicondyle or both are medial condyle? 4 options. Which one is condyle? Left side is okay. Left side medial condyle fracture. Raise your hand. Okay. Right side, male 9 years, medial condyle. Raise your hands. Only one. Left side medial epicondyle. Raise your hands. 1, 2. Left side medial epicondyle. Right side medial epicondyle. Raise your hands. Okay, let's see what happened. Let us talk about the right side, in which you all told that this was a medial epicondyle fracture. This was treated with open reduction until the COVID came, was lost to follow-up and presented to my clinic in April of 23. With the flexion deformity, you can see the scar of the open reduction. And now you can see the X-ray. How many you want to continue with the diagnosis? How many you want to revise the diagnosis? Yes, Kausar, what it is now? So there is one dictum is, unless you can prove that there is a medial epicondyle convincingly in a child less than 10 years, unless proven otherwise, the fracture is medial condyle. So this was done by one of my teachers who just opened with a minimal incision and put it in a K-wire. Unfortunately, the patient did not follow up with them because the lockdown came in between, and this child came to me like this. There was a newborn formation anteriorly. These are comparative views. That's the CT scan. This is the movement at presentation. Significant flexion deformity. What was done was open reduction, clearing, and 2 cc screw fixation. And this is about 2 months follow-up. His flexion deformity has significantly improved, and there is a sound union, and he has significantly improved even after that. Compared to that, this girl, at the time of presentation, she had no problem at all.
What was the primary fixation in the previous case?
I don't have any X-ray, but I think it was a K-wire, because if screw was there, patient never went back to the orthopedic surgeon. So I am sure it must have been a K-wire. So what will you do if this girl comes to you with this this type of function, 1 month old, just there's a little bit of swelling which is not much painful? What will you do? Yes, Dr. Tapas, would you accept this or would you go ahead and fix it? Sorry, sir? You want to fix it? Yes? You don't want to?
I don't want to go for any operative procedure.
Any operative procedure? Yes, let us take more opinions. Surgery, no surgery. Fix it. Fix it. So there is a division between fix it and leave it. So let's see what happened. I decided not to fix it. That's a 1 year follow-up. That's an 8 year follow-up. Child has no problem and no scar. Anybody wants to volunteer for this injury? Yes, that last gentleman, yes. Yes, you are looking at me. What injury is that? Yes, please get up.
Sir, I think there is a loose body in the joint.
Where has that loose body come from?
Maybe there is a broken piece of the medial condyle.
Okay, so that is a medial epicondyle incarcerated.
Yes.
You could diagnose with X-ray, but this gentleman had gone to an adult orthopedic surgeon who did not realize, probably would not have seen. So CT scan was done, and when I took this child and gave anesthesia, there was a spontaneous reduction. So now, Kausav, what will you do?
Interarticular fracture, I should go for pinning.
No, it's a medial epicondyle fracture.
But it looks like it has articular extension.
Yeah, it is still displaced, no? It's come out of the joint, but it is still displaced. So there was significant instability. If you look at this, there was significant instability, so we decided to fix it. That's a 2 month follow-up, and that's the function at the removal of implant. So medial epicondyle fractures are not very common. They can be left alone if there are no symptoms, but if there is an incarceration or a demanding elbow like as a cricket player or a tennis player and playing with the same hand, it may be a good idea to do a surgery. But every medial epicondyle does not need to be fixed. Okay?
How you decide which one is to be fixed or not? Because the first time when the patient will come with you,
so you will
medial epicondyle, will you treat it by 21 days or 15 days by class?
Yes. Yes, so if there is an acute medial epicondyle fracture, I'll discuss with the parents what is the inclination of the child. If the child fell while playing a tennis, then I'm more likely to fix it. If the child was just going on a bike, fell and he is not a very sporty person, then I will just treat it conservatively. No, so whenever there is a medial epicondyle plaster, not more than 15 days. So, sir, there is a beautiful paper coming from Taiwan. They studied medial epicondyle non-union with a 40-year follow-up, and they found that they had no functional disability, majority of them. So, if your elbow is not demanding, sorry, sir. Of course, sir. Of course. But sir, even if it's ulnar neuritis, what will you do? Because that's a traumatic injury. It will recover on its own. By fixing the medial epicondyle, you are not going to take care of the nerve. The nerve is not entrapped here. It's injured here with the pull of the fragment. This is an avulsion injury. This is not a direct injury, sir. We must. It grew, sir. It grew slightly. Yes, sir. But when it is outside, it grows. It doesn't make any difference. If it goes when it is attached or nearby the joint, it will hinder the movement. Yes, most of the people would accept that, sir. Otherwise, they would accept a big scar. So, I mean, there's a choice is yours, sir.
One last question regarding choice of implant. You in both cases of condyles, you have chosen the screws. Should you always use
It gives you good compression.
Achha.
Because there are once the child moves, when you move your finger, even then the fragment is going to move because your flexor origin is attached to the medial condyle. So in the morning also I showed the case in which I had fixed with a screw. That is preferable unless the child is really young and you cannot get hold of, then you can use KYs, but at least if we are using KYs, you have to use 2 KYs in a divergent direction. Okay, so fractures around the shoulder, 8-year male, what will you do for this injury? How many for percutaneous pinning, close reduction and percutaneous pinning? Nobody? Open reduction and plating? Open reduction and ligament repair, coracoacromial ligament? How many for conservative? Wonderful. I don't need to present this case. This is 1 week post-op. Still same, conservative? Yes, okay. 3 weeks, 5 weeks, 2 months. This is a sleeve fracture and this is a 6 months follow-up. So there was a paper in JPO after which clavicle fracture surgeries exponentially increased. But I think Taral, me and Sandeep all put together, we have not operated a clavicle fracture. Sandeep, have you operated? So we haven't, none of us have any experience with operating a child with, I have experience of 2 children with congenital pseudoarthrosis of clavicle, but not with acute traumatic injury. Okay. So this is a 10-year-old male, had a road traffic accident. He was knocked over on the other side of the road, had a head injury and could not be operated for 1 week. And this is how the reduction was accepted. He's a 9.5-year-old boy. What will you do? Conservative? Yes. Conservative? Anybody for pinning? Nobody for pinning? Kausar? No? No pinning. Oh, I should not have brought this case also. So after this age, will you follow the child or not follow the child? You should. You would always ask them to follow, but when they are symptomatically alright, they always go away. But this child came back to me after 13 years because his uncle had a similar fracture and he wanted me to treat conservatively. So that's a high expectation. So he was a 52-year-old gentleman, had a similar surgical neck fracture with intra-articular extension, and he wanted me to treat it conservatively. Anyway, that's beyond my age range, but I had an opportunity to take an X-ray and you cannot find out that there's a fracture there. Okay. 8-year-old male coming down with a radial nerve palsy. What should be the treatment? How many for conservative? Conservative. Yes, radial nerve palsy, sir. What will you do, sir? Sir, second row. You had some opinion, sir. Yes, sir. You. Yes. Sorry, I don't hear. Follow? No, you don't want to treat this child with a fracture? So, what will you do? Come forward. Casting?
Yes, sir.
You don't want to explore radial now?
No, sir.
Okay, great. This child was treated like this. Is it acceptable? Kausar, is it acceptable?
Whether there is rotation?
Rotation, suppose there is rotation, what will you do? Say about 20-degree rotation into this.
Still with that, I will accept it.
You will accept this. And what will you tell the parents about radial nerve palsy?
Regarding radial nerve palsy, for regular follow-up, and that will eventually, I think, cure itself. At initial nerve trauma will heal within 6 to 9 months.
Okay, so that's a 1-year follow-up of the same child. Okay, 15-year-old boy, similar injury, no neurovascular deficit, and now the weight of Indian children is really growing. They eat a lot of cheese and other things, and they attend a lot of classes. They don't go to play. It's very competitive there, and this is the injury. What will you do? Operative. How will you fix this, sir? Open reduction. How many for conservative treatment of this? It's a long spiral, sir. He is 15 years height, and if you look at this, his olecranon is fused. There is no growth much left in this child. Yes, 90 kg. So applying a plaster is not easy, and that's why an orthopedic surgeon sent to me because it was a friend's son. Kausar, what will you do here? Yes?
If parent permits, I'll treat it as an adult.
No, no.
But
Parents will tell whatever you want to do.
In this case, even I can use TENS with IFICS to hold the length. I think that will also do.
Surgery, what's an implant? Interfragmentary plate and screw. Anybody for interlocking nail? No. Anybody for TENS? Kausar is for TENS. No. Why you are saying no to Kausar? He has learned good 10 nailing in India. But sir, 90 kg
for the lower
indicated in lower limb, not in upper limb.
Not in upper limb.
Where is the fracture, sir? 10 nailing. There's always element of surprise. I think if you keep it closed with some bracing, I think you can get a good result. Okay. This is the same girl which I showed in the morning, where you said you want to do open reduction. The radial neck, I showed two cases, one which was upside down and another was this girl. Yes, Kausar, what will you do? I think you have written a paper on this.
Yeah, I'll try my technique.
Yeah, your technique is a technique of amalgamation of everybody's technique. But it's okay. So this was, when did you publish?
2022.
Look at the injury.
At that time.
So people used to treat radial neck even before you publish paper.
Yes,
with the technique, all the techniques which you described. So what will you do here? What do you think is the success rate of this significant swelling? And I'll show you somewhat more views. Sorry. So this is, I think I just cut down on few slides. Okay, so the first thing you always do in radial neck fracture is you put a compression bandage. And you look at this, with the 2 or 3 attempts of compression bandage, there is a significant improvement in the angulation. Then you can see on the right side of the slide, I am pushing it with my thumb and pronating, and this is all the maneuvers which are described in the book has been done here, and we have got this thing, and this is the alignment I got and I accepted. What do you think at 1 week X-ray of the right side, should I continue or should I operate her? How many of you feel that we should continue with the plaster, 1 week old X-ray? How many of you think that we should try and do meta-issue nailing and do reduction? Nobody. Yeah, Kausar is the expert on this. Kausar, what will happen to this child?
I think I will still accept this.
And what is the longest follow-up in your series?
I think 7 years.
7 years. So this is 7.5 years follow-up, and this is the follow-up X-ray and a comparative X-ray. You cannot even figure out which side the fracture was, right? And in the morning session, you all said that you will operate that girl. And I'm happy that we have been able to change your opinion from morning to afternoon. So I think food makes everybody wise. You all had nice lunch and everybody is wiser compared to morning. Okay. Now we come to difficult injury and we'll ask the expert, what will you do, Kausar?
Any other views?
No, this is the only view. Okay, we have comparative views. But do you need any more?
The pain and swelling and deformity on the right distal forearm. After doing an X-ray, we got there is a fracture in the distal radius and ulna. Now, in this situation, what we can do?
We should.
So now the floor is open. If you want to comment, just grab a mic. What will you do?
Assalamu alaikum. I have a question. What is the, or how many days old the fracture is?
It's
9-year-old patient.
Patient, the age of the fracture.
Oh, age of the fracture, just after the fracture.
I will go for close reduction under, I usually use hematoma block. And close reduction and plaster.
Close reduction and plaster. Any other thoughts? Okay. And we give exactly, try to reduce the fracture and keep a plaster on it. And after 3 to 4 weeks later, when after removal of the plaster, the scenery is like this, and on the left side there is angular malunion after 4 weeks, and the clinical picture is on the left side. You can see that. Is this okay? What do you think?
So actually the case was like the case presented after 30 days without plaster. It was primarily it was treated by some other surgeon, and now he came to us with that angulation, and now he wants some answer whether that's correctable or we should do something to correct it or not. At this point, video so this is his supination, pronation, wrist movement is full, elbow movement is full. Should we try to intervene or leave it as it is? Now this is the question for the experts.
Lewis. And we exactly did the conservative treatment, as there is a supination, pronation of the forearm movement is okay. No, normal.
We just spoke about this some time ago in my presentation. See, the paper is very clear. Less than 9 years old. Lower fourth radius ulna, sham reduction, which means correct the angulation to acceptable limits. So just go back, let's try to analyze what all happened and what all could have been done better rather than. So go back. Yeah. So this is a very acceptable reduction. Can you see that?
Yes.
There is no angulation, it's just translation beyond it, which is totally acceptable. So why do you think the reduction slipped? So that's what I'm saying.
Lack of follow-up.
No, look at the plaster. It's given a slab on the dorsum. There is no volar plaster at all. So that is why I keep on saying that I don't think a slab is a good idea. Always give a circumferential cast so that you can mold it well. So there is no cast index here. One side is completely open. Child is moving his fingers. When the fingers start moving, this is a bicortical green stick or a complete fracture. It is lying, it is going to displace, no? This is expected. Go ahead. So when he comes with healing, you see it has collapsed dorsally. Now, fortunately his age is less and we know that remodeling is very good. So you don't need to do anything, but all this heartburn of the parents, seeking second opinion, coming to you, third opinion, everything could have been avoided. No? So now there is no question, you leave it alone because he is going to do well.
Absolutely, and presenting at IFICS could have also been avoided. So this is deformities in the direction of the wrist movement, and that
with this type of injury, what should be done? I'm sorry for the quality of the X-ray. This is what is there. What will you do? I'm asking you now because you treated the last case.
So I will try to reduce first.
And if you get a good reduction, what will you do? He's 13 plus. Yes, on the moderator side we have 4 people. What will you do on day 1? Close reduction and Sandeep, will you paint that 13-year-old boy?
So this is the older child, but his volar fragment concerns me because that is probably impinging onto the flexors and the median nerve. So I'll definitely try to reduce this with a percutaneous method if required. Yeah, this is okay. This is fine. No, I'll leave him alone.
So 2 weeks old. Now with this displacement, Sandeep and Taral feels that they should be left alone.
Hello.
Good plaster is required. Next, you can move further now. Pain-free movements. Fracture is not moving under anesthesia, without anesthesia. Of course, you don't need anesthesia in this. Next. There is a significant growth remaining. He says, father says 13 plus 3, but there is a significant growth remaining. You can always check the growth by doing elbow X-ray in adolescent patients. As Taral and Sandeep said, well molded below elbow cast because it was already 2 weeks old. Otherwise, I would have given above elbow cast, right?
Okay.
On removal. Next. This is a removal X-ray. Next. 6 months down the line. Next. Next. 2-year follow-up. Next. Look at the function. There is a significant remodeling happening at the distal end of radius, and you shouldn't worry about it. As Sandeep said, in less than 10 years, I think I will go ahead and extend that age to up to 11 years. You can just keep a bayonet reduction, see to it that does not remain angulated.
Fast growing physis will remodel quite well. The only issue is, my primary concern would have been the sharp edge of the proximal fragment. If I find flexor impingement or volar pain or median nerve symptoms, I would have treated it. So if that is not there, you can definitely accept.
So at least one good thing you have done is that you have not done a K-wiring or open reduction, because Sandeep has shown some disastrous results of open reduction and fixation.
Thank you. So now the second case is 2 days old fracture in a 6 years old lady, a young girl. Proximal ulnar fracture.
Let's wait, Kausar. Let us find out what is the diagnosis here. Who wants to volunteer for the diagnosis?
কেউ একজন মাইক নিয়ে বলেন।
This is the proximal ulnar fracture.
Yes. Yes, you are standing next to the mic, but you know about the case, right? So. Yes. Please come to the mic.
This is the proximal ulnar fracture with radial neck fracture.
Yes.
Maybe it's Monteja fracture dislocation.
But here where is the radial head? Where is the radial head in this X-ray?
Radial head just below the lateral condyle of the.
That means the radial head is in the place, right?
Yeah.
So what has happened here? This is a very interesting injury. It's a very uncommon injury. Yes, Kausar, you want to describe the injury?
Yeah, there's a proximal ulnar fracture with the radial head in place, but the distal end of the radius, that means the neck beyond the radius, is shifted towards medially.
So instead of the radial head, the fracture has happened and the metaphyseal and the distal fragment has dislocated. So this is a Monteja equivalent, right?
Right. So operatively, also we plan to operate this case. Any other thoughts? Anyone want to try that close reduction or close reduction with pinning or metazo technique or any other technique you know? So we also planned for open reduction. We reduced that open, and what we found that there was a 1/6 area of the radial head was attached with some sort of flimsy sheath. I can't tell that is capsule or any other thing. So we decided to keep the head there and reduce the distal end of the radius and fixed it with 2 K wires, and those K wires are placed just beneath the annular, like just where the annular ligament will move, I think. And we then reduced the ulna, proximal ulna, and put 1 K wire through that to fix the ulna. And it was post-operative status of that case.
Yes, Sandeep, your comments on this.
Any comments?
So can you go back to the means the injury X-ray? Okay.
Even the radial head is not exactly at the position where it normally is.
Was the elbow dislocated?
No, sir. The elbow was well in place.
Okay.
And even during perioperatively we checked it through IITV, and it looked like it was in place.
Because there is significant displacement of the radial head with the neck. It's a metaphyseal fracture, and the whole piece is lying somewhere about a centimeter below where it belongs, where it should be.
And it is quite uncommon.
It is extremely unusual. I have not seen such a large displacement. I have seen flipping and other things, which is why I thought whether it was dislocated and then came back, and how did this happen at all?
My question was also that radial head, how did it went there in that position?
Yeah, was it run over? What was the mechanism of injury?
Stroke fall.
Just fall.
Yeah.
Okay. Unusual, very unusual. So you have put everything back. What is your feeling? What is going to happen to this?
I think the baby fall over his...
No. Post-op now, what prognosis?
Suppose this is your friend's son. What will you discuss with your friend and his wife?
In that case, like radial head AVN is quite common. The attachment was not there that much. A flimsy attachment is there, but yet we tried to press it towards the metaphysis so that if possible, if it can get some blood supply from there. And other than that, obviously it can again redislocate. Though we have put 2 K wires.
Go to the next.
We didn't go through that. Just
do you have a post-op X-ray?
Post-op X-ray is this one.
Okay.
Just before discharge, 2 days after OT.
So, like you said, one AVN, second is cross union. You may end up with a proximal radial nerve cross union there, because the injury is roughly at the same level, and when you have such a large devastation proximally, this syndesmotic membrane, the intraosseous membrane also will be ruptured, looking at the amount of displacement. So you can end up with a fusion there.
So what I am planning that we will start early mobilization, whatever amount of mobilization can achieve within first 3 weeks.
See, that is where the catch is, that you will not be able to mobilize this child because both your K wires are impinging on the radial.
How will you start early mobilization? Till the fracture
let us go to the example now. What should probably is a little better thing. Let's go next. It's a similar fracture, but the displacement is not that bad as you see here. The radial head piece has remained, the metaphysis has migrated, and the ulnar fracture is way down here. Same case, this is my case, but it's similar injury. You can classify similarly, but it is not exactly the same injury. Next. We are not able to reduce either radial head. There is a combination at the ulna. Next. Next. Even after establishing the length, the radial head is not falling, radial metaphysis is not falling in line. So the option remains is to do open reduction. Next. But I usually would like to fix it with intramedullary K-wire. This is simple. I am 12-inch K-wire. Next. Open reduction, alignment and fixation. Next. Just click on that. I think there should be a video. Okay. So if you put an intramedullary K-wire, then you will be able to mobilize early. If you put 2 K-wires, till the union you will not be able to remove the K-wire, and with K-wire coming out of your elbow, it is impossible to mobilize that child.
The K-wire, all the K-wires are beneath the skin.
Even then, but the capsule,
So
is going to be the
I
capsule.
repaired the capsule.
Wait for 3 weeks and remove the pins and mobilize. Let primary healing happen, some healing.
Yeah.
For 3 weeks you will not be able to mobilize.
So go next, we'll show you some longer follow-up in this. Next. So that's the orthographic confirmation. Next. Post-op X-ray. Next. 2 months follow-up, everything remote. I think next. Next, it's going for AVN. 4 months down the line, significant flexion deformity. Next. 3-year follow-up. Limitation of forearm rotations, but elbow flexion and extension has come, and as you can see, there is a malformed radial head because of the avascular necrosis, which is inherent of this injury.
So whatever we do, the head will go to AVN eventually.
So your disease or the injury is so bad that outcome is not going to be very perfect. That is the first thing that you will need to counsel.
Yeah.
You have done your best and put things back. Now let them heal, because you know mobilizing it early is not going to give you a better result. AVN is not in your hand. So whereas if you try to mobilize with wire inside and they get infected, loose, or you go into non-union, you will end up with more problems. At least one problem, let it heal. Then you see what next happens.
Can we plan like that after 4 weeks we can start flexion and extension?
Yeah, so after 4 weeks is enough. 4 weeks give a plaster.
Yeah.
4 weeks later you remove the pins also if you want. Some callus will be there. You can give a back slab and start mobilization with protection.
The only advantage of putting nail is that you will be more confident in mobilizing the child, because still the fracture is, the gummy end is being held by your K-wire.
Yeah.
And ulnar K-wire you could have removed, or you may not have removed, whatever it is.
Right.
But fixation of radial neck fragment with intramedullary nail allows you to mobilize earlier than open reduction and 2 K-wires. Of course, it's one more incision, but it's definitely advantageous.
Should I go for the next case, or anyone want to make some comment regarding this case? Okay, going to the next case. Jilani. Dr. Mohammad Nahidul Haq Jilani. So the next case is from Dr. Mohammad Nahidul Haq Jilani.
Welcome to my case. My case summary: 5 years old boy, presently with 6 years old, melanating supracondylar fracture, left humerus, range of movement 25 to 75 degree, and distal neurovascular status intake. This is X-ray. What should our plan, please? Either conservative or operative.
So let's take audience opinion. How many of you feel that this anterior bump is bad and should be excised, or so that the range of movement will come back? How many of you want to do that? How many of you want to leave it alone and feel that this will remodel?
Leave it alone.
How many of you will that, you know, this may remodel, but some future surgery may be required? So that's the audience opinion. So let us see what what was done
Yes,
for
sir.
this patient.
Yes, sir. We should plan or another plan next to observation at 16 week and then 8 months after 1 year.
Did you give some magic medicine to this child?
Yes, sir. Take home message.
The only
Pediatric
magic
school has
medicine is,
extraordinary
avoid the
motoring power,
physiotherapist.
but parent counseling is most important.
I just have one question. I just have one question for you. What did you counsel to this child?
Then if you don't go through any physiotherapy or massage or massage,
No, suppose if I am the parent, I would ask, sir, what are the chances that he will be absolutely normal? Will you confidently say that you will be absolutely normal?
usually what we tell is like that will in some sort of remodeling will be there. Your child will get some like 80, 70 or some percentage of movement, but not 100%. But yet that will be helpful for him. If you want to go through any procedure, we can go that or we can do that later on, not now.
I think it's a very wise way. Which direction it is? What is the functional limitation? Is it any harm in waiting? Because anybody can do surgery at any time, but the correct timing is very, very important. Thank you.
I have one question to you, sir.
So one thing comment I want to make in your case, of course there is an anterior bump, but fortunately child did not have hyperextension. There are some children who will have an anterior bump and a hyperextension which doesn't remodel. And in that case you will have to do bumpectomy and osteotomy, and both can be done together at one sitting.
So I have one question. Like when you excise the bump, that is you get rid of all the anterior cortex, and at the area while you are doing that bumpectomy, and that area only the posterior cortex will support the whole like functioning hand. Like do we need to put anything there to?
So
like,
in this particular child, the posterior cortex was thick, and I immobilized this child for 15 days. Then gradually we mobilized, and as we all know, we did not send this child to therapist. But sometimes, occasionally, you might put a K-wire for a while. I have put a K-wire in a young child for 3 weeks and then mobilized them after that. Sandeep, you want to write something?
Okay, thank you, sir. So the next case is from Dr. Rubaiyat Tashfir.
So my case is Sharif, 10 years old boy, came at emergency with the complaint of fall from a tree 3 hours back, followed by pain and swelling at the left elbow, unable to move his elbow also. On examination, swelling at the left elbow, temperature raised, and movement couldn't be done due to pain. Distal neurovascular status is normal. And this is the clinical picture. So first of all, I want to ask about the diagnosis of this X-ray.
Anyone from the audience? Diagnosis of this patient.
Thank you, sir.
Supracondylar with intercondylar extension. Any investigation you want to do, or this X-ray is sufficient to plan your treatment?
So this is a case of supracondylar fracture with interarticular extension.
So the question, you can hold the mic, is this X-ray sufficient, or do you want to do any more investigation for this patient?
CT scan, sir.
Yeah, maybe it will delineate things better, but even if you don't have, I think you can adequately still treat this this patient.
So
Traction view.
Traction view. Traction view will really help.
Preoperative traction.
Absolutely. So what we do many times is, give this patient, a traction view. It should be done in the department. Or once the patient is anesthetized, then you do traction on table and decide.
So what will be the plan?
So only one thing is that the traction view is a very important tool, and I also described it. The only disadvantage of traction view is that you have already committed certain things, and suppose you do not have proper implants, and when you realize that there is an intra-articular fracture, then you are in soup because child is already anesthetized, right? So I think in such cases, if you get a CT scan done pre-operatively, it's not a bad idea. If you suspect that there's an intra-articular thing, then you will be able to plan better. And even if the child is small, intra-articular fracture is that, like Taral showed, I would keep few screws and small plate ready. I think he showed a beautiful example.
Will you ever try that close, like instruction day will say the fracture fragment is aligning good, then will you put a percutaneous 3.5 mm distal threaded cannulated cancellous screws to the articular surface and 2 KOIs to hold the proximal and distal extremity? 10 years?
10 years, sir.
Yeah, so in 10-year-old child, I would still try that. I'd try a close reduction and fix it with wires. But even if I don't get a close reduction, if I have to open, I will not be very finicky about it. I will open from a posterior approach and then still fix this with K-wire in a 10-year-old child. But if the same child is 15-year-old or 14-year-old or 16-year-old, I would prefer to put plate as that's shown in the morning. Young child, wires are fine. Yeah. You want to show what was done?
So I initially first tried to for the close reduction and under traction and Siam view. I found this is a supracondylar fracture to interarticular extension. So then I go for open reduction. This was the
What
picture.
approach did you use?
The posterior approach, sir.
Okay.
And after open reduction, we reduce the fracture and fixed by K-wire.
Right. All right.
After fixation, this is the Siam view, and this was the post-op X-ray.
Nice.
And after 1.5 years, this is the final picture of this boy.
So if you go back to the X-ray, what I see is you tried and neutralize each fragment.
Yes, sir.
And in a proper manner. So this requires good planning on table, and I think it's a good job done. Sandeep, you.
This has been managed very well. It highlights two things: pre-adolescent and adolescent supracondylus, if there is a high impact injury, can go intra-articular. We shouldn't be under the impression that there is never an intra-articular injury. Secondly, I have had cases with malrotation of the condyles, if their pillars are not reconstructed well. So it was a good thing that if close was not coming, you put the pieces back together and stabilize each of them. There is another way. You could have used an external fixator to stabilize it with small screws, small fragment screws. But K-wires work as very well. Well done, well managed.
So I would differ slightly in this. If I do an open reduction, I'll put a screw in a metaphyseal area where you put a K-wire. I'll put a small neutralizing plate because I want to mobilize them little bit early, because with K-wire it will take at least 4 to 5 weeks with intra-articular fracture. In this case, I'll be able to mobilize, say, within about 2 weeks, because you may not get movements very well. You are very lucky that you got the movements, but it is possible that you may not get a movement. So early mobilization in an intra-articular fracture is not a bad idea to achieve. You can then remove that plate in about 6-8 months time.
The problem in a 10-year-old child is to put a plate. See, if it's a 14 or 15, if you have to go across while IFICS is healed, it's very easy to put a plate and get hold. In this case, Premal, to get even a couple of screws with a plate in distal fragment is not going to be very easy. Intra-articular screw is justified, but putting a plate, I found it very difficult in very young children with a fracture like this.
But intra-articular screw, I think it will be better whether you will put the intra-articular screw except the K-wire.
No, sir, I think the most important thing is an alignment. Fixation can be your choice.
Big fragment. Because it was a big fragment, the forces are adequately neutralized to the wire. Screw was a choice.
Yeah. Because I think Taral in the morning showed a beautiful plate, one screw and plate on the medial side. Yeah, 15-year-old boy.
So one good thing in that this X-ray is when he was operating, he was planning ahead and take the olecranon brochure free, so that he can start mobilizing that early. Like supracondylar fracture, if we have put wire through that, then mobilization may not be possible early, right?
So congratulations, nice case.
Thank you, sir.
Rashmi, thank you for your case. So now it's time for Dr. Sohail Rana. Dr. Sohail Rana.
Assalamu alaikum and good afternoon everybody. I am Dr. Mohammad Sohail Rana presenting my case. 7 years old.
He underwent revision surgery by malleolar screw for broken implant. He reported to me at the age of 14 years. On examination, there was a manus valgus deformity with prominence ulnar head, range of motion, palmar flexion 0 to 60 degree, dorsiflexion was 0 to 50 degree, supination 45 to 50 degree respectively, and there is the LLD 2.1 centimeter approximately. All investigations including CBC and CRP was with normal limits. Radiologically, X-ray, AP and lateral view, radial physis was closed with positive ulnar variance, metaphyseal broadened with distorted articular cartilaginous outline, ulnar head dorsally subluxated with malleolar screw at epiphyseal level with peri-implant osteolysis.
Sir, may I ask you one question, please, sir?
Okay.
Sir, when the radio-ulnar joint is distally screwed, where do you get pronation and supination from?
I'm showing. The malleolar screw was loosened. So possibly this is periarticular osteolysis. This indicates that these are the loosened. And this was operated. What could be the management plan?
Did he have pain?
Yeah.
Was there pain?
Pain. Painful restricted movements with deformity.
What kind of deformity?
Deformity, there is LLD 2.1 centimeter. There is positive ulnar variance with restricted movement.
Sir, I think if there is a screw, the first thing I would have done is just remove the screw and wait for a while. If he improves, then he doesn't need anything. Because we haven't proven sufficiently enough that the positive ulnar variance was the cause of the pain. With the implant inside, the implant could have been the cause of the pain. So, I am a little bit more conservative, so I would explain to the patient that you might require more than one procedure. With a small incision, you can remove the screw, give him some therapy, and then you can...
This patient was operated by me. I did 5 things on the ulnar side and 3 things on the radial side, on the volar aspect. Firstly, I used the middle incision in between the flexor and extensor group. I removed the malleolar screw and extensively curated with mini curate, and the effluent sent for the histopathology as well as culture. But all were negative. Ultimately, I came to know. Then I did the downsizing the ulnar head on the dorsal aspect and made the physis. I kept the physis out and upturn, fixed it with upturn. That is by the Langen-Scale procedure. I permanently epiphysis is done permanently by Langen-Scale procedure. Then I made a cleavage in the radioulnar synostosis introducing and radioulnar synostosis. Then I went on the radial side, made the volar hand with volar rectus approach, and osteotomy was done. And gap was created by gentle manual extraction, later sustained it by the laminar spreader. There was a LLD of approximately 2.1 centimeter, and I used definitive bone graft from the outer table of the ilium and fixed with 6-hole plate. And during the fixation, I found that the ulnar variance has substantially improved, the grotesque appearance of the wrist improved, but after provisional fixation, the improvement of the supination, but pronation, but less improvement of the supination. Then I removed the proximal screw and again rotated the distal fragment almost 20 degrees. The movement was dramatically improved. This is the initial preoperative. This is the post-operative. And that removal, that's before removal of the implant at the OT. This is the OT picture. Yes. After implant removal on 15th post-operative day.
Can I ask you the question? So
Definitely.
My question is, what was your diagnosis and what is the result outcome?
That the patient was then, when I operated the patient, he was a student of class 9 with dominant right hand. He is now past HSC and is the student of philosophy honors student first year. The grotesque appearance of the wrist dramatically improved, LLD improved, 2 centimeter I made it cover by bone graft. And substantial improvement, no pain, and as well as functional cosmetic improvement. Yes, both functional and cosmetic improvement. That I tried to show in X-ray and video.
Nice.
And all the pictures and video of the patient in this presentation have been used with the patient's and his guardian's consent. Thank you.
Thank you very much, sir.
Of pediatric cases, but still I would like to share my one case here. Hopefully you will be able to understand why I am showing this case. See, you don't see? So look at this. Just look at this. This is the boy, and I am showing the arrow mark. What will be what do you see and what will be your diagnosis? Anybody from the back side? Anybody from the back side? What will be your diagnosis? Hey, all our orthopedic surgeons sitting here. Mani, tell me.
Sir, vestibular, sir.
Oh, by looking the X-ray, see the left humerus and the bone. You can see here which one is the red marking here. Pathological fracture. Hey, where is the pointer here? Pointer to
Where is Munir?
This is the exam. Okay, so look at this, just here, and look at the arm from front side and from the back side. So what's the diagnosis? Nobody. Pathological fracture due to what? Due to tumor? Due to SBC?
Maybe bone cyst.
Bone cyst? Infection. Okay. Now you see here. Next, what is your treatment plan? Before that, I would like to show non-union left upper humerus with 3 centimeter LLD and with angulation. Age is 14 years. Now, you please, what will you do? What will you do? This is not the answer.
Sir, some investigations.
Because investigations all are normal. CRP and ES are normal. X-ray I have shown you, and you can just see here, normal. All investigations are normal. What is the diagnosis? I am telling you, this is the non-union I have already shown you. Non-union left upper humerus due to chronic osteomyelitis. He was treated elsewhere by 3 orthopedic surgeons with plaster immobilization.
Sir, এটা তো বলবেন, history তো বলতেই হবে।
না, history আমি বলেছি, এটা just বললাম, this is the next. What you will do? Now what you will do, you just tell me. Destruction osteogenesis by uniaxial fixator, biaxial fixator, or multiaxial fixator. Multiaxial fixator. Multiaxial fixator, what you will do, see. Multiaxial fixator. Next. That's all. Interlocking kurbe. Interlocking infection with compression. Normal, কিন্তু ওখানে তো pathological fracture. It is normal CRP if below 6, above 6, we tell this is the infection. ESR below 30, this is normal. Next, now see what I have done.
Yes.
What I have done. What I have done? See, nothing else. What else? See, look at this. One ring with wires, second ring with wires, and third ring, this is the bar, you see, and small pins, because considering the anatomical situation, I have put only 1 pin here. Then, whenever you put the reserve apparatus, the effect of reserve, you must keep it in your mind that slow and steady traction on a living tissue creates a stress which is metabolically activated both in biosynthetic and polyperiodic pathways. And at the same time, you allow your patient to go for dumbbell in the hand and do the exercises, nothing else. And what happened then?
So, Professor Pari, this middle X-ray, the proximal pin, do you think it is in or out?
Proximal? This is, you're talking about this one? This is the non-union side. Chance, and this is enough. And this is the, you see, how many wires are fixed? This is the non-union side. Which one? Center one. Wait a
Second one, yes.
This is inside the bone.
No.
No. This is inside the bone.
Yes, sir.
You see that?
No, sir.
Look. Outside.
No, this not. This sir. Yes, outside.
This is not outside. This is the view of the X-ray.
No, sir.
No, it cannot be. Then next you see.
Hey, next.
Let us take the opinion of the foreign faculty, whether it is inside or
Now you look. If it is not into the bone, it cannot be like this.
Yes.
See, if it is not in the bone, it cannot be. See, look at this. Now this is the, just you see how remodeled in the bone. Now see Otatika say, if it doesn't goes to the bone, it cannot be. So your comment, expert, please.
So this is good. I think the infection is.
This is the effect of Elizarov. Law of tension and stress. I have done nothing, no compression, no distraction. Just applied the apparatus and you go for exercise all the time. Now you see how it is remodeled. This is before and this is after. Sorry.
Sir, I have one question. In upper limb arm LLD, that much
up to 5 centimeter accepted.
Then if that is accepted and you have done through this, why not go through TENS and IFICS then fix it?
So
the infection is not there.
See, listen. Your question, you can do whatever you like. Even you can go for bone grafting, you can go for plating. But here, since he was treated 3 times by 3 orthopedic surgeons and came with pathological fracture, I know this is the obvious diagnosis of the osteomyelitis. Then I can treat. The best treatment that I know, I learned from Kurgan Center, is the Elizarov with biocompatible thin wires.
I have a question, sir.
No, 5 centimeter accepted in upper limb.
No, where is the difference, sir?
Sir, I have a
5 centimeter?
Yes, 5 centimeter is accepted in the upper limb.
1.7 centimeter for the lower limb, 2 to 3 centimeter for the upper limb. This is the book.
No. Which book reference you tell me?
You show the reference.
Next.
Sir, I have a question. Sir, how can you correct the how can you correct this angulation without any distraction?
No, I have put the hinges. You have not seen the apparatus.
Yes.
See, this is the hinge.
So you correct the angulation by
hinges. This is hinge.
And another question is that is there any fracture in the anatomy, surgical neck of the humerus?
No. Here you can see no. The question arises, the pins is outside. No, this is the view of the X-ray.
Yes, sir. Thank you.
Okay. So my teaching is, my message is, you don't need to go for any kind of curettage or anything. You just put the Elizarov apparatus with only the wires.
Sir, one question please.
Yes.
As you mentioned, the previous surgeon treated conservatively 3 times. 3 surgeons 3 times.
Yes.
What is the cause of infection there? It is a closed wound, adult person. Why there was infection?
40 years old, starting from, came to me at the age of 40, and he was treated for the last 3 years. Then came to me, I have treated like this. And I am treating this kind of patients with the Elizarov apparatus by putting the only biocompatible thin wires. No, after taking no discharge. And if you don't believe, you can go through the journal, American journal, I have the publications of that one. Chronic osteomyelitis in case of children, this is 100% absolutely you can get result in case of children. But adult, you should have to go for removal of the sequestrum and others. But children, you don't need to do anything except applying the apparatus.
Sir,
Okay?
Sir, I have a question. Sir, is there any, upper limb shortening is not the factor, so, and there is multiple option to fix the postoperative non-union or something else.
why we do some kind of device that is more discomfortable for him, because his arms always in abduction position. But why we not intermediate fixation?
What do you mean with discomfortable? I don't know. Cumbersome is that person, the man who doesn't know how to apply. You understand? That is cumbersome. But that's why my message. If you are an orthopedic surgeon, once in a life, you just go to the Kurgan center and visit. Otherwise, you will not be able to understand. This is my message. Thank you. Okay.
So thank you, Dr. Bari. Small comment is that this patient had already, periosteal elevation and newborn formation, and by giving stability, the healing has happened, and it's a good result. We congratulate Dr. Bari.